I'm Sadie Whitaker, the Chief Scientific Officer of SolveME. We've been privileged enough to work with Joe and several others in planning this conference over the past several weeks, so excited to be here and excited to introduce today's panel. We have Cindy Bateman, Sue Levine, Jose Montoya, Peter Rowe, and Dan Peterson in a session moderated by Tony Komaroff. I was joking with Tony before I started this session that I was going to refer to him as the Brad Pitt of the ME/CFS world. I mean that because he's so well known. Sorry, he's cross now. He could almost go without an introduction. But to give you a bit of background, Dr. Komaroff is the Simcox Clifford Rigby Professor of Medicine at Harvard Medical School, a senior physician at Brigham and Women's, and over the past 35 years, he has helped define ME/CFS. He's cared for over 400 patients with the illness and published almost 150 articles and book chapters. He's served on several committees at HHS, NIH, and CDC. Please join me this morning in welcoming Dr. Komaroff and the clinicians panel.
Thank you. The panelists today are some of the most experienced and thoughtful clinicians and clinician investigators studying this illness over the last 20, 30 years. It's a pleasure to be with you. We're going to go down in the order we're seated here, and everyone can either speak from where you are or from the podium. If you have notes on your PowerPoints, they won't project on this monitor here, but they will project on the monitor at the podium. So let me begin by introducing Dr. Cindy Bateman, the Bateman Horn Center in Salt Lake City, who opened the conference, reminding us all, despite the fact we've been bathing in molecules for the last day, that it's about the patients that we're convened here, and we're trying to understand the molecules. So Cindy, you're going to talk. We're each of us going to talk for 10 minutes, and I'm going to give the hook to people who have gone past their time.
So you got a speed read.
Yeah, exactly. Cindy's going to talk about orthostatic intolerance.
So I want to talk about orthostatic intolerance because as clinicians, we try to find the low-hanging fruit. You know, how can we do something right away to help people improve their situation? The orthostatic intolerance syndromes are diagnosable and treatable, and we have actually a lot of evidence and a big literature about how to deal with them. And most of all, improving orthostatic intolerance improves symptoms and function and gives the patient more control. It's important to remember that there are many causes of orthostatic intolerance, and instead of just, that's the first step is to try to understand what might be behind the orthostatic intolerance. But one of the most important things is prolonged bed rest can cause severe orthostatic intolerance. So although it's not that easy to just say, don't spend time in bed, it is an important consideration when coaching people about their activity. And this is illustrated by astronauts who go out to space, and it takes about 3 weeks in weightlessness to develop severe orthostatic intolerance without informing your autonomic nervous system with gravity. There are also many things that we need to remember as clinicians, that many drugs can cause orthostatic intolerance. Prostate drugs, there is a kind of birth control that has drospirenone in it, which can cause orthostatic intolerance, and certainly heart and lung disease, central nervous system problems as well, as what we might consider neurogenic. And in our field, there are many causes of chronic OI that might cause small fiber neuropathy. There are post-viral syndromes and autoimmune processes. Many things can contribute to orthostatic intolerance syndromes. I wanted to make the point with this slide that acute orthostatic intolerance presents very differently than chronic orthostatic intolerance. When patients have an orthostatic intolerance syndrome that's chronic, their body adapts and the symptoms can be very nonspecific, and often patients are not even aware that they have orthostatic intolerance. They present with nausea and chest symptoms and headaches, sleep problems, and rarely, is in my experience, do our patients pass out unless it's very, very severe. So it's helpful to teach the patients about avoiding triggers of orthostatic intolerance, very common sense things, getting overheated, dehydrated, prolonged upright position, and muscle atrophy. So, if they need to keep their core body and their lower body muscles as strong as they can and be aware of medications. And also, it's my experience that patients, all their symptoms worsen when they're in post-exertional malaise. So people may have mild orthostatic intolerance until their illness is flaring, and then the orthostatic intolerance becomes more severe. So my basic interventions for orthostatic intolerance, the first is to increase volume. And you can do that with fluids and sodium. There are medications to do it. The one we use the most frequently is fluticasone. I will say a word about desmopressin. Desmopressin is a drug version of vasopressin, and it's very effective at raising volume and has pressor effects. But you have to monitor very, very carefully because patients can become hyponatremic, especially our patients who are pushing fluids. But I've had very good success with desmopressin in patients who know how to report to me, and they kind of have a standing blood draw. And we all know that IV saline can be helpful for patients, although it's limited by access. So the second major intervention is compression. And this can be done with compression socks, compression clothing, and they are effective. They're as effective as the compression gets. And then we use a drug, midodrine, that's a peripheral alpha agonist that causes constriction of the blood vessels in the arms and legs. This is actually, their own body is doing this. The reaction to orthostatic intolerance, the adrenergic response, causes vasoconstriction. But the way I see this is you can do it with the medications, and then there's less of that adrenergic overdrive that makes people feel anxious and have palpitations and sometimes have trouble sleeping. I use some beta blockade, but it really depends on the patient, and it depends on the results of their orthostatic intolerance testing. And if I do, I usually start with very low dose propranolol. And I use the orthostatic testing to guide treatment. So instead of just having one test, one tilt table test, we do the 10-minute lean test to assess treatment efficacy and to make sure that you're hitting the right targets with your medications. I also wanted to mention that as Dr. Systrom did, I've been using pyridostigmine, and in patients with POTS and ME, this has been an interesting and very effective intervention. I want to show you that if I have time. It's important to improve, I alluded to this, the muscular pump. So there are a few mechanisms that help venous return, and one of them is just the muscle pump. And the heart is no longer pumping venous blood. That pressure is pretty much gone, and there's reduced cardiac output. So I work with patients to develop the strength in their muscles and to remember to use their lower leg muscles as a way of encouraging venous return. And then exercise with orthostatic intolerance should be adapted so exercise can be more effective. And I'm saying exercise in terms of movement at all levels, but patients should exercise in the supine or semi-supine position, reclining position, or in water. And if they have access to water to exercise, that is easier on their joints and their low back. You're either upright in a pressure tank, or you're horizontal. That mitigates the orthostatic intolerance symptoms, and it can be a very effective way to. Patients can do more exercise in water than they can do on land upright. And I wanted to just show you quickly. This is the patient that I mentioned in my initial talk. This is her vital signs on no medications. And you can see supine 98/70, her pulse is 85. And as she stood up for the test, her heart rate on no interventions went up to 168. On Midodrine, propranolol, fluids, and compression. Her baseline heart rate was 52 and went up to 109, and her blood pressure, supine 130, still dropped. She still had a 40-point drop in her blood pressure and a 57 beats per minute rise in her heart rate, but you can see that her heart rate is much more controlled, and this is a better state for her. But I want you to look at her on pyridostigmine. We added 30 milligrams of pyridostigmine 3 times a day. The first number, and these are standing blood pressures and heart rate. The first is before taking any medicines in the morning, and you can see she still has severe POTS in the morning with a low blood pressure and a high heart rate. This is after her first dose of propranolol and pyridostigmine, and the last number is after all 3 doses of propranolol and pyridostigmine. It's in this case, and this is the best case I've seen. I have to say I'm presenting the anomaly, but after 3 doses of her medicines, she doesn't have POTS. Her POTS is completely compensated. And this took her from mostly housebound to going out every day in the car with her mom. So light activity, she was able to go out. And the first thing that happened is she started getting post-exertional malaise. And I've had several patients with severe orthostatic intolerance say, oh man, I forgot what PEM was, because they were so limited by their orthostatic intolerance. So it doesn't eliminate everything about the disease, but you can take away one disabling part or mitigate it or improve it. And I think that's really important. I think my time is probably up, but I was just going to, I think I've got 40 seconds. So these are just some terms under the umbrella of orthostatic intolerance, which is really just a symptom presentation. Patients might get orthostatic hypotension. They may develop a rapid heart rate response. Neurally mediated hypotension, and some of the synonyms are when there's a delayed syncope or orthostatic event. And then the term neurogenic orthostatic hypotension has been resurrected lately because of a drug on the market. And this really just implies that the cause of the orthostatic hypotension is a neurogenic cause. And for those of you who might have to do diagnostic coding, it's interesting because there really is no code, no billing code for POTS or NMH or NOH. The old codes for dysautonomias are there, and you just have to be a little bit creative. Thank you.
Yesterday, Dr. Montoya noted that mast cell activation may play a role in this illness, and Dr. Susan Levine will be talking about that now.
Thank you, Tony. Hope my slides are going to come up. Okay. So mast cell disorder comprises a spectrum of diseases, most notably mastocytosis, systemic mastocytosis, which is a potentially serious neoplastic disease in which mast cells can be found in the skin and in other organs such as the bone marrow. Mastocytosis is relatively rare compared to what I'm going to mainly speak about, which is mast cell activation syndrome. So just briefly, however, mast cells are cells that are mostly located in the tissues. They're found in connective tissue and in mucosal organs such as the gastrointestinal tract and the bronchioles. Activated mast cells, as you can see from this not too well projected slide, produce many mediators. The ones that we hear about the most are histamine, but they also produce cytokines and leukotrienes. Eosinophils are also involved in producing cytokines or molecules that can contribute to mast cell activation disorder. Mastocytosis, once again, is a condition in which mast cells are always secreting histamine and tryptase. Mast cell activation disorders, however, are where mostly they're secreting these mediators when provoked. So that's probably the main distinction. So, like I say, I'm going to talk a little bit about mast cell activation syndrome and its potential role in connection with at least a subgroup of ME/CFS patients. And I've examined the literature on other disorders, which many of you are involved with: autism, Parkinson's disease, Alzheimer's, and some more common disorders like IBS, and even hypertension, in which mast cells may play a role and may shed some light on the pathophysiology in ME/CFS. I'm going to discuss some comorbidities and give a case presentation, provide some laboratory markers, treatment ideas, and just very briefly mention an article from Australia in which a unique mast cell phenotype has been found that expresses a toll-like receptor. Like I said before, mast cells are found mostly in tissues and not so much in the periphery. So it's a challenge to recognize these cells in the peripheral blood. So special techniques need to be developed in order to do this. So we're starting to do that. Like I said, systemic mastocytosis is mostly bone marrow or other organ involvement, and we're not going to focus so much on that here. The major criteria for mast cell activation syndrome involve you have a patient who, and oftentimes, like I said, with a lot of these things, you have to elicit these symptoms from the patient. Very often, they're not going to just tell you that because their main concern is PEM, post-exertional fatigue, the brain fog, sleep disturbances, et cetera. So you're going to have to ask specifically, do you get flushing? Do you experience hives or urticaria? Of course, you're going to ask about GI and neurocognitive complaints. And once again, there are IgE-dependent and independent triggers for release of mast cell mediators. IgE-dependent means your typical allergic triggers like certain foods, pollens, bee venom. IgE-independent triggers relates to things like mast cells, stress response, which involves potentially the HPA axis, and also viral or other types of infections can be independent or non-IgE dependent triggers. There is a validated mast cell questionnaire, which I think is quite helpful, and you can score that. Frequently, patients with some degree of mast cell disorder will have GI complaints such as nausea. Their symptoms oftentimes respond to H1 blockers. They will have chest pain, however, they will have a negative EKG. In some cases, they may have a positive EKG, however. I found something last night. There's a disorder called Curran syndrome, in which there are mast cells that are located around the coronary arteries and can mimic myocardial infarction. But in most cases, that's not the reason for the chest pain. Bladder pain, because mast cells are found in the bladders in some patients with interstitial cystitis. Paresthesias, angioedema or swelling of the lips or tongue, telangiectasias or evidence of bruising in the skin, tinnitus, nasal congestion, and once again, these various cardiac manifestations, tachycardia, asthenia, fatigue, weight loss, memory loss, and I'll go on in a few minutes to outline why that might be. Some laboratory parameters are increased serum tryptase. Now, once again, in mastocytosis, systemic mastocytosis, the serum tryptase will be elevated most or all of the time. In people with mast cell activation disorder, you may need to elicit it with a challenge. So I would urge most practitioners to not dismiss this diagnosis in the face of a negative or low tryptase level. Elevated plasma histamine is obviously a good clue. However, patients should be on a low histamine diet and be off omeprazole, which can cause elevations in histamine. You really have to go after this diagnosis. So if the symptomatology is there, I urge people to continue to look for it in terms of laboratory markers. There's an elevated 24-hour urine methylhistamine, more esoteric and harder to get from your LabCorp Quest diagnostic lab is a 24-hour urine for prostaglandin D2. Elevated IL-6 is kind of an outlier, but response to therapy is a good way to gauge whether or not, at least one of the methods you can gauge whether or not this patient has some component of mast cell disorder. Now, gastroscopy will often show clusters of mast cells. Oftentimes, I've asked patients who've had a recent endoscopy, I've called their gastroenterologist, who's then gotten in touch with the pathologist, who's taken out the frozen section and then stained the gastric mucosa for CD5 positivity. And in a few cases, we've actually found it there. There are some mast cells present in normal gastric mucosa. However, the number of mast cells per high power field in the lamina propria is increased in mast cell involvement of the gut that's clinically significant. Colonoscopy may show similar findings. However, I haven't investigated the colon biopsies. In some cases, you may see splenomegaly, hepatomegaly, osteopenia, osteoporosis. Some other triggers that elicit mast cell activation are fasting, certain histamine-containing foods, sleep deprivation, and upright posture, which is likely linked to some degree, as Cindy talked about, of POTS or cardiac autonomic dysfunction. Now, some comorbidities, again, we're seeing this pattern of all these comorbidities that we see very clearly in our ME patients. The postural orthostatic tachycardia, most commonly the hyperadrenergic variety, which will be talked about in the case I'm going to present briefly. Fibromyalgia, autism, migraine headaches, irritable bowel syndrome. Now, this is very interesting because in a cohort we examined at Columbia, we looked at ME/CFS in patients, the metabolome in those patients with and without IBS. Now, mast cells may be implicated as a causative factor in terms of the symptoms of IBS. And there are neurons in the gut that can interact with these mast cells. And when mast cell mediators are released, they can cause bloating and some of the other symptoms through the sympathetic nervous system of the gut. So there we have a mast cell neuro interaction, a gut neuro interaction. Okay, let me wrap it up quickly. Let me just run through this case presentation, which I think is quite illustrative. So we have a 43-year-old female who had MCAS since age 18. Foods triggered her flushing, rashes, dizziness. She had constipation, postprandial bloating, orthostasis, developed it to age 23, hives, early satiety, dermatographism, vertigo, shortness of breath, insomnia, all are common complaints in ME patients. Her laboratory test showed a positive for hyperadrenergic POTS with an increase in heart rate of greater than 30 beats per minute and a rise in systolic blood pressure. Elevated serum norepinephrine, 24-hour urine, leukotriene, and 11 beta prostaglandins. And sorry, this is another case presentation. Okay, so the other thing that this patient had was EDS. And so she was treated with midodrine, and her POTS improved. She was also treated with H1 and H2 blockers, cromolyn sodium, which is a mast cell stabilizer, montelukast, and low-dose naltrexone, and her SIBO was treated as well. And many of her symptoms resolved. She also received IV gamma. Now, this is max treatment and probably not necessary in the usual patient. But I just thought it was illustrative of a lot of the different comorbidities and how they all occurred in this one patient. I guess I don't have time to explain all the rationales for why these different treatments might work, but improving the permeability of the gut allows reduction in mast cell recruitment, and that improves some of the IBS symptoms, and her GI symptoms improved by treating the SIBO. And the low-dose naltrexone regulated the T lymphocyte production, which also the T regulatory cells, which alter the cytokine, suppress cytokine release, which can also lead to mast cell activation, and block toll receptors, which stimulate mast cell activity. And the high-dose IVIG blocks the IgG receptors as well, which reduce mast cell release. So, okay, so let me wrap it up. Thank you for your attention.
Dr. Jose Montoya will talk about, is there a role for anti-herpes virus therapy in this illness?
Thank you, Tony. So this is one piece, one angle, and I think the key to one of the things in this meeting, thank you, Joe and Vicky again, is that can we arrive to a greater understanding of this disease, of this process that is bigger than the sum of the individual pieces that each group brings here. So this is just one angle. See, I forgot how to move this. Oh. Here, thank you. So we have this coming from various angles. That there is inflammation there. We talk a lot about that, and so the point today is we have at Stanford the experience that we have had patients who have had extremely highly functional normal lives, and that's the story of many of them, and then out of the blue go like this. And in our experience, we have a growing number that is relatively significant of patients that with antiviral therapy, they get back to here where they were before. So we have seen this shift. They go from normal life, really bad for years, and then with anti-herpes therapy, they go back to normal function. And this is Mia Anderson, who has publicly reported that she has the illness. She's now recovered. On the right side is when she did the internship in our place after the therapy and recovering. So can infection or reactivation of latent infection have a role in exacerbations, in the persistence, or the severity? What is the role that these things can have in this process? Can then, more specifically, latent infection be associated with ME/CFS severity? Lily Xu in our group published this report where she found that infectious illness, about 35% of the cases, contribute to exacerbations. So the course of the illness gets worsened with intercurrent infection. So the same idea that a really bad infection somehow triggers or is associated, let's say that, with the onset of ME/CFS, it is also known that having ME/CFS, when there is a new infection process, it worsens significantly the illness. And notice that there are other things that could have been infections in addition to that, like international travel, for example, in 5% of the patients, or domestic travel. So usually travel is not infrequent that ones get exposed to an infectious process. The other key thing is that the pathogen not always announces its presence with symptoms. So our immune system can interact with things that normally will make people very sick. And even they are present, they are not causing symptoms, but they may be still engaging an inflammatory dialogue with the immune system. So these are the 8 herpes viruses that are known to infect humans. You can see the first 3 primarily target the skin, but they hide the ganglia, all of them. And then herpes 4 and 8, they are the oncogenic viruses, and 5, 6, 7, they tend to cause more of the like CMV-like manifestations, syndromes, and then they also play a prominent role in immunocompromised patients. And one of the aspects is that those herpes viruses always stay with the life of the host. So once a human being gets a herpes infection, it stays there for life. Tulia Lieb from our group presented on Wednesday how we found this association that the proportion of positive herpes IgG, or the proportion of patients who are infected with herpes, is statistically significantly higher in the severe group. So the more severe ME/CFS, the higher is the proportion of patients who have herpes infection. You can see that for CMV, for herpes simplex 1 and 2. So that's a manuscript that is under review now. So is there a clinical basis for this? So do we have symptoms that suggest that reactivation of herpes could be doing it? And patients often complain of a flu-like symptoms, viral-like symptoms. There are some patients that say that they experience the ME/CFS as a viral illness that never goes away, the flu that never goes away. Or others tell us that they experience this periodically, that it comes every few weeks or every few months. They have these viral-like symptoms that are totally unexplained. This is not like being in the flu season and experience the flu. This is different. This is like something out of the blue, let's say that comes with certain periodicity. Also, a group of patients who are aware that they are infected with herpes simplex, either oral or genital, or shingles, they will say clearly that once they experience the obvious outbreak with the skin lesions, that their ME/CFS gets worse. The other fascinating thing, and for this disease, all you have to do, at least to get closer to it, is just listen to the patients. They will tell you that they have what is called prodromal symptoms, that it can be like numbness or tingling or some kind of like a nerve pain, and even that doesn't end in having the lesions. When they experience that prodromal symptomatology, their ME/CFS gets worse. The other fascinating thing is talking about Dr. Navio's book 1 in Medicine, that we want to translate to book 2 Medicine, is that there is a well-known syndrome that only experienced clinicians can see, and it's called zoster-Sine herpes. So the patients will have the varicella zoster virus reactivated from the ganglia, and it's attempting to go to the dermatomal area of the skin, but it does not reflect in the obvious skin lesions. But they are having the reactivation of the VCV, and then patients with ME/CFS will say that that's where the whole thing of the exacerbation. Even more fascinating, if you take these patients and give them herpes suppressive therapy, few years later, they are much better. And we have had patients with the herpes, the trigeminal roots, like especially 3 on the mandible, and they have had dental surgery, the temporomandibular joint kind of horrible things, and the pain continues, and it's only when you suppress that for several years they get back to normal life. So that's the clinical part. So are there biological data that support herpes as a factor for ME/CFS exacerbations? The herpes infections stays latent for life. We already stated that. And you don't have to be immunocompromised in the traditional sense to reactivate it. So we do see that in the overtly immunocompromised patients, in the patients that I see with solid organ transplants, bone marrow transplants, cancer, who have all that overt hit in the immune system, they do reactivate these things, and they die, in fact, if you don't act promptly. But also, it is well known that herpes can reactivate without that obvious compromise of the immune system. The other thing is the natural killer cell story in ME/CFS, and our group hopes to contribute a piece for NK cell story in the next few months. But it's well known that NK cells appears to be a key cell that is compromised, and Nancy showed that yesterday. And NKs have been primarily evolved in our immune system to take care of tumors and viruses, and particularly herpes viruses. The other story is Nancy's group about the deoxyuridine triphosphate nucleotide hydrolases, or DUTPases, are higher. Antibodies against this enzyme are higher in ME/CFS patients and Gulf War illness, suggesting that there is more activity of the herpes. And herpes has been associated with severity, like our group established, and we have a small sample randomized double-blind placebo-controlled clinical trial showing that valganciclovir appears to bring an improvement in the symptoms and in the cognitive function of these patients. Herpes simplex can also reactivate in the genital areas of normal people, non-CFS, even they are asymptomatic. We have found a subgroup of patients at Stanford that have the herpes on the buttock area, genital, and that group seems to be with worse symptoms. This is usually postmenopausal women. Herpes can reactivate in the nasal and oral mucosa of healthy adults, even the lesions are not present. And the beautiful, fascinating Morales meningitis, where it can go even to the spinal fluid. So it's basically taking fuel from the fire, what the herpes will do. And I just want to say, remember Dr. Lerner, who was a major proponent of antiviral therapies. And like Maurice Béjart, before he died, says, hope is always victory. Thank you.
Our next speaker is Dr. Peter Rowe of Johns Hopkins, who has introduced sort of a new concept, in my opinion, into the question of the underlying pathologies in this illness. Peter?
Thank you, Tony. So this is something that we've been working on clinically for about 20 years now. We think it's a very important source of examination abnormalities and a very treatable phenomenon in the illness. So neurodynamics refers to the interaction of nerve mechanics or movement and nerve physiology. What got us interested in this was observations in adolescents with the illness who had an increased prevalence of these postural abnormalities that you can see on this slide, where this young man had a lot of thoracic kyphosis, a head-forward posture, and we noticed that doing maneuvers with his legs, like straight leg raise up to about 20 degrees, which ought to be well tolerated by anybody, would provoke his headaches, as would hip flexion. And as we looked at more and more of our patients, we recognized that people who had marked restrictions in range of motion. So healthy individual could get to 60 degrees of straight leg raise without developing stretch, whereas our patients were feeling that 20 degrees was uncomfortable enough to stop raising the leg. They also reported that their symptoms would be reproduced by these examination maneuvers. So we could reproduce classic ME/CFS symptoms by selectively placing tension on the neural tissues. So as an example of this, we brought in two young men who had ME/CFS, and we exposed them to a serial process where we raised the leg 10 degrees, waited 2 minutes, measured heart rate, blood pressure, pulse oximetry. We were at the time thinking that we were aggravating their autonomic nervous system function and that we'd see some circulatory problems. We then lifted the leg another 10 degrees to 20 degrees, then 30, 40, 50, and 60. So it was a 12-minute test, and we were ranking their symptom severity on a 0 to 10 scale. And here's what we found. So the individual came in with a fatigue score in red of about 5.5. As we raised the leg further, the fatigue got worse. lightheadedness in blue got worse, even though we were improving the venous return to his heart by raising his leg in the supine position. He got very cognitively foggy, and by the middle point of the test was unable to answer our questions about symptom severity with any speed, even got visual blurring. At the end of the 12 minutes, the leg was placed down. The two boys that had this test performed then needed about an hour of crackers and Gatorade to get up off the table and feel safe enough to drive home. So neurodynamics, as I mentioned, is this interaction of nerve mechanics and nerve physiology. The basic concept is that as the bones, muscles, and joints and connective tissues move in daily life, they impose forces on the neural tissues. The nerves must elongate, slide, angulate around joints, and then undergo compression. And these mechanical stresses can evoke physiologic responses. The consequences are, first, when the nerve is stretched, you get a protective increase in resting muscle tone. The body is attempting to prevent further stretch of that nerve, but that increases the energy expenditure of that muscle and reduces the person's ease of movement. Neurophysiologically, you can see a reduction in intraneural blood flow, decreased electrical conduction, and sometimes intraneural swelling. There's increased mechanical sensitivity. People have recorded autonomic responses like sweating, altered blood flow to the tissues, and in some experimental situations, you see a release of inflammatory neuropeptides. We followed up our original observations with a cohort study of adolescents where we looked at the prevalence of range of motion. We were looking at 11 different items. I won't go through them, but we generated a range of motion score that went from 0, no restrictions, to 11, which was the maximal number of restrictions. And on the left-hand side of this slide, you see paired patients who are matched by sex and level of joint hypermobility. The CFS patients had a much higher median number on the range of motion score of 5 compared to 2 in the healthy controls. On the right side is the same patients followed for 2 years with repeated measurements. They were exposed to multidisciplinary treatment. Many of them got physical therapy addressing the movement restrictions. And you can see the same range of motion score in the purple. And these same patients at the end of 24 months had shifted down to where you see the distribution in black. So the range of motion score improved in correlation with their improvements in overall health-related quality of life. We then followed this up with a repeat of our initial pilot study, exposing people in a randomized trial to either a real straight leg raise strain or a sham strain. And we measured 5 of the classic ME/CFS symptoms. These were fatigue, body pain, lightheadedness, difficulty concentrating, and headaches. And what this slide shows is the percent of people who had at least a 2-point increase in their symptom intensity. And on the x-axis is the number of symptoms that increased by 2 points. So these are ME/CFS patients compared with the strain compared with the sham. And at each point, you see a big increase in the increased intensity of symptoms if they had the true straight leg raise strain. And by the number of patients who had at least 3 symptoms with a 2-point increase was 47% in the strain arm and 14% in the sham arm. And the other interesting point was that at 24 hours, we also saw an increase in symptoms. 44% versus 18% had 3 symptoms or more, increasing by 2 points. So there's a suggestion that this is capable of reproducing PEM. So our conclusion is that a longitudinal strain that's applied to the nerves and perineural soft tissues of the lower limb is capable of increasing symptom intensity in individuals with the illness for up to 24 hours, consistent with PEM. We would add that this isn't restricted to neural tension on the lower limb. It can occur in the upper limb as well. These findings confirmed our preliminary observations that an increased mechanical sensitivity is a contributor to the provocation of symptoms in the illness. The mechanisms for transduction of that neuromuscular strain into increased symptoms are not known, But I want to emphasize that these are neutral with regard to all of the etiologic hypotheses you've heard at this conference. So, for example, if one believes that neurotropic viruses are the problem, you could get intraneural edema that follows infection, contributing to adverse neural tension. You could get infectious or immune-mediated neuroinflammation. You could get inflammation due to suboptimal intraneural blood flow in those with hypotension and orthostatic intolerance. Stretch is known to activate mast cells, so excessive neural strain can, we think, trigger mast cell activation. And there are other deformative stresses in the nervous system due to ligamentous laxity like one sees in Ehlers-Danlos syndrome or other neuroanatomic problems. The increase in symptoms with the imposition after an otherwise fairly mild mechanical strain like straight leg raise is consistent with the presence of an inflamed, non-compliant, and mechanically sensitized nervous system. So if a simple and relatively brief straight leg raise can provoke symptoms, then prolonged or excessive strain beyond the person's usual range of motion in daily life might be followed by a similar exacerbation. And our clinical experience, we haven't studied this formally, but our general impression over the last 2 decades is that treating these areas of movement restriction using gentle manual forms of physical therapy, not exercise-based, but manual forms, improves the ability of many patients to tolerate the gradual increases in activity that get them back to normal function. My main collaborators in this work have been Rick Violand, a physical therapist in the Baltimore area, and Kevin Fontaine, who's now at UAB. And just wanted to thank the others who were part of this.
Thank you, Dr. Rowe, and also for staying on time. Our last speaker, Dr. Dan Peterson, has chosen a challenging topic, precision medicine and artificial intelligence in the diagnosis and treatment of ME/CFS.
Yes, it's a pleasure to be here and to give a very superficial overview of this and then some examples about might apply for the clinicians. I'm reminded coming back here of 30 years ago when I brought a patient here for diagnosis and potential treatment, and I saw Dr. Stephen Strauss, and he also saw the patient, and left me with the wisdom that science will prevail. And I think that's come true as we've seen in the last 2 days, but it's just a shame it took 30 years. How do I go? Which one do I do here, Don? So I'm just going to give a very superficial overview of artificial intelligence, precision medicine, and then do some case studies that illustrate the utility. So I want to add to the basics about ME/CFS one big negative at the bottom of this list of impressive statistics, that there's a total lack of trained physicians to take care of these patients, and there's additionally lack of access. So where do you start if you're going to apply artificial intelligence to a disease like this? Well, it helps if you have some plausible mechanisms that you can look at in your big data accumulation. And there was a recent article by the recently deceased Jonas Blomberg from Sweden that is a nice review of potential mechanisms, and all of you can refer to that. He presents many, many possible hypothetical mechanisms that could be explored using artificial intelligence. And if we accept that many of the patients have an infectious trigger, that's another way of looking at this in managing big data. So the potential of AI in ME/CFS, well, AI has already been used in diagnosis of liver disease, inflammatory bowel disease, and is now being applied to new definitions of rheumatological disease. Imaging analysis has come up, and I just might do a side comment that there's a new software for 3D MRIs that are going to replace physical exams. It's like a driverless car. You go in for your whole body MRI 3D and you get a diagnosis of splenomegaly or lymphoma or something else based on big data. Disease modeling has been successful in Parkinson's disease and breast cancer. And there are firms out there now that will take your big data and disease model for you, particularly in chronic diseases. It's also useful for subtyping, which I think we've all talked about, drug repurposing, but you need a large N of patients in order to do this. There are examples in other diseases of disease modeling using completely AI in order to get there. There are 3 papers I found about using machine learning and artificial intelligence in chronic fatigue to separate depression from chronic fatigue, neural networks, the kind of thing that Nancy showed, and in other aspects. What about precision medicine in ME/CFS? Well, this is sort of mandated by the economics these times about more precise, and actually there's an NIH initiative for precision medicine, and it's showed great success in treatment of certain cancers, particularly breast cancer. Well, what about CFS? It would be useful, of course, for taking this great array of data that we're all collecting to subset patients. Perhaps we could use it for drug repurposing. And to pause on drug repurposing, spironolactone is an old drug used as a diuretic for congestive heart failure and now recently has been reported to prevent EBV replication. We all know that if a new drug were designed today for chronic fatigue syndrome, it would take 5 to 10 years to get marketed and probably $300 or $400 million. So I think repurposing is probably a better alternative. Here's an algorithm from the UCSF fatigue clinic where I was for 5 years that ends up on the far right with chronic fatigue syndrome. And we're in the process of operationalizing this so it's easier for a primary care doctor to do the differential diagnosis for fatigue, which is, I think, the second most common complaint that people come into a primary care office with. So deep phenotyping is a part of precision medicine. You really have to know the patient and what's going on in order to prescribe precision medicine. Well, we can use it for dissecting subsets and identifying treatment. Longitudinal data is very, very useful, and we accumulated a great deal of this at the 7 sites in the CDC 6-year longitudinal study, including many, many questionnaires, self-assessments, and some biological specimens. Unfortunately, as you all know, one of the problems we have publishing is that we don't have evidence-based literature. But we're finally at the lowest level here, thanks to Lucinda and other collaborators, because we are designing consensus opinions with respect to effective treatments and diagnoses. So we got to move up this ladder eventually, but it's a slow process and it takes large numbers. So one of the approaches that I've been using at Sierra Internal Medicine is to amass all this data and enter it into a database. We're entering it into REDCap, the infectious agents, the immune findings, the functional studies, including ETT, MRIs, et cetera, so that we can make better decisions about these patients. Here's an algorithm for how I decide who gets IVIG, antiviral therapy, amino acids, saline, or even Alpogen under some circumstances. And I always measure something before, during, and after therapy. So I wanted to share, lastly, some case studies so you understand really how this can practically be applied. First case, standard kind of 23-year-old, classic onset. He was forced to do cognitive behavioral therapy and graded exercise, which made him worse. He came to see me as mannose binding globulin deficiency, recurrent infections, was treated with intravenous gamma globulin, and returned to the university. Second case, a patient who had lots of pain, cognitive dysfunction, elevated inflammatory cytokines, absence of IL-10. I treated him with Enbrel, and 3 months later, he had normalization of his cytokines and marked improvement in his cognitive dysfunction. Here's a patient who had intestinal dysbiosis and amino acid deficiencies. Cerebral spinal fluid demonstrated these abnormalities as well and was treated with IV amino acids with an improvement in his cognitive dysfunction, but it's hard to continue that therapy. This was a case that was allegedly post-Lyme disease with severe headaches and cognitive problems as well as fatigue. The spinal fluid was positive for powassan, but not for any of the Lyme-related agents. Powassan is associated with vector-borne disease. Another case of IgM positive, PCR positive parvo with concomitant herpes viruses, as Jose mentioned, who was treated with IVIG and antiviral therapy with a significant improvement in symptoms. Here's the case that came from a laboratory exposure, severe headaches and encephalopathic kind of picture with HHV7 PCR from the peripheral blood as well as the spinal fluid. She was referred to infectious disease for antiviral therapy. Another tool I use, and there are many, many variations on this, is GenoMind. And this I find helpful because it will tell you the profile of the patient and which drugs may work, which ones will have side effects, and which ones you should not use in the realms of pain, sleep, neurostimulants, and just show you an example of how this works. If there's a red check on the far right, you should think twice or 3 times before utilizing that particular antidepressant or analgesic, and it outlines for you the side effects, and they also have experts who can discuss the genetics with you. Pathogens is another interest. I've become very fond of the overnight PCR results that you can get out if you send it out early enough, and I just wanted to show you 4 examples. The first one was a urinary tract infection in a male patient. Turned out to be Pseudomonas. I would have never guessed that. Treated successfully with symptomatic relief. The second case on the right was interesting, a woman who had had a cough for several weeks. Turns out to have whooping cough. There's a resurgence of whooping cough on the West Coast, and I would have never really thought of that probably. The third case is a woman who'd been sick for quite some time, and a lot of times on the upper respiratory PCRs you get adenovirus and rhinovirus, and then you don't need to use an antibiotic. And so this woman had Haemophilus, which was treated. And lastly, GI PCR that in a woman who had several months of diarrhea, which was positive for listeria. And on taking a better history, I found out that she was in the habit of eating unwashed vegetables. Okay. So, well, that's it. So I think there's a tremendous potential in CFS for artificial intelligence as well as precision medicine, and I look forward to instituting it.
Thanks so much. We now have about 20-25 minutes for questions of this clinician panel from the audience. Step up to the microphones, and may I ask you to make the questions concise and to not involve too many questions about personal health.
Hi, my name is Margaret Janklow. I am a pediatrician from Chicago, and this question is for Dr. Montoya. In deciding on antivirals that you use, can you let us know what criteria you use for them, as valacyclovir versus Valcyte, and also what the role of Immunovir is? Immunovir.
Thank you for the question. So I think there is a role to profile the patient's herpes infections, to attempt to obviously determine which ones they have, and a simple IgG should suffice. And then there are a few patients, or a percentage of patients that have the chromosomally integrated herpes 6. So I always get routinely the PCR for, in addition to the serologies, for HSV6. Occasionally, there is the chronic active EBV infection patient, so I get the EBV PCR as well. And then the next step, once you have a good history suggesting that that could be the case, then go first, or I go first with the acyclovir-like drugs, acyclovir, famciclovir, valacyclovir, it appears that in vitro famciclovir has better activity, so I tend to favor famciclovir. And then either if CMV is positive or HSV6 PCR obviously is positive because of the chromosomal integration, then I have a very low threshold to go to ganciclovir, Valcite. And in that situation, one has to be careful with the monitoring and all the side effects. And the other important thing that we didn't talk about is lung. So we have found that the subgroup of patients that dramatically improves, that's so given the antiviral for a year at least, and some require 3 to 5 years. And the Immunovir, I apologize, haven't tried much, but I know that there are some good clinicians and there are some data, I think Tony has more on that it helps. So we try to use it as well in some cases.
Thank you.
Okay, thanks. Good morning. I'm a caregiver, and I wanted to thank the panel and all the researchers here. After studying this disease and trying to treat it for 10 years, I have a better understanding now than I ever have. And I appreciate all your compassion towards patients. My question is, I'm also a professor of management and I'm a team science scholar. What can we do in the short term to improve translational work and, maybe drawing on the knowledge base of management organizations, science of team science? Is there anything that we can do to help you, the researchers, besides going to the Hill and advocating, which we did the other day, and also to help in improving medical education, diffusion of information and knowledge, so that in the short term we can improve the experience of patients in the doctor's office?
Anyone want to take that?
I'm not sure there are any easy answers.
No, there aren't.
I think in terms of exposing physicians and other providers to this illness, it really just takes everyone making an effort. Talking to them, directing them to continuing medical education, constantly, giving them papers and just drawing them in. I know that I hate to open up the floodgates, but if a doctor calls me during the day to discuss about their patient, I'll always take the call, try to give them a little bit of advice or schedule a time to talk to them. There is really a lot out there now, and I think mostly it's just awareness, and I think I see a lot of the more negative attitudes improving and disappearing, at least in the area where I practice.
Jose?
So in addition to the funding is a big factor. This meeting led by the NIH, Cindy Bateman and others are involved in this fantastic initiative called the Clinician Summit, and is supported and led by Mary Dymock in Salt Lake City, where basically decades of clinical wisdom that each clinician who has seen hundreds, if not thousands of patients have accumulated and need to be decanted and need to be distilled and put in some form of a place. So that is being done there, where all the wisdom coming from Cynthia on OIs and Susan's mast cells and Peter's autonomic and all the syndromes that Peter has discovered and Dan and Charles' lab, and those who have some experience with herpes. So that is put together and results in something that is greater than the individual pieces of understanding of each person. So efforts like that needs to be done before we retire or die, because that needs to be somewhere. Yeah.
Thank you.
Over here.
Thank you. So a lot of us patients are taking a lot of supplements, and though I benefited from IVIG, from mast cell meds, from POTS meds, a lot of the work that I've done nutritionally has really helped my recovery, and I'm not hearing any of that from you guys. So I'm curious as to how you're including functional medicine or the metabolomics work, or whether you're including functional medicine and naturopathic doctors at your clinicians' summits who do this work.
Just a comment on what we find in the adolescents. We have been interested in it for a long time in the fact that many of them have upper gastrointestinal discomfort, reflux, and early satiety. And we published a paper about 2 years ago showing that in our cohort of 55 adolescents, 31% turned out to have a non-IgE mediated intolerance of milk protein. And removing milk from the diet as the most common of the allergens was associated with a much a bigger improvement in overall quality of life than we might have expected. It was statistically significant after 6 months. And so these people who are sicker than their non-milk allergic cohort had caught up by 6 months. And removing the dietary factors that can aggravate symptoms helps clarify what's left and what else you need to address.
There was just a study that came out that from Brigham and Women's about food allergies and medications. Most of the drugs that are prescribed have lactose and corn in them, which affect a lot of us.
Yeah, I wanted to say something. I didn't have time in my presentation to talk about luteolin or Neuroprotect, which is a flavonoid that I think is quite helpful and should be done in a clinical trial.
I usually individualize that kind of advice with a patient because it's not one size fits all with diets, and so usually just have a dialogue and have people really empower people to pay attention and investigate things and give them some backup and advice.
Dr. Schuster.
Thank you. This is sort of directed to Dan and as well as everyone else. On the Powassan case, how well was that studied? Was it just molecular or antibodies? And the reason I'm asking is, and this may be the wrong panel, but just because you all see a lot of patients, but the approach is see a lot of patients or see a few patients and study them very intensely to get at the cause. This is just focusing on cause. Sorry to give it to you, but...
No, I'll take that. I mean, I think the deep phenotyping, which includes extensive evaluation, is the most valuable thing for that individual patient. But whether it extrapolates to the group of patients at large is a completely different question, and we need much more data on that.
Yeah, and I agree with that. And the other thing is Powassan is known to be transmitted by a specific tick. So we know that it follows the tick. So the scapularis, the Ixodes scapularis in the East Coast. So I think if a patient is in the West Coast and where the tick is not present that carries Powassan, then Powassan probably will not be indicated. So and Ian Lipkin's group has fascinating work on tracking the presence of the organisms with multiplex PCR assays of what is carrying the tick and where the ticks are distributed. So there is some grounds for not doing Powassan in everybody, but in those where the epidemiology indicates.
No, I just meant in that case, how deep did it go? Including geography, where was the patient from?
Yes, over here.
He was from Manhattan.
Lucky.
Hi, this question is for Dr. Bateman. I'm curious if during your treatment of orthostatic intolerance, if you've found any therapeutic benefit to IV saline being administered to the patients?
IV saline is usually very effective. The problem is that access is risky, right? And eventually there's going to be some problem with access. So each individual case needs to be weighed. I personally kind of reserve it for rescue and maybe periods of time for people because of people with PICC lines eventually get an infection or a clot, et cetera, right, when you have a long-standing chronic problem. But it definitely can be helpful to help kind of bring people back up, or for special events like graduation, walking at graduation.
Dr. Rowe?
Yeah, we had, when we were first doing the tilt tests in the 94, 95 period, we noticed that our patients would have the development of hypotension, and then they'd feel worse for about a week. we very quickly realized we were not going to recruit very many people with CFS to the studies unless we fixed that. And the way we would get them feeling better when they left the lab that morning after crashing was with a liter or two of normal saline. And we've continued to do that as rescue therapy. Some patients who don't respond to any of the orthostatic intolerance medications, we will offer them weekly IV saline, in part thinking that if they can at least get a day or two of decent function, that's improving their muscle strength and tone and their overall function and activity better than not treating them. But as Cindy mentioned, the usual comment that we have about indwelling lines is it's not a matter of if, but when they will develop an infection. So those lines have to be managed with utter fastidiousness.
Thank you.
Yes, over on the left.
Yeah, I have two short questions for Dr. Peterson. Thank you for introducing a very exciting area. My question one is that, because the AI is a big word, right? So could you introduce us briefly what method you're using or you see is going to be using, like whether machine learning or deep learning or shallow learning or this kind of thing? The second short question is related technically. Do you have any like a commercial software you recommend?
I can answer both together because I've only been exploring this for a couple months, and I'm interviewing a number of vendors with respect to the management of the data as well as developing the models. So I'll keep you posted on those answers.
Yes, Professor Geyer.
My question is related to Dr. Levine's talk, and its question is for the audience. Please raise your hand if you know what alpha-gal allergy is. So a handful of people know about alpha-gal, which is the tick-induced adult-onset meat allergy. And it can be elicited, the allergic reactions can be elicited even by gelatin capsules in your meds. It doesn't have to be just the meat. And the symptoms come on within 3 to 6 hours after you eat the meat, and so most people don't even recognize that this allergy, eating the meat, was the cause of their hives that broke out 3 to 6 hours later. So I asked Dr. Levine to just comment on whether this is another test that we should be doing in all ME patients to see how many have IgE anti-alpha-gal.
No, I think that's a good point. I mean, but in terms of the other symptom, the clinical presentation of PEM and just generalized fatigue, that sounds more like an acute episode of, I mean, I think it's a good thing to include, but that I think would be a more isolated type of episode if that person comes in with just that allergy. I'm not sure that alpha-gal allergy is associated with the ME phenotype.
Yeah, I'd actually turn it around. So this is about my wife, who was bitten by a tick in 2014. Before that, she was a mountain hiker. She gradually went downhill over the last 4 or 5 years. Every possible test, including next-gen sequencing, was negative. And the only thing that came up positive was this past November, I came home and she was having a near-fatal anaphylactic reaction. And so then we learned about alpha. I taught hypersensitivity to medical students for 30 years. I had never heard of alpha-gal allergy until it happened to my wife.
Yes.
Given that a lot of these individuals have recurrent herpes virus infections that are neurotropic, and the recent evidence linking that to the development of Alzheimer's disease, Parkinson's disease, have you guys seen in your clinical practice any of these individuals transitioning into mild cognitive impairment and then on to either a movement disorder and or Alzheimer's disease?
I have not seen the Alzheimer part, no. The CFS patients, there is a subgroup that have ill-defined neurological symptoms that are hard to box in one area of known neurological disorders or other, but clearly they have neurological flavor. And in that subgroup, when they respond to the anti-herpes therapy, they seem to gradually get out of that neurological complaint. So but not bona fide Parkinson's, Alzheimer, I have not.
I think also when we develop biobanks in the future, and we stain the brain tissue, we'll know then for sure, I guess, if there's a greater prevalence of that among the ME patients. But I don't think any of us really can tell at this point.
Yes, over here, Sadie.
Tony, you alluded to this at the start of the presentation, and I know, Cindy, you do a lot of work in this area, but what approaches can we take as a community to bring more clinicians into this field?
I think more material online and more material on in those online sources that are most heavily used, like the up-to-date online textbook of medicine, is definitely needed. The information that has been out there until the last year or two is, in my judgment, inaccurate and really not very helpful at all to the practicing physician. So most patients with this illness are probably being seen by generalists, general internists, general pediatricians, and very few of them, I think, are likely to focus their practices largely or exclusively on this illness. But all of them need a lot more help in managing patients because ignorance on their part is doing damage, I think, to the care of a lot of patients. So, and the clinician summit that Jose Montoya mentioned a minute ago that Dr. Bateman has been organizing will hopefully generate a lot more helpful online information. And several of us are working on the online sources like UpToDate to improve the quality of that information as well. But to be honest, there is a real financial problem for generalist physicians to take care of patients with this problem because the fee-for-service reimbursement system does not provide enough support for the time needed on the part of doctors. And so changing the reimbursement system, like working with capitated systems like the Kaiser Permanente system to improve what they do, because the financial issues are reversed in the capitated system. There, it's really imperative for them to do as efficient a job as they can, and they don't have to worry about getting paid on the per minute or per hour basis. And there are initiatives, several people in this audience are working with organized capitated group practices to help them improve their care. But it's not an easy thing to do.
So this is a very challenging problem, and I have to say I've put many long hours in different settings into this question of how do we take this material to practicing physicians. And we had a subcommittee on CIFSAC to try to work on it. And at our nonprofit, the Bateman Horne Center, this is one of our major parts of our mission is to try to create materials and opportunities for physicians to be trained. And really, there's no easy way to do that. So we're trying to do it on multiple fronts. So the clinicians who attended the summit, the Clinician Coalition, we're going to try to create, and we're working on it and have some of it done, but some consensus materials. We hope to set up a website where we can put some of those consensus materials so they're easy to access. Again, though, how do you let doctors know that it's there? We're working on materials that we can give people to distribute. And we also have a listserv that we've started among us that we hope to grow, and so that interested people who want to become more expert physicians in this area can join our listserv and contribute to what it is we're doing. But honestly, it's hard to do things without funding and infrastructure. So one of the reasons I changed my clinic to a nonprofit model was to open up the doors for other funding sources. But to really provide a product, you have to be able to support it financially. And that's the only thing I think that's slowing down our efforts.
Tony, one other comment would be that I think there are a lot of people who are thoughtful and creative in medicine, but they need to have the financial backing to put a career into a complex chronic illness. And I've advocated for something like a Ryan White initiative that was done for HIV for this illness. And I think if the money is there to support academic careers, we're going to have centers at every single university, which is what this population deserves.
There is one handwritten, I'll come to you in just a moment, but before you went to the microphone, one handwritten question was submitted by someone who can't go to the microphone. And it's directed, I think, Dr. Montoya, at you, but others free to answer. With a patient who developed ME/CFS after EBV mononucleosis at age 17, how do you determine if she is a candidate for herpes suppressant treatment?
Because of interest of time, careful history again, that's crucial. But a good candidate, for instance, will be one that persists with the viral-like symptoms. It will be one that perhaps will have very high levels of VCA, IgG, or it will be IgG, EBNA, or EA positive. If they have obvious positivity for PCR, then they will be falling probably in the group of chronic active EBV rather than chronic fatigue syndrome, but it will be the fatigue syndrome associated with the EBV being chronically active. So those patients probably would be good candidates for antiviral therapy.
I think we want to wrap up this session now. Thanks everyone on the panel for a very stimulating session. Thanks to the audience for your questions.
Good morning, everyone. And what I wanted to do now is to introduce the director of the National Institute of Health, Dr. Francis Collins. I'm not sure if people have been following this, but Dr. Collins has really been a champion at NIH for ME/CFS research. A number of years ago, he listened to the community, and he came to the forefront and charged the NIH to really look carefully at what we're doing and to do something much better. And that reinvigorated the Trans-NIH Working Group for ME/CFS, led to a number of the research opportunities that are out there now, a lot of the work that we've been doing with the community and with the scientists and the meeting today. So he is really the force behind this kind of new look at ME/CFS from the NIH standpoint. And Dr. Collins has a number of talents, and we won't go into all of them because he did not bring his guitar today. Yay. But suffice to say that he's a real doctor. He trained at medical school at the University of North Carolina and then did a medical residency and was chosen to be a chief medical resident, which indicates that he really has that skill set and that dedication to patient care. He went on from there to do mostly research, but best well known for the genetics research and the Human Genome Project. But now he's been running the NIH for a number of years and has really changed things, and particularly in the ME/CFS space. So I want to, again, thanks, Dr. Collins, and I'm sure people appreciate your remarks.
Well, thank you, Walter. I'm really glad to be able to be here for at least a few minutes to address this distinguished group at what I think is a real milestone in our efforts to understand the cause and ultimately to find preventions and cures for ME/CFS. And I hope you have heard in that brief introduction from Walter, but I'll tell you myself how deeply committed I am to trying to find answers in this circumstance. I get lots of emails from people who are suffering from this condition. They are heart-wrenching, oftentimes, in terms of the stories of what people are going through and their sense of frustration at the lack of progress. I was involved in a very significant way 10 years ago when it looked as if we might have, for the first time, a really exciting clue, and even a clue that would lead to treatment, namely the suggestion that a retrovirus, XMRV, might in fact be the pathogen involved in many cases. And it was intensely disappointing for everyone involved when that hypothesis ultimately fell apart and left us once again with no answers to understanding why these hundreds of thousands or maybe millions of people are affected with a condition that we understand poorly and have relatively little to offer in the way of real hopes for cure. We've supported then the National Academy of Sciences to conduct that study, which reported in February of 2015 a number of really important recommendations about what needed to be done to try to organize a more effective research focus and a clinical care focus. And responding to that, in October of 2015, we did pull together a much more aggressive plan at NIH, convening this trans-NIH MECFS working group, which has then involved lots of scientists from around the 27 institutes and centers to work together to try to identify the most effective path we might take. And it did allow us then to ratchet up our funding. Not enough, I will agree with you, but certainly in a way that has provided the opportunity to fund the centers that we are now seeing at this meeting, producing a lot of very interesting findings in metabolomics, in immunology, in neuroscience, all of these giving us ideas of what may be going on in this circumstance, but probably also underlying that there are different kinds of MECFS. And if we really want to understand this disorder, just like any other condition, we need to understand the subsets that may have different pathogenesis and therefore be susceptible to different interventions. We are doing that with virtually every other disease right now. I'm on the way to a meeting in New York to talk about how we might do this for schizophrenia and Parkinson's disease, identify subsets that have different kinds of molecular basis. We're doing that with Alzheimer's disease. We do that with diabetes. We do that with heart disease. We need to do that here as well to really understand what is going on with a large number of individuals who have somewhat different presentations, and it seems also potentially different causes once we begin to get that data. So I'm excited about what I see being presented at this meeting. It does seem to me like this really is a milestone where some very bright, capable groups have turned some of the latest technologies to work on this, the single-cell biology efforts to look at the immune system, new and more specific ways to understand metabolomics, which are yielding all kinds of clues that suggest things such as maybe this really is a mitochondrial disorder, which we need to understand even better. I was particularly delighted that as part of this meeting, on Wednesday, there was a meeting of early-stage investigators and mid-career investigators who are just getting into this field, because clearly, if we want to make progress, we need to see that kind of recruitment of new people with new perspectives, new ideas, bring their talents to this circumstance. If history is any guide, it will often be the person who didn't know a lot about the condition, but brought a particular insight to it that results in some kind of a new breakthrough that everybody else can then jump on and move forward. And so getting that new talent into this space is a critical part of NIH's agenda. We have done what we can in terms of the resources, both intramurally and extramurally. Right after I finish speaking, you will hear about the intramural program right here in this building that is aiming to try to understand in a very detailed characterization way, admittedly with a small number of patients because the program is so intense, to see what we could learn by looking at every possible feature of individuals with MECFS. And that will add, I think, also to our body of knowledge. But I come to you today basically to say that we are listening closely to all of this scientific advance and certainly to the cries of help from the community. We do want to see coming out of this some new ideas that could result in further NIH investments. We don't know what they're going to be, but one of the reasons to hold this gathering was to have all in one place the kind of presentations that would help our working group identify what those next opportunities might be. that they can then bring forward ideas about new projects, new kinds of funding, present those to all of the institute directors to see what we could do in this space, and that will have my strong personal support, because I think we are starting to see now the kind of moment that has been needed in ME/CFS, and we don't want to wait a minute if we can see a way to accelerate that progress. This is a very tough problem. You all know that better than I do. And it has obviously not been one where the answers come easily or we would have them already. But with the talent of the scientists now engaged in this, and all of you in this room are part of that community, I am more optimistic than I could have been a couple of years ago that we may ultimately sort this out, find out what the causes are, and figure out the interventions that are so desperately needed. I know that we have, in this particular community at NIH, often not seemed to be as responsive as you would like, and I regret that. But we are a part of a family now. We don't always agree with each other, but it does feel to me like we've come together in a fashion that was needed to address these issues collectively. You should keep pushing us, and I know you will, and we will keep doing what we can to try to find the resources and the talents and the capabilities to move this forward. And, you know, when we pull this kind of a gathering together again, and we will aim to do that on a regular basis, every time I will hope I will see new faces and new ideas and ultimately very exciting kinds of things that will end up in the front pages of the newspapers, that we finally have come to a place where we understand this condition and we have specific interventions that we know can help people who have waited far too long for that. I know you are impatient. I want to tell you I'm impatient too. I wear on my lapel here this little button, which was actually something that got designed back in the dark days of 2013 when we had the government closure for 16 days, where this very building had to be emptied out of anybody who was not essential for patient care. And I had to send all the scientists back in the laboratories on this campus home under threat of being criminally prosecuted if they showed up to do experiments. A very dark 16 days indeed. And I wanted to do something to try to explain to the world why this was a wrong kind of way to try to produce the kind of next insights into medical research that we all needed. I was thinking of black armbands. My wife talked me out of that, said that might be a little extreme. So instead, we decided there had to be some kind of a insignia for what NIH is all about. Being a guitar player, I started with a guitar pick, and then it had to have some kind of statement on there, which is now, I think, caught on in a lot of places. And basically, the statement here is hope at NIH, because we think of the National Institutes of Health also as the National Institutes of Hope. This building you're in, the clinical center, where people come from all over the country, all over the world, because all other options have kind of run out for them, is often called the House of Hope. We want to be that for ME/CFS. And yet hope is not something you just sort of throw out there and then walk out of the room. Hope is something that has expectations for actions. Peter Levi wrote this wonderful description of hope, which I think of every time I talk about that word, that hope in every sphere of life is a privilege that attaches to action. No action, no hope. We want to provide the kind of hope for ME/CFS that is attached to action. That's what this meeting is about. What follows after this meeting is going to be actions as well. Watch us, encourage us, hold us accountable. We want to be part of your family in the best way. Thank you all very much for the chance to say a few words.
So before I make my introductions here, I would like to give a shout out to the folks that are watching us through the webcast. I was told that yesterday there were over 500 people. I don't know what the count is today, but that's really amazing. So hello to all of you, and thank you. So it's my pleasure to introduce today Dr. Brian Wallet, who is working together with Dr. Avi Nath to oversee and implement the intramural clinical study on ME/CFS. Dr. Nath is not able to be with us today, so Brian has kindly agreed to step in and provide this update. So welcome, Dr. Wallet.
Thank you, Vicki. Here we go. I'm Brian Wallet, and I'll be presenting the update on the post-infectious ME/CFS protocol here at NIH. Unfortunately, Dr. Nath was scheduled to give this talk but can't be here. It really has been a privilege to work with Avi, and he has given me the privilege of giving this talk to you today. As most of you know, the focus of our protocol here at NIH is to study post-infectious myalgic encephalomyelitis, chronic fatigue syndrome. The overarching hypothesis to the program is that PI ME/CFS is triggered by an infectious illness, and that results in immune-mediated brain dysfunction. The program is thought to be sort of a multi-phase program, but we're going to focus today only on the first phase and what we're doing these days, which is the conduct of our cross-sectional study to deeply phenotype patients with PI ME/CFS and to better define its pathophysiology. As you can imagine, selecting the proper patients for any study is very important, and perhaps doubly or triply so for PI ME/CFS. And it has been quite the challenge to identify the best population to bring here to NIH. And we have received a great deal of feedback and useful feedback from the community in this regard. What we are doing now to select our patients is we start with looking at medical records to find documentation of a life-changing onset of symptoms that occurs after an acute infectious process. We look to see if people who are participants have fatigue and post-exertional malaise for more than 6 months but less than 5 years. Participants must meet ME/CFS case definitions, such as the Fukuda Canadian Consensus and Institute of Medicine criteria. And perhaps most importantly, after they undergo a full evaluation here at NIH, we must have unanimous agreement from a panel of expert clinical adjudicators who review our cases with us. Some of those folks are in the audience, and we are very grateful for their time that they have put in to adjudicating our cases. Thank you again. While there are 3 different study populations that will be involved in this part of the study, today's talk will only focus on 2 of those, our patients and our healthy volunteers. We often get questions about our recruitment for the study, and today we'll review that for you. To date, we have had 367 total inquiries to participate in the study, and after our initial telephone screening process, we have screened out 186 of those individuals. The reasons for people being screened out at the telephone screen are medical and some are protocol related. Medical exclusions most commonly were related to having a Lyme diagnosis and treatment, which are about 6.5% of individuals calling. Autoimmune disorders were not uncommon, along with head injuries and concussions being related to the onset of symptoms, about 5% each. Cancer and neurologic disorders are also represented, but a whole array of medical disorders represent around 27% of the reasons why people are excluded on telephone calls. In regards to our protocol-specific exclusions, the most overwhelming reason people are excluded are because of the onset of their symptoms being more than 5 years, around 70% of individuals. We have had one individual call whose symptoms had not yet met 6 months. If that person still has symptoms in 6 months, we will rescreen them, but we are very hopeful that we will not get a call back and that they will be better. No infection as a cause of their ME/CFS has excluded around 20% of individuals. Not having a formal fatiguing diagnosis excluded around 7.5% of individuals. Issues with severity, being too sick to travel or too sick to bicycle, take around 10% of the exclusions. Not meeting our age criteria pushed out around 6.5% of individuals. And unwillingness to have procedures or dropping out or not responding to our calls excluded an additional 1% of individuals. Of course, this is not a mutually exclusive list, and about 1/3 of people calling had multiple reasons for exclusion. After our telephone process, I interviewed 181 individuals and reviewed their medical records. And after that process, an additional 130 people were screened out of the protocol. The reasons that people were screened out after interview and medical record review are, again, medical and protocol-specific ones. There were 23 medical exclusions, the most common being a concomitant inflammatory disorder. Head injuries were also not uncommon, as well as severe enough medical sleeping disorders that would confound an ME/CFS diagnosis. Immunodeficiencies, endocrine disorders, cancers, childhood epilepsy, and hepatitis B were more incidental exclusions. There were also some psychological exclusions for participants. 5 participants had medical records of psychosis that excluded them. 2 had severe depression that were beyond what one would call community normals, along with severe PTSD and severe anxiety, excluding those additional people. In terms of the study protocol itself, 100 people were excluded. Most of them were because on medical record review, we found that the onset of their symptoms predated their infection or were more than 5 years prior to their infection. 26 individuals didn't have any record of infection on medical record review. 10 individuals were undergoing persistent treatment for Lyme disease on medical review and were excluded. 9 participants had taken medications that would exclude one from participation. 7 individuals had fatigue prior to their infection within the time limits. And 2 participants had recovered enough that it would be hard to consider them to have moderately severe fatigue still. And so we were unable to include them. There were some participant exclusions as well. 13 individuals dropped out or lost contact with us. Some were unwilling to have their procedures. And there was one case where a physician of the participant was unwilling to support their participation. So after that entire process, to date, we have invited 21 healthy volunteers and 22 ME/CFS patients to come to campus to have their Visit 1 deep phenotyping study. To date, 13 individuals have been adjudicated as PI ME/CFS cases. 4 participants have been adjudicated out, and there are 3 cases still pending adjudication. So what do we do in terms of our medical evaluation here at NIH? Well, we do a lot of different things. We collect pretty detailed histories of people's life experiences, profiles of patient symptoms. We have an independent internal medicine evaluation, neurological evaluation, and rheumatological evaluation for each participant. We review medications and symptoms. But what is really special about working here at NIH is that the world's experts in almost every disorder sit somewhere in this building. And whenever we come across something that we feel needs to be looked at a little more deeply and understood a little bit better, we're able to give them a call and they come and see our patients for us. And this has been a great help to our protocol to both include and exclude and better understand our participants. And I'd like to say a special thanks to all of our NIH specialists that have helped us out with this protocol. In terms of our deep phenotype measurements, this is not a comprehensive list, but I figured I'd put something up that you guys can look at after the talk to see what we're doing. This also gives you a sense of all the different parts of the NIH intramural program that are contributing to what we're studying here. And some of this information is used in our clinical decision making, and some of this will be used as research measures. So to date, 21 healthy volunteers have come to campus to participate in our Visit 1. All of the healthy volunteers had no complaints of fatigue or post-exertional malaise. One participant came to campus and withdrew early. Her family was not comfortable with her continued participation, and she withdrew. 3 participants were excluded based on their medical evaluation by our staff. They thought they were healthy volunteers, and we had to break the bad news that they were not quite as healthy as they had thought. One of the participants had a marked elevation in their white blood cell counts in their cerebrospinal fluid for reasons that are still not 100% clear. One participant had marked demyelination on their brain MRI. On further questioning, we believe that a Epstein-Barr infection 2 decades prior led to sort of diffuse demyelination, which makes them not quite normal and usable in our study. One of our participants, after examination, we felt that they had changes that were really consistent with an early onset dementia that had not quite shown itself fully yet, and also was unusable as a healthy volunteer. So to date, we have 17 what we would call certified healthy volunteers that we can use as comparators. And one of those is actually a sibling to one of our MA-CFS participants, which both gender and almost age matched, which should be very interesting in our exploratory work to look at people that are so genetically similar. We've had 22 ME-CFS participants come to campus to participate in our Visit 1. All of the participants coming met criteria for having substantial fatigue and post-exertional malaise. We had one participant come to campus and withdraw early, deciding that this study wasn't really for that person. And we've had 4 participants that were excluded based on their NIH evaluations. One of the participants was discovered to have a very rare cancer and actually ended up passing away. We had one participant who had an atypical myositis, which we can understand why it was so confounding to all of the physicians that had seen that participant prior. One participant seems to have signs of Parkinsonianism that makes them sort of hard to qualify as a ME-CFS participant. And one of the participants had confounding legal issues that would have made it impossible for impartial adjudication. After the adjudication process, 4 of the participants were thought on review of all the details of their case not to really be post-infectious. To date, we've had 20 cases that have completed all the measurements that would meet the criteria for ME-CFS, and we've had 11 cases that would meet the criteria for PI ME-CFS that we set for ourselves, and 3 pending cases that are undergoing review. So where are we now? The number of ME-CFS and healthy volunteer participants that we have completed is now robust enough for us to start our interim analyses. There are 2 major goals of our interim analyses that we will be seeking here. The first is to screen for measurable and substantial biological differences in our assays between the healthy volunteers and the PI ME-CFS patients. This is for 2 purposes. The first is to help us refine, improve, and expand our NIH study methods for the rest of the cohort going forward. In areas that we are seeing change, we may add assays to expand and better understand what those changes are. We will also be using this to help us start to identify mechanisms that have the potential for therapeutic intervention. This is part of the overarching structure of the program, is to take the information here and to translate it into intervention. And we'll be starting that process with this interim analysis. Also, we will be looking to determine areas where it would be futile to continue searching for biologic differences. Our cohort will never be epidemiologically sized here at NIH, and we'll be able to tell if some of the avenues that we're pursuing are futile to continue. And that will help us reduce the study burden on our participants, help us do less to them, and also optimize how we are using our study resources. I figured that I would provide you 2 examples of our interim analyses. We'll talk a little bit about our mitochondrial function assays using Seahorse that are being performed by our colleagues at the National Institute of Nursing Research, Liray Saligan and Rebecca Feng. And we'll talk a bit about our cerebrospinal fluid flow cytometry analysis done by our colleagues at the National Institute of Neurologic Diseases and Stroke, Steve Jacobson and Yoshimi Akahata. I choose these 2 to talk about today because they highlight some of the real strengths of the intramural program, which is how we collect samples. Both of these are live cell studies, and cell viability is a major issue when it comes to live cell work. And here at the NIH, we're able to measure the time between sample collection and analysis within minutes rather than hours or days or weeks. And I think that's sort of special. Mitochondrial function has been spoken about quite a bit here at the conference. I figured I would show you a picture of mitochondria and a little cartoon that reminds you that oxygen is the coin of the realm when it comes to energy production by mitochondria. For our study, we are using the Seahorse XFP analyzer, which is able to understand oxygen consumption that occurs from mitochondrial use at the cellular level. Usually when people talk about the Seahorse assay, they talk about the cartoon on your left. When you put cells into the plates, you initially get measurements of oxygen consumption rates, and that will give you sort of a sense of the basal respiration of the cells that you are measuring. First step of the seahorse is to inject oligomycin, which blocks complex 5 of the electron transport chain and sort of turns off basic ATP production, helping you get a sense of how much ATP one is making by subtraction and giving you a sense of how much proton leak is occurring. The second step is to inject a compound called FCCP, which decouples the mitochondrial membrane and really sort of pushes the mitochondria into overdrive, into a maximal respiratory state, where you get a real sense of the maximum capacity that a mitochondria can have. After that step, a third step injects antimycin A and rotenone, which block the complex 1 and complex 3 of the electron transport chain, essentially shutting off ATP production and giving a sense of non-mitochondrial respiration. In a webinar that Avi participated in 2017, he showed the cartoon on the right, which showed a single participant and a single healthy volunteer results from the seahorse assay. Here you see that in terms of maximal respiration, that the healthy volunteers seem to be more capable than the participant. Well, we've done a lot more of these seahorse assays now, and it turns out that was a trick, because we're actually seeing that the opposite seems to be true, at least in the small amount of patients that we've done. What you see here is baseline OCAR, or oxygen consumption rate, and you can see that there's a statistically significantly different amount of OCAR at baseline in our patients compared to our healthy volunteers. As you know, there is a second study visit to this where we do an exercise challenge, and we are also doing these seahorse measurements in a serial fashion before and up to 72 hours after an exercise challenge using cardiopulmonary exercise testing. And as a little teaser here, I'm showing you some of the early results from that, where we see that our healthy volunteers, in terms of both spare respiratory capacity and maximum respiration, have sort of upward trends after 24 hours exercise that we're not quite seeing in our participants. While it's very hard to draw any firm conclusions from this data at this point in time, it does suggest that these kinds of measurements are worth continuing pursuing. The second example I will give you today is the immunological profiling we're doing of both peripheral blood and cerebral spinal fluid. Again, this is run by our collaborators Yoshimi Akahata and Steve Jacobson at the viral immunology section. And this is an opportunity to talk a little bit about what we do with the cerebral spinal fluid samples we collect. We collect lumbar punctures here on all our patients during that first week, around 24 milliliters of spinal fluid. And that fluid is immediately separated. The actual cell-free fluid is siphoned off and frozen for further analysis. But the cells are immediately used to do flow cytometry and immunophenotyping. At the same time we are drawing the cerebrospinal fluid, we are also drawing a sample of blood. So we can do a concomitant flow cytometry to understand the blood and CSF similarities and differences, and really understand the immunological makeup of both of the different compartments. In terms of the immunological markers we're able to look at, this sort of gives you an overview sense of what we are looking at. Most of them are cell typing types of markers, looking at different CD cells, differentiating T cells into CD4 and CD8 cells, B cells, NK cells, and what have you. We are also able to do more detailed phenotyping to look at particular receptors on sort of T cells in particular. One of the wonderful parts of this is if we find things on these flow cytometry analyses that lead us in a particular direction, we can change our column and make it more detailed to further investigate any changes that we see in this interim analysis. I'm going to provide you an example of what the flow will look like and some of the unique advantages here of our program. The NINDS program has a long history of studying neuroinflammatory diseases and have a wide range of data across different inflammatory diseases which will allow for comparison. And so in these examples, I'm showing you samples, I have a pointer, blood and CSF, and these are CD8, CD8 ratios in those patients. Our normal healthers or healthy donors are seen here. These are HCLV1 demyelinating patients, HIV patients, MS patients, PML patients, other neuroinflammatory disorders, and here's CSF. And you can get a sense of where CSF patients sort of compare across these measures. Not too different here from healthy volunteers. And that's in the blood, and you see sort of the same here in cerebral spinal fluid. We look again here is looking at NK cell frequency, and we don't see much differences in blood or in the CSF in either of these cell types. However, when we look here at sort of B cell measures, what we see is healthy volunteers and CFS participants are not so different in terms of blood, but you really get a bottoming out here, very few B cells seen in the cerebral spinal fluid of all of our participants. While we do see decreases compared to the other neuroinflammatory disorders from our healthy volunteers, it seems pretty low. And we see this again reflected in our B cell monocyte ratio measure here, but that's because this is a B cell measure. Where this will take us is not 100% clear at this point, but we believe that our interim analysis will help us focus, find these differences, and better focus the study going forward. A lot of people ask us how busy we are, and so I'm providing here sort of an idea of what we have upcoming. A visit 1 takes around 2 weeks per participant. We have 3 healthy volunteers scheduled and 2 ME/CFS volunteers scheduled going forward. Our visit 2s also take around 2 weeks, and we have 2 ME/CFS healthy volunteers returning for their exercise challenges on the schedule. There has been a little bit of changes to the protocol over time. I think we're on Amendment 11 to the protocol now. And we've recently been approved to bring some of our completed participants back to complete measures they didn't have. And so if they didn't come back for a visit 2, we are now allowed to bring them back for functional magnetic resonance imaging, transcranial magnetic stimulation, performing electroencephalography during sleep in the metabolic chamber, and for skin and muscle biopsies. And we've also gotten approval to add these to our initial visit as options, so people who come in, we can get them during their first visits. Of course, we could not do this work without the volunteers from the ME/CFS community, and again, we really still need your volunteerism. We cannot do this work without you. This is our website. Our phone number is listed here, our email address, and our internet. Please get in touch with us, and we're happy to talk to you and look at your medical records. I'd like to take this time to acknowledge the clinical team I work with that has direct patient contact. Angelique Gavin, who's in the audience, is our clinical operations manager. Really a wonderful person. Many of you have probably talked to her on the phone. Anita Jones is our senior research nurse and does a wonderful job with all of our patients to make sure that all their needs are taken care of. Joy Kreskow is our nurse practitioner on loan from the National Institute of Nursing Research, who does a wonderful job and keeps me in line. And the bottom are our IRTAs, our Institutional Research Trainee Awardees. These are people that graduated college and are trying to figure out what comes next. And they've all decided to take 2 years with us to learn about ME/CFS. Benjamin Coleman has finished with us and has gone on to medical school. Ashley Williams is finishing up her 2nd year with us and will also be going on to medical school. And Bryce Calco is going to become our senior IRTA, and we have a new IRTA starting soon named Snigga. And they've been wonderful with our participants. This slide here is to acknowledge the greater role that NIH has here in our protocol, all the different institutes that are contributing personnel and resources to the program. Many, many people are involved in this, and we are grateful for all their participation. I'd like to make a special shout out to the nurses on 7 Southwest North and 5 Southwest North, where our patients are housed, who take wonderful care and make sure that our patients have a good experience here at NIH. Again, I would like to thank our expert adjudicators, Lucinda Bateman, Andy Kogolnik, Anthony Komaroff, Benjamin Nadelson, and Daniel Peterson, for whom we are greatly in debt to provide the time to do these adjudications. And again, extra special thanks to our ME/CFS and healthy volunteers, without whom there would be no program. Thank you so much. to you. Are there any questions?
Thank you, Dr. Walid. Excellent presentation, and for the rigor in the methods recruiting the patients and the implementation of the trial. And as you have corrected for duration, given that patients will have to be with the illness more than 6 months, but less than 5 years, there are published data that suggests that the severity of the illness may impact the results. The more severe patients may have some biological signals greater than the mild patients, and then when you average them, they may affect the comparison with the controls. Is severity being taken into account by a measure, and finally on the analysis of the results?
We collect very detailed information about symptom severity as best as we can, both in subjective and objective ways. And we will look at those data in conjunction with all of the other data we collect. A good example of this is with our exercise stress portion. We already know that the way that people describe how they feel and the way that they answer questionnaires often do not align. And so that we have a qualitative interview coupled with symptom questionnaires, coupled with our biologic measures of function and biology at multiple time points, marching through, so we can look at all those issues, how symptoms and biology interact. It's a particular interest of mine.
Hi there, my name is Lila Rosenthal. I'm a family physician in Colorado, and I treat many patients with ME. And I have a patient who just completed her second visit as part of this group. And I just read her email yesterday to me, kind of summarizing her experience of 2 weeks being here and poked and prodded and everything. And I just wanted to let you know, like, how extraordinary this opportunity is. I'm sure you know this, but I want you to hear it, and I want to say it in front of everyone. Like, as a practitioner, for my patient preparing to come for her second time, we meet monthly, and she would talk about the anxiety and the enthusiasm, and now to have heard it on the other end, like, it's an unbelievable opportunity, and I appreciate it so much more now too, hearing from you about it. So thank you for one.
Thank you very much.
Yeah, and I just hope that you can grow the number of patients you can take on, and I also want to put a plea in to see younger people too. I have an 11-year-old boy who I would just love to get in here, but I know his age is an exclusion criteria. Is it something you're thinking of opening up to a younger group?
Sometimes you start down the road and you find the paths that you need to go to once you start that journey. The idea that pediatric cases and people that have had it for long periods of time, that people with very severe cases all need to be studied and understood, that's pretty clear. But we have to start somewhere, and so we're trying to start with this sort of clean, small cohort to help us, give us guidance, and to help us design those studies in the future.
I wonder if Children's National could take on a similar project. Are you able to replicate with other institutions in the area to encourage that?
We are always open to sharing our methods with other institutions. I know we've been approached by the VA system to talk about taking this approach to the study of Gulf War veterans. And we would be happy to share sort of our view of things with anybody that would be interested in talking to us.
Thank you.
Hi, my name is Becky Torog. I'm a person with ME, and I also am a biochemist. I used to actually do research. I'm just curious about the NK cells. I assume that you're also looking at NK activity, not just at the total number of cells. I know you were just showing a tiny bit of, but
yeah,
I'm just
we
curious.
do functional assays on the NK cells. We'll be doing transcriptomics on the NK cells. We'll numbers and flow. The interest in NK cells makes it impossible for us to ignore, and so I think we even have a collaboration with an Australian group that studies NK cells if we need to go that route.
And you're still looking for healthy volunteers as well?
Yes, we are, and always looking for people who, family members of people with ME/CFS, to match up with their participants and help us, have as many genetically similar individuals. This kind of exploratory small discovery work would really benefit from that.
Hi, Dr. Wallet. I have a question about the exclusionary criteria.
Mm-hmm.
We know that autoimmune thyroid disease, depression, anxiety are very common, and sleep disorders in ME/CFS patients. So from your slides, I'm presuming that if someone has controlled thyroid disease, anxiety, depression, they could be part of the trial.
If we had to exclude the descriptions of depression and anxiety from the study, we would be excluding about 40% of the American population. All right, and so, controlled thyroid disease on medication, controlled mood disorders, those things are all included. We expect that almost in our normal participants. What we're excluding are really sort of more extreme cases. People that have had electron convulsive shock therapy, institutionalization, things like that. We try to keep it pretty dealing with the extremes in our exclusions.
Thank you.
Brian, thank you. I've reported that about 30% of spinal fluids in ME/CFS have abnormal protein or high cell counts. What did you find?
We have not quite found that yet. Again, the interim analysis is starting, and we'll be sending these samples are being sent for analysis called Myalgic, which sort of breaks down into around 1,100 different immune chemicals and proteins to get a sense of sort of the range that we're seeing there.
So you haven't done the regular laboratory cells and protein?
Work we have, and the regular laboratory work has really not shown any differences between the healthy volunteers and the participants, although we have found 2 individuals with oligoclonal bands in their CSF that can't quite be explained.
Thank you.
So hopefully we're all able to grab a cup of coffee and you feel refreshed going into this next session, which is on the microbiome virome. And I'm pleased to introduce our first speaker, Dr. Ian Lipkin from Columbia University. Dr. Lipkin heads up the NIH-funded CRC at Columbia. Welcome.
Thank you. Is this now mic'd? Great, thank you. I'm going to be representing the work done in our center over the past year and a half. It's hard to believe it's been that long. I'll be trying to cover the project with respect to the bacteriome and the virome, which are largely now done in 3 compartments, as you'll see. Metabolomics with respect to methods was covered by Oliver yesterday. I'll talk a little bit about some of the work that we did previously and what we've now done and how those 2 sets of results compare. A new project in epigenetics that is a little fanciful, but I think is very interesting. And I'll close with talking about serology, which I think will be essential if we're going to fully explore the issue of the microbiome, the virome, and the fungome in these disorders. I'm representing a large number of people here. The basic scientists are in red, and in gold we have the clinicians. There's no value judgment there. And then the blue team, right, which is primarily administrative and also to some extent scientific. And as you see, we're distributed across the United States. We've been working together, at least in part, for many years. Francis Collins this morning alluded to the early work on XMRV that we undertook. It seems like a very long time ago now, and I guess it was. But that's what you see here is the XMRV study, which began really in 2010. Then with funding from the Hutchins Family Foundation, there was an initiative known as the Chronic Fatigue Initiative, which led to the collection of a wide range of samples, as well as clinical data, an extension study that was a smaller subset, and then finally, with support from NIAID, some additional sample collection. We've been storing these samples now for several years, and this has many advantages. It allows us in this biobank to examine in cross-sectional and to some extent longitudinal analyses blood, saliva, feces from all of these groups going back over a period of several years. We have normal controls, and we also have some controls where individuals with multiple sclerosis. We don't have blood represented at all of these time points, but as you'll see, time 1 to time 4, which is a span of approximately a year, we tried to subdivide that into quartiles and collected at least saliva and feces. We have 3 major projects. The first one is the microbiology of these disorders. We look at bacteria, viruses, and fungi. We've completed the bacterial and virus works in large part for direct detection. Looking at feces, saliva, and blood, we have not yet done any of the work on yeast, however. We've begun to do metabolomic and transcriptomic studies. I will not be talking about the transcriptomic studies today, though I will talk a little bit about some RNA data. And then we have the third project, which is focused on clinical aspects of translation, where we look at the impact of exercise and orthostatic challenge on the pathophysiology of ME/CFS. And then we have a database study which allows us to refine criteria and look for various insights which we might find by looking at endophenotypes. The exercise work has been largely led by Dana March in our team and Susan Levine, and more recently Jose Montoya and his group at Stanford. The orthostatic work is led by Cindy Bateman. Our emphasis is on rigor and reproducibility, and I think you'll see that because we have these databases and clinical sample sets, we can really adjust the whole issue of reproducibility because, as I say, we have samples that have been collected under different initiatives. I'll start with talking about the bacterial work, largely done by Dora Narzakal and Kinji Yu. And I will be presenting the CFI study, the original work funded by the Hutchins Family Foundation, and what I'm referring to is the CFS study, which is the larger study that is ongoing now. If we look at these sorts of metagenomic analyses, so this is not 16S, it's full genome sequencing, we have in the original CFI study 50 cases and 50 controls. In the CFS study, we've looked at 106 cases and 91 controls, and this Venn diagram illustrates what is common in both of those studies, and this is where we want to focus. So the green arrows indicate those bacteria that are present in higher concentrations in cases, and the ones that are in gray and pointing down are the ones that are lower. So there are a few leads with this fecal study. First is that C. boltii and R. navis are associated with inflammatory bowel disease. Navis is also associated with degradation of mucus that could have an impact on the ability of molecules to transit from the gut into the systemic circulation. In addition, we have a reduction in levels of butyrate producers, and butyrate producers are very important for controlling immune system function and apoptosis. If we predict pathways based on the bacteria that are present, again focusing on the overlap between the original 50-case, 50-control study and the 106-case, 91-control study, you can see that the common bacteria are associated with pyrimidine ribonucleosides and vitamin B6. If we look at those patients who fall into that category that Sue Levine was talking about earlier this morning about irritable bowel syndrome, we find that there are specific differences here. Again, looking at the overlap between the smaller study and the more recent study, 9 bacteria come up and Clostridial species, again, the butyrate producers are reduced in ME/CFS with irritable bowel syndrome. If we look at the saliva, we're finding that there are certain bacterial species that appear to be overrepresented in ME/CFS. They are frequently associated with both oral and GI disease, and we see a reduction in Neisseria and Veillonella species that are more abundant in healthy humans and mice. So there is evidence, at least in this case control study, both of these case control studies where we can look at that. We unfortunately don't have saliva from the earlier CFI study. You'll see that there are things that are predictive of associations with a number of different diseases, suggesting that there may be, in fact, dysbiosis, at least in some of these patients. And here's more evidence of that. We're looking at salivary bacterial metabolic pathways. You see reduced arginine in ME/CFS, and in this instance, we have a prediction based on the bacterial species present that is associated with a metabolomic disturbance that was found by Oliver Fien and his team. Now, viromics, which I've heard a lot about today. Jose gave a wonderful talk, I thought, about herpes viruses and the potential important. Dan Peterson did as well. We held a lot of hope that something was going to jump out of this work. So we've now done fecal, salivary, and PBMC viromics. These are all the different viruses that we've detected. I'm not going to run through them all. I will tell you that if you use purely statistical criteria, there is no one agent that jumps out, whether it's a herpes virus or an adenovirus or any other virus. That's not to say that viruses can't be implicated. It simply means that at the time we sample, the compartments we sample, we are not finding it. And I'll be talking at the end about serology and the ways in which this can give us leads that we can't find this other way. And I know that many of you treat patients with things like valganciclovir and that these have been effective. And I will tell you that in the work we now do, we don't yet have a CLIA lab, but we will have one shortly. When we analyze PBMC and we find evidence of herpes virus infections, whatever type of herpes virus infection it is, many clinicians, based on this research-grade test, have treated these patients with anti-herpes drugs, and they have reported response. This is not a controlled trial, but I would certainly be sympathetic to anybody who had such a finding who wanted to do such. It would make sense, at least biologically. Specifically focusing on herpes viruses, HHV1 through HHV8. Again, nothing jumps out in terms of statistical significance with respect to herpes viruses in saliva, PBMC, or feces. We have not specifically looked at NK cells. That is something that I think we might wish to do in the future, but this is a progress report and gives you some sense of where we are. Now, Oliver Fien talked with you yesterday about the approach that he takes at UC Davis and the West Coast Metabolomic Center to looking at metabolomic profiles, and I'm not going to replicate, and I couldn't replicate what he talked about, but I will show you that it is important to maintain updated databases. So in this slide, you see this original CFI study, which was the first metabolomic work which we did, and more recently the CFS study, done using the same instruments, but because there have been database updates, it can be very difficult to compare the results of these studies. It requires some finesse. But if you look at the end of the day at what came out with the CFI study, what came out of the CFS study, and you focus on those 7 metabolites that were common in the Venn diagram, you can see that they relate to phospholipids and sphingomyelins. These have been reported, obviously, in previous work by Navio, Najzakal, Germain, and so on. We have some new findings that came up in the larger study that I'm going to represent here, and that is the presence of these molecules known as plasmalogens. These are reduced in the brain in Alzheimer's, in Parkinson's, and in MS. Whether this has a relationship to disease or not is something we need to explore. Again, these are findings that we're only just beginning to work up, and we need to understand them in better detail. We're presenting the data slightly differently here, but again, if you compare the CFI study, which is on the left panel, versus the larger CFS study, you can see again that with the larger sample set, we're finding these molecules as known as plasmalogens. And if you have more questions about them, I will defer to Oliver, wherever he is, to talk about them. Now, I was really interested in trying to approach the issue of epigenetics, and we really didn't have any support to do this. So we did a very small pilot just to see it was going to pan out. So what we've done is to look in a very, very simple way at work that we could pursue with the original CFI pilot of 50 cases and 50 controls, and very simply looking at methylation differences, with the reasoning being that if a gene is hypermethylated, it's not going to be expressed to the same levels. And you can see here the locations of the methylation sites relative to the promoters, the methylation differences, and so forth. I'm going to focus only on one that we've had a chance to try to test as a hypothesis with respect to using things like transcriptomics. And what we've done here is to develop real-time PCR assays that allow us to ask questions. And these are all really relating to disorders that are well known to be associated with a variety of intriguing disorders. And what I find interesting about them is that you can study them from a pathway vantage point. And I'll show you that now through a cartoon. So here you have iron, which is free in the circulation. It gets bound to transferrin. It gets bound to a dipheric transferrin receptor. You can see here in this inset the RNA data. So you can see not only do we have a methylation difference, but we also see reduced levels of transcripts expressed from those genes. And although those differences are modest, as you'll see, they're all linked in the same pathway, and the cumulative effects may be important. So the iron binds to the receptor. It's all internalized through a clathrin-coated vesicle. And these are the two in bolded here that are important in terms of the clathrin-coated vesicle. They are then brought into the endosome. There's another protein that's important for the release of those molecules. They are released into the endosome. They're pumped out. They go into the cytoplasm and then wind up going into the mitochondria, as you see here. So we would predict, based on what we've seen with the epigenetic analyses, that there are lesions at the level of 4 of these important factors that are associated with iron transport. And iron, of course, is very important for oxidative metabolism, but it's also important you need to control iron to prevent oxidative damage and so forth. So this is a very early pilot sort of a presentation, and I don't have any more data literally than I'm showing you. But it is interesting, and it shows what can be achieved using these sort of epigenetic approaches. When we failed to find anything that was truly extraordinary using direct methods for detection of infectious agents, which included positive selection for viruses, bacteria, and so on, we began shifting to use of serological arrays. We've recently built a chip in collaboration with Roche Biosciences that allows us to map the entire proteome of all viruses. We've done similar sorts of things with various bacteria. It's a fluorescent assay, and you can see the size of the slides here. They're really fairly straightforward to use. Last year, we reported the implementation of this for a diagnosis of tick-borne diseases. The arrays demonstrate the entire proteome of the relevant genes for Borrelia species, Babesia, Anaplasma, Ehrlichia, Rickettsia, Powassan, Heartland virus, and viruses that we've begun to discover in ticks that are unknown significance, and a total of roughly 170,000 peptides are required. Using this sort of an approach, you can see here that you get a very nice sort of normal distribution as you get binding to these peptides, and that lets you define the critical epitopes for these individual agents. We can use these to not only diagnose the primary consideration of the clinician, which in most of these instances with Lyme disease, but we can also find co-infections, in this case, Babesia and Anaplasma. And it's possible to move these onto even smaller arrays. So those large arrays cost roughly $500 each to use. This is about $5, and it works very, very rapidly, and the readers are cheaper as well. This is an example of how we've been able to move these, and you can see that you get very, very clean data with this pepper-print array. It's even cleaner than what we got with the larger slides. Now I'm going to show you how we've used this more recently to explore a disease that hasn't been explained, that's been a lot in the news, called acute flaccid myelitis. This is an illness that presents with acute flaccid limb weakness. It sort of looks like polio. Magnetic resonance imaging shows changes in the spinal cord. It should span at least 1 or 2 vertebral segments. Almost all of these children have a history of a febrile illness. Most of them have a respiratory disease. Some also have GI disease. This is the epidemiology. We tend to see peaks of this disorder every 2 years. This is not yet understood. We decided to approach this in collaboration with Steve Overstee and Fei Ng at the CDC, initially by using a method called VIRCAP-seq, which is a very sensitive method for viral sequencing in spinal fluid. And with 2 AFM cases, we were able to find and recover nearly complete genomes for enterovirus 71 and enterovirus 30. But the vast majority of the cases that we studied, we were unable to find any nucleic acid. So we designed a serochip to address the same issue by looking for something like a hit-and-run phenomenon. And here we've represented findings for binding with the serochip to enterovirus A, B, C, and D types. And you can see here now that the vast majority, it's actually 87% of the children with a clinical diagnosis of acute flaccid myelitis have antibodies directed against type A and type D enteroviruses in spinal fluid. We found none in children with Kawasaki disease, which is a vasculitis of children. We found none in adults who didn't have AFM. And we found in a very, very small set, roughly 4% of children in Gorakhpur, India, who had a bacterial meningitis and had high titers of these antibodies in spinal fluid, we were able to detect antibodies to enteroviruses, and they were not to A and D enteroviruses. So based on this sort of data, we feel that we have a fairly strong case now for making enteroviruses the leading candidate for causative agent in triggering this disorder known as acute flaccid myelitis. Now, what are the implications of this sort of work for ME/CFS? If there are candidates that we or anybody else finds, you can develop these sorts of arrays and you can use these to test those hypotheses, because the agent may no longer be present, but you may nonetheless have evidence that the agent was responsible for triggering the disease. So the next phase of the microbiology, which is Project 1 in the Center for Solutions for ME/CFS, is to complete the fungal work in the feces and the saliva and the blood, and to pursue serology with these and other candidates. I don't do this work in a vacuum, so this is a list of the various people who have done this work, and I'm acknowledging the funding from a wide range of organizations, including Hutchins, who's unfortunately misspelled. Thank you very much. Are we doing questions or not?
Thank you, Dr. Litkin. Are there any questions?
Jose Montoya.
Ian, great talk. Ian, on the virome, saliva, stool, blood, where you didn't find significant differences, have you analyzed that data by severity?
No.
Thank you for your eloquent answer.
Jose, the viromic data is 24 hours old. I brought it specifically for you.
That's amazing. If you don't mind, add the severity to the analysis. Thank you. Thank you.
On the right.
Thank you. Janet Flint, I'm a patient in North Carolina. We have a lot of ticks, and I'm an outdoor type person with dogs, lots of dogs. So I didn't know if you tested for ehrlichiosis, because I know one of my dogs had a sensitivity to that, and I joked with my vet that maybe I should get tested for that too. Was that in when you were talking about the chip that's been developed to for the different tick-borne diseases or bacteria?
So we have a serological tick that simultaneously addresses Ehrlichia, Anaplasma, Babesia, European and US-based forms of Borrelia, and we hope in the not too distant future Stari as well, once we have a better notion as to what that actually is. We have not run these on any of the samples from the ME/CFS cohort that we have. We developed these with the intramural program here at NIH with Adriana Marquez, primarily to look at people who have known tick-borne exposures who have not responded to treatment.
Okay.
This is certainly, though, going to be part of that, as well as a number of autoantigens and herpes viruses and other things of that nature.
That's great. And is it commercially available? Can I pay for having that test or ask my insurance company?
It is not yet commercially available. We're trying to take it through CLIA certification at New York State. We hope that the viral panels will be available through New York State within the next 6 months.
Oh, that would be great. And I noted that the government agency, I can't think of the name right now, sorry, but they've noted babesia on the blood bank screening. Are you adding more? Are you involved?
I'm not involved with the FDA or blood banking.
Because I know I've had surgeries and I've had blood, packs, and so one of my thoughts was maybe that was one of the causes. So anyway, but if anything else you could do there would be helpful.
Thank you very much. Jeff?
Beautiful talk. Just wondered whether, this may be a short answer as well, have you had a chance to look at CSF in terms of the virome or bacteriome, and if so, what sort of numbers?
So this is a huge problem. So Oliver ran spinal fluid and did a metabolomic study. We didn't have sufficient controls for the reviewers. So we've not published even the metabolomic part. We would love to do that. And actually, we've done a lot of spinal fluids now all over the world. And it's remarkable. The sensitivity of VIR-CAP-seq and BAC-CAP-seq is equivalent to real-time PCR because you're covering the entire virome, the entire bacteriome, and it's positive selection. So if you want to do some of that, I was talking with Avi about that earlier, we would love to do that with you.
Yeah, we have a collection as well of CSF.
Perfect, thanks.
Yeah.
On-stage collaborations. All right, thank you, Dr. Lippman.
Thank you. Yeah.
Our next speaker is Dr. Julia O from Jackson Laboratory. Dr. O is leading one of the projects funded by the NIH CRC. So please join me in welcoming Julia to the stage. This is where I tell a joke.
Right. Okay. All right, so thanks very much for the invitation to be here, and hopefully I can keep this in a projectable location. So you've had a wonderful introduction from Ian in terms of the role of the microbes that live in our bodies, so the bacteria, the fungi, the viruses. And I would say that among probably many of you here, I really grew up with much more of a germ theory background, thinking that these microbes were in fact disease-causing organisms that we had to get rid of with all of our hand sanitizers and antibiotics. But of course, over the last decade or so, the way that we think about microbes has really changed dramatically with the explosion in terms of understanding the microbiome. We've come to understand that the role of the microbes in our health is a lot more nuanced than just playing the bad guy. And in fact, these trillions of different microorganisms are in fact essential for our health, whether it's for digesting our different food sources, producing different vitamins and cofactors, and of course educating our immune systems, which will be the main subject of my talk today. So changes in the microbiome have now been linked to a very wide number of different diseases. One's very surprising to me as I was starting out early in the microbiome field, that things like heart disease and cancer could be caused by not just pathogens in infecting a host, but also to changes in a broader microbial community as a whole. And really, central to how the microbiome contributes to our health is this notion of homeostasis, where there are healthy microbes. The people from my lab will laugh because this is the pointer that never works, and it has yet to continue to not work in a much bigger. Okay, here. Luckily, I saw where they put this. Well, anyway, so there are beneficial microbes that contribute to beneficially modulating and tuning our immune system, and then of course we have the pathobionts that naturally reside in our immune system, in our microbiome, that have pro-inflammatory potential. And then when there are shifts to the microbiome, then these can be intrinsic, whether they're driven by different factors innate to the microbiome in terms of the different species that are present, or extrinsic in terms of different host factors, exposure to different pathogens, changes to diet, exposure to different viruses even, for example. Then you can be driven into a state where you have a dominance of the pathobionts, the pathogens outgrow, and then you have an inflammatory state. But what this cartoon doesn't show is really the tremendous biodiversity of the microbiome. And so this is we're here at the birth of the location of the NIH's Human Microbiome Project. And this was a characterization of a couple hundred different individuals in terms of their gut, oral, skin, and microbial diversity. And really what this study showed was this tremendous biodiversity. The microbes, the hundreds or thousands of different microbes that are unique to each of our different body sites in terms of the diversity, where the gut is a very high diversity site with many different types of microbes, in contrast to other more simple yet very distinct different microbial communities like the urogenital tract or the skin. And then, what's important about this is that, each of these different microbes and each of these different locations educate the local immunity and provide the body site specific functions such as the digestion, such as the immune tolerance, for example. And as we try to understand now at a mechanistic level, now that we've kind of gotten a census-based approach in terms of kind of who's there in the microbiome, as we try to understand at a mechanistic level how the microbiome impacts our health and modulates our immune system, we have to really think at two different levels. So what are the functions of the individual microbes? So here now colored in the different colors here, how are these individual microbes each impacting the immune system uniquely? But then also, what's the impact of the collective coding potential of all the microbes together working in concert, even at times competing, and essentially adding their metabolic repertoire together? And so, what the goal of our center is, and of the basic research project that I've been working on, and what I'll tell you about today, is our efforts to systematically unravel these host microbiome immune interactions, which is really a very difficult feat and a challenge, given the biodiversity of the microbiome, the differences not just within our own ecosystems, but between individuals, between different disease states. And so our goal here is to understand these interaction networks, because we seek to understand what changes in a disease state, because these present new potential therapeutic targets for remodeling either the microbiome or the immune system to treat disease. And so the philosophy and the basics of how we'll approach this is to pair high throughput metagenomic sequencing-based approaches to understand who's there in terms of who's there in a healthy microbiome, who's there and who changes in a disease state, and then use this information to guide how we can actually extract these microbes from these individuals who are healthy or who have disease, to build the interactome and to build the hypotheses as to what is dysbiotic in terms of this interaction. So Daria described yesterday our collaboration with the Bateman Horne Center and the patient population that we're looking at. This is an early onset ME/CFS population, and this is really with the goal of capturing early risk factors, among others, to capture early risk factors as well as progression of disease. And so what the clinicians and the patients they do, this is really their achievement, and we're very thankful to their contribution, is we provide them with two different kits, so a metagenomic sampling kit that preserves the microbes and the DNA with which we can do our sequencing, and then also a kit by which we can actually recover the live microbes. And these are kind of our two major workflows. And especially here, I want to point out the value of the centers that have come out of this NIH funding mechanism, because it's brought researchers like me. My background is actually in the skin microbiome, and actually I had very little experience in the gut microbiome before starting this project, but this has really allowed me to diversify in terms of apply my different skill sets from the skin microbiome to learning new lessons in ME/CFS. So the basics in terms of how we analyze our sequence data and understand who's there in the microbiome is through high throughput microbial community analysis, what we call metagenomics. And this is basically extracting the DNA in total from all of the different microbes present in a sample. And you may have heard of 16S ribosomal RNA sequencing. So this is a single gene analysis that allows you to reconstruct with a certain degree of resolution the bacteria that are present in a sample. But here we're sequencing the entire DNA complement present in a sample. Therefore, we can gain information on not just the bacteria, but also the viruses, the fungi, as well as infer function by the gene coding potential. And of course, the benefit to this genomic approach is that it's cultivation-free, so it's relatively lower bias. You're not relying on different media conditions to extract particular microbes, and we can simultaneously, of course, identify and study the potential functions of these different, of all the different microbes simultaneously. And just as by way of background, so my group is a hybrid computational and experimental group, and so my group and others have developed different approaches to reconstruct these microbial communities. And this is one of the major ways these work, which is called reference-based analysis, where you take all the short sequence reads, and so they might belong to, the different colors would be reads belonging to different microbes here, here from the short sequence reads, and then you align the reads to some reference database that could be custom curated in terms of the species you're interested in, some genomic loci of interest, a functional pathway of interest, and more. So, and then we can deconvolute this data and then infer a relative proportion of the species that are present in a microbial community. And these would be some of the major goals in terms of what we would be interested from a metagenomics survey. So we might be interested in the composition, so who's there. We might be interested in the diversity of different microbes that are present. Reductions in diversity in the gut microbiome have been associated with different disease states. So perhaps this is a pro-inflammatory or more a high-risk disease state. We might be interested in interpersonal variation, different characteristics of a healthy community that we could then contrast with a disease community. In terms of the function, we might be interested in things like virulence pathways, pro-inflammatory pathways that are higher in their relative abundance, meaning that the microbes that are present may be encoding more of these pro-inflammatory molecules. And then I'll talk a little bit about strain diversity at the very end. But the overall goal is to really identify differences between individuals and the cohorts in terms of the potentially identifying disease-associated microbes. So I'm just going to show a quick snapshot of our data to date. So we have, I would say, probably 30 to 50 controls and ME/CFS patients each. And so these are called relative abundance plots, and each bar is a different patient sample. And the different colors represent the relative abundances of the different bacteria, fungi, and viruses present in the different sample. And I've just highlighted a few of the major genera and species here. This is actually a very high-resolution analysis to the species level. I would say, and so this is actually one of the punchlines of this section, is that this is all well and good. Is there anything immediately apparent from this contrast between the control gut microbial composition versus the ME/CFS patients? Maybe you can kind of see some differences here or some differences here, but it's not. This is actually not all that informative. So we can go into the data and look with a little bit higher resolution and look for species that are over or underrepresented in the disease or the ME/CFS state. And this is, you're not meant to read all of the different species present here, as in the ones that are overrepresented in the ME/CFS state, as you are to look at all the ones that are depleted in the ME/CFS state. And consistently with what Ian was just saying, is that we see a major reduction in the different microbes that produce the butyrates in the microbial community, as well as Prevotella. And Prevotellas are complex in terms of their phylogenetic and functional breadth, but they've been enriched in, for example, individuals that have a better diet, for example. So there can be complex interactions here that could be mediated both by kind of the lifestyle inferences of these patients, as well as being associated with their disease. This, too, is very limited in that this is just a static snapshot of what is present or enriched in a community. And so we hope to gain a little bit more information in terms of function. And so what my postdoc, Tunde Amiola, developed was an algorithm to infer growth rate. So what microbes are actually actively growing in a microbial community that could reflect the potential active microbes that could be differing between, say, a healthy population and control versus, when we sequence this, really any or all of the microbes could actually be dead. And so this is predicated on some very basic bacterial genetics. So bacteria are small. Unlike us, they typically have a single chromosome. And when they're rapidly dividing, they actually accumulate copies of their genomes at the origin of replication with relatively fewer copies at the terminus. And so when we plot the coverage of, say, our sequencing data across the length of the genome, we can see high coverage at the replication origin and low coverage at the trough. And so we can make a ratio from the peak to trough as an inference of its growth rate, where you see this bell-shaped curve, but then in a non-growing organism, the peak to trough ratio is much closer to 1. And so Tunde ran this on, looked at all the different species. So this is a metagenome-wide analysis. And so he looked at all the thousands of different species that we found in our metagenomic data set. And what was really interesting here is that, again, differentiating what's more rapidly growing in ME/CFS is really what is more rapidly growing in the controls. And again, these butyrate producers are really very significantly featured here. So I think this will be very, very important in terms of understanding the interactions with the immune system, because that is one of the major metabolites of interest in terms of host microbiome interactions. So again, all well and good, still inferences in terms of what may be more active, what may be more highly represented in a healthy microbiota versus these patients. But really now what we want to do is get closer to mechanism. What are those butyrate producers? What are these species that are enriched or depleted between the controls and our patients that are really driving kind of this inflammatory state that's been observed, as you saw from Daria's talk yesterday. So to come from the metagenomes to the mechanisms, our goal is, again, to systematically untangle these interactions. And really, there's a couple different flavors here. We can do this in vivo, or we can do it in vitro. So there's a really wonderful paper that came out a couple years ago from Dr. Geva Zatorsky's lab, where she took human, and Dennis Kapster's lab, and what they did was to take 50 different human microbes and then associate them into germ-free mice. And so these are mice that have never seen microbes. And then they looked at the immunologic response after 2 weeks, of growth of those microbes in the intestines of these mice. And so this is just all the different immune profiling that they did from these mice, covering both aspects of innate as well as adaptive immunity. And I'm just going to show one figure from that paper here, which was really striking. And that, so here, each of these boxes basically just represents one of the immunologic assays that they targeted here. And then in green is kind of the baseline. It's the germ-free only control. And then each dot represents the immune activation of that particular microbe in that assay. And then basically what's statistically significant is really in red and in the green. But what's really remarkable here is where all the microbes fall on these distributions. Like for here, you can see all the microbes are actually falling below kind of the baseline normal of the germ-free mice. Here they fall all above, and then some fall right in the middle. So some are activatory, some are non-activatory. And so this really emphasizes the breadth of potential immune modulatory capabilities that each different microbe can actually cover. And they only looked at 50 different microbes here, because this is a very intensive and very time-consuming approach. Actually, this was a heroic feat in terms of the scope of the experiment. And so, but this really highlights that we really need to look at and understand the functions of the thousands of different microbes that are present in any given individual or different patient cohorts. And so Daria alluded to this yesterday, and so here's this is our pipeline for building the human microbiome interaction. And so guided by our metagenomic surveys, we then perform, I would say, laborious, but our aspiration is to be high throughput in terms of the systematic cultivation of microbes from both the healthy as well as the disease cohorts. We then isolate the microbial supernatants, lysates, different products will come later. And then Daria Daria and his group have developed a range of different innate as well as adaptive immune assays that look at the immune stimulatory potential of all these microbes in high throughput, and meaning that we can now look at in vitro, and these I should emphasize that these are all human cell assays, and so this we think is more directly translational, but now we can screen the thousands of different microbes that we're cultivating from these different individuals to look for the immune stimulatory activity, and then build a network in terms of what are the different interactomes characteristic of an individual or characteristic of a healthy microbiome. And then kind of on the microbial end, we can do a lot of things like microbiome systems analyses, comparative genomics of high versus low activators to identify potential candidates, identify potential genetic pathways that underlie the activation. And then we do a lot of CRISPR work in our lab, heterologous overexpression, as well as metabolite discovery in order to understand the microbial mechanisms in terms of what is being produced by the microbes that activate or fail to activate the immune cells. So briefly to describe our stool culturomics pipeline, and so we've developed this for stool, skin, and the oral cavity. So here is our metagenomic data, just some random metagenomic data really here to show that this really guides the selection of our different cultivation conditions, which are both aerobic and anaerobic, and this was developed by my staff member Elizabeth Fleming here. And then we identify, basically type every single strain that comes, species that comes out of this analysis with MALDI-TOF, and then 16S ribosomal RNA sequencing or even whole genome sequencing if neither of those methods can actually produce an identity. And then you might ask, how many of the microbes do we actually cover? It varies, and so between the skin, the oral cavity, and the gut microbiome, we may be able to cover about 50% of the different genera that are present, as predicted by our metagenomic data. For the stool, but we're able to account for a pretty good proportion of the microbes in the microbial community, all the way up to 85% in the oral cavity. But really, there's still a lot lacking in the stool, and this is just because the anaerobic cultivation conditions can be very difficult for the gut microbiome. So, I think technical innovations in that space are also really going to be important. So now we have these thousands of different microbes. What might we do with them? And so Daria may have explained about this particular T cell subset that was kind of our proof of principle of this approach, where the bacterial metabolites, and in this case a metabolite of the riboflavin biosynthesis pathway, are presented to the mate cells, and then he's developed so the supernatants are then exposed to the APCs and then subsequently to the mate cells, and then we look for activation here, and this is just the result of the engineered mate cells that he developed for this assay, where here if you see that they're TCR negative engineered mate cells, you see no activation with E. coli supernatant, versus with the supernatant you see very strong activation. And then this was just to show the metabolite that's particularly being produced that the mate cells are stimulated by, and this is important because then we use this to guide our comparative genomics analyses. So the real take home here is that, and this really blew my mind, is how differently different species could activate the mate cells. And so these are the 4 dozen or so different microbes that we performed as our initial proof of principle, and they come from all over, from all different phylum. Most of them are human associated, some are randomly acquired. But really you can see that there are species that very strongly activate mate cells, and then species that don't activate at all. So just as proof of principle as well, and to see if we could actually knock down genetic components of the pathway to see that we can determine what is the metabolite that is affecting the mate activation in these assays. So we did CRISPR interference in E. coli, knocking down RIB-A and RIB-C. Those appear to be essential in terms of producing this metabolite, whereas RIB-D was not. And then finally, my bioinformatician, Wei Zhao, he performed comparative genomics to look for the presence of the riboflavin biosynthesis pathway in these different species. And not surprising, of course, everybody who's very strongly activated did have the pathway. There was a number of species that didn't activate the pathway, but didn't activate the mate cells, but also didn't have this pathway. But then there's a subset of microbes that had the pathway but didn't activate. And there were some suggestions of microbes that didn't have the pathway and that could somewhat activate the mate cells. And those are really those two latter ones are really the interesting ones in terms of why might a microbe make itself invisible to the mate cells and not produce the riboflavin metabolite. metabolite, or are there other metabolites that are produced by different microbes to activate the MATE cells? And those, I think, are particularly interesting cases in terms of metabolite discovery or environmental regulation of the production of this metabolite. So, and then another really interesting thing, and so as you may have noticed here, is that they're colored here by the phylum, and so this is one of the broadest phylogenetic levels that we can look at. And you may have heard this mentioned before, but the Bacteroides firmicute, this phylum level ratio, has been implicated in a lot of different inflammatory diseases. So this was a review from way back in 2011, looking at IBD and type 2 diabetes, necrotizing enterocolitis. And this is a pie chart representation of the Bacteroides and the firmicutes and the other phyla that were typically present in these different cohorts. And you can see that in a healthy control versus a cohort, the disease cohort, the Bacteroides firmicutes ratio could really be very significantly different. And so we were interested to see if mate activating cell as bacteria tended to belong to one or other phyla. And in fact, that was true. So the firmicutes tend to be relatively non-activatory, whereas the Bacteroides as well as the Proteobacteria tended to be much more, those tended to be much more activatory, activatory in terms of the MATE assay. And then this consequently may be of interest because this aberrance in this ratio may then underlie potential pro-inflammatory phenotypes that are observed in these different disease states and indeed potentially in ME/CFS. When we look at our own data, it does look like there's a change in this ratio, and that's again the cumulative. So I pointed out a lot of different species level differences in the composition of the ME/CFS versus the controls, but here we can see that at the phylum level, the ratio does seem to be dysbiotic. So we'll definitely be keeping an eye on this as our cohort increases in size and as we profile more microbes, particularly from these patient populations. So the last point I just want to make is that it's really not this easy. And if you were not surprised enough by the complexity of microbiome analysis, it's far more problematic because we have this issue of strain level variation. And so most of you are familiar with our favorite cabbage, kale, Brussels sprouts, and cauliflower. So this is all one species. But you can see that these subspecies have very different phenotypic, morphologic, taste, I would say just generally phenotypic properties. And this really underlies, I think, this is a good analogy for the microbial diversity that occurs at the subspecies level. An example for microbes that you're all probably familiar with is E. coli. So, we have the normal E. coli that lives on our benches, and then there's the E. coli that, of course, that kills. And so these differences at the strain level are really important from a microbial point of view for a wide variety of different microbial phenotypes, whether it's antibiotic resistance, inflammatory phenotype, and so on. And so one of the things we're really digging into in terms of the differences between the controls as well as the ME/CFS patients are these strain level differences. Everybody has some Bacteroides vulgaris and E. coli, but there's strong indication that the strains are different between individuals. Your strains are almost certainly to be different from my strains. And this is really where I think the majority of the genetic diversity is actually encoded. And in fact, we do have early evidence that there are real functional consequences to this strain variation as well. So if we take 24 different staph epidermidises, so in the initial assay, it looked like it was actually a pretty strong activator. But if we performed the MATE assay and then looked at the activation profile of these different strains that were isolated from different individuals and different body sites, we see that it really runs the complete range from non-activatory to activatory. And I suspect this will be true for I would say the majority of different species that we will profile in this assay. So with that, what I want to point out is that the importance of discovering the interactome is for understanding kind of the basic biology of the immune microbiome interactions and how these networks can be pro-disease, but also every one of these microbes that we isolate and identify an immune activatory potential could be a potential therapeutic, a potential probiotic, whether we are able to isolate the metabolite of interest to it, or if we're able to use the microbe as a whole, or if we're able to take a safe microbe, for example, maybe a lactobacillus, and engineer a particular metabolic pathway into that lactobacillus to express the immune activating metabolite. That's what we call an engineered probiotic. And this is really, I would say, kind of the philosophy of my lab, is in terms of leveraging what we understand from these genomic surveys to create microbiome-based therapeutics. And I really hope that we can identify some of these that can be of use to these patients. And so just to kind of give the range of potential options, and this is, we can think of this as a species network where the different colors are similar species. Antibiotics tend to be very broad spectrum, killing off multiple species in the community. Now that we understand a lot about the beneficial microbes and their role in terms of our health, this is undesirable if possible, although I would say it's still a very essential therapeutic. There are fewer ways to target single species in networks. So if you want to go in and really target that pathobiont, so we have been working on particular flavors of this, like different biosensors to sense these pathogens and then specifically eliminate them. So the different microbes that might come out of this from our work may be probiotics and engineered probiotics, where we're seeking to replace or remodulate, reshape the microbiome towards a configuration that is less inflammatory, for example, would be one example, or have even combinatorial targets where perhaps one microbe could produce multiple immune modulatory molecules and then and therefore be able to fine-tune the interactome. So with that, I'd like to thank my lab and highlighted in red, and I guess the illegible part are the people who have been very directly involved in this work in terms of the data analysis and the culturomics. And then you saw from Daria yesterday the human immunology team, and of course the clinical team and the patients that have contributed samples to our study. And thanking very much also the NIH for funding all this work, as well as my other funding sources and the Jackson Laboratory as well. All right, thank you.
Thank you. It was really cool and exciting. So thank you for that presentation. Are there any questions for Dr. O? I know we're coming up against lunch, so let's keep them quick.
Quick question, Armin Aladini, Columbia University. Very, very nice data. I'm just wondering if you're able to connect the differences in diet to the microbiome differences that you're seeing. I mean, the diet may be different between the patients and controls, and are you able to understand the connection there, or have you looked into it?
Yeah, so that's a great point, and I actually completely glossed over that in my very superficial description of the patient population. So one really powerful aspect, I think, of the center is kind of the integrative analysis that can occur once these kind of data have been collected. So we're not just collecting immune data, not just collecting microbiome data, but collecting a detailed history of lifestyle data, dietary surveys by app, all the different potential clinical metrics, whether self-reported or measured in the clinic, and those will all become correlates for this kind of analysis. So I showed the very high-level analysis that we might do just looking at the microbiome, but really the goal is in then linking it to all of the different other data types that are collected in the study. So that is indeed one of the goals, because we do know that diet is one of the strongest determinants of gut microbiome composition. Although I would argue that you start out with your own strains, and those and to a degree species, and those will be ones that fluctuate. But when we test them in the immune assays, they'll still be your own species and strains that will have a unique potential. But diet may be, for example, expanding a pro-inflammatory configuration or contracting a pro-inflammatory configuration. So I absolutely think that diet will be really important there. Yeah.
Okay, on the right.
Yeah, I'm a patient. I've been up here before. I used to travel a lot before bottled water days, and I'm trying to understand, is like water consumption, what's in your water, an environmental consideration? Does that relate to the bacteria and what you're analyzing in your
Yeah, so if you've traveled a lot of different places, you've probably collected a lot of different random microbes. Okay. So for sure, tap water is not sterile. Filtered water is somewhat sterile, and your bottled water is mostly sterile, but there have been different products found in all of those. But no, absolutely, if you've tried a lot, especially drank the indigenous water sources, you've at least been exposed to very different repertoire of microbes, for sure.
Okay, so I take probiotics now, and they do help me. I was wondering, when will this be available? I think all of us patients want it yesterday. I'm patient. I understand the science and the progress.
Yeah.
Could I come and get tested for my own genetic composition of bacteria in my gut?
Yeah, so it's actually quite straightforward to get the composition of your gut microbiome sequence. So there's a number of over-the-counter, or I would say DTC, sorry, not over-the-counter, companies that do it. So like 23andMe, there's now UBiome, and there's American Gut, and they will return compositional analyses of what's in your gut microbiome. In terms of the actual interactions between, say, the actual microbial properties and the functional attributes of your microbes, that will be, that's occurring in our labs as we speak, so that's a little harder to get at, but I totally hear you. The great part about each one of these microbes is that they're human associated, and each one theoretically could be a probiotic. Fecal transplants are already, have been very rapidly adopted in terms of treating Clostridium difficile infections. And what we hope to achieve here is to identify, the subset of, say, maybe not the entire fecal community for a transplant, but maybe 4 or 5 essential members that may, present, say, 90% of the remediation as far as an immunologic standpoint that an entire fecal transplant with kind of all of its random microbes could do. But can't put an exact time frame on it other than to say we work hard. My people work very hard who are there in the audience, so I thank them really in the end.
Great work, and looks like great potential for even a broader community, since a lot of people suffer from inflammation these days. So thank you.
We've actually run out of time, so I know there's a question here, but do you want to just come and ask it privately, and we can let everybody else go to lunch? Thank you, everybody. So I'm really excited to introduce our next speaker, Bhupesh Prusti. He was funded as part of our Ramsey program, and I'm really excited to see his data today. He's traveled all the way from Würzburg University in Germany to be with us. Please join me in welcoming Bhupesh to the stage.
Is it the right one? I'm not very sure. Well, anyway, because I thought there was something else in the presentation. But anyway. Oh, you thought it was different. Okay. Good afternoon, everyone. I come from a small place in Germany, Würzburg, and I'm completely new to the field of MECFS. And thanks to the Solve MECFS initiative, I'm here to show some of our data and to share our knowledge and experience with you. So what I'm going to do today is to tell you the differences in concepts. So if I tell people sitting here that the viruses, particularly herpes viruses, can contribute to the disease of MECFS, I'm sure majority of the people will not agree with me. Yeah? There are many evidences, for example, people have shown that different herpes viruses, parvoviruses, enteroviruses, and different bacterial species has been associated with this disease over the last several decades, rather, I would say. Yeah? But what is the missing point here is that we have the data of association. Yeah? We only tell that these viruses, these bacteria are associated with the disease. But that there is no molecular data, there is no study to show that how these pathogens can be linked to the disease. So my aim today is that to show you one of a unique mechanism by which herpes viruses can contribute to the disease of MECFS development. And by telling that, I will represent our data, or I will show you our data from HHV6A studies, but please do not take it granted that HHV6 is everything. Rather, I would like to show you some data that it might be possible that many other herpes viruses or many other bacteria have developed similar strategies to cause mitochondrial alterations. So, I will show you the molecular characterization of infection process in MECFS. Now, I will introduce you to mitochondria, which is being elaborately discussed over the last 2 days. Now, we all know that mitochondria is responsible for ATP generation. It's an energy house of the cell. But there is another characteristic feature of mitochondria which is very important in the disease perspective, and that is antiviral immunity. Now, mitochondria is very puzzling to me because when I started my studies, I read that mitochondria is bin-like structures, right? But when I looked into the microscope, I never found mitochondria as a bin-like structure. So what is wrong here? Nothing is wrong. Rather, mitochondria is a network of structures which sometimes is like beans, sometimes is elongated structures. Now look into this video from our lab where we target GFP or RFP proteins to the mitochondria. And here I try to focus into this red circled region. You can see that 2 mitochondria is getting separated, which is called mitochondrial fission, and the mitochondria also move towards each other and fuse. This is called mitochondrial fusion. Yeah? This process is very important for the mitochondria to be healthy. The mitochondria constantly fuse with each other and get separated, and this is required for healthy mitochondria. Now, as I said, the antiviral immunity from the mitochondria is very essential. So when the mitochondria are elongated structures, they are capable of mounting the antiviral immunity very efficiently. When the mitochondria is fragmented bin-like structures, the antiviral immunity from mitochondria is decreased. Yeah? I'm not going to details of this, but this is very important for understanding why viruses can target mitochondria. I would argue that because they want to survive inside the cell, they don't want the cell to produce the antiviral immunity. There are many different ways viruses target mitochondrial immunity, but for HHV6, this is unique because we found that HHV6 induces mitochondrial fragmentation just because to stop the antiviral immunity. Now look into these pictures. So a couple of years back, we developed first ever latent HHV6A model. So what we did is that we took the HHV6, put a fluorescent molecule into HHV6 genome, and then targeted into the cell. So as you know, the HHV6 goes and integrates into the chromosome in the subtelomeric region. So when the virus is integrated, there is no fluorescent molecule being produced in the cell. The moment you reactivate the virus, the cell produces these fluorescent molecules, and then you can know where the virus is reactivating. If you look into these cells, you see that this is the solvent control here, and here is the trichostatin A treated cells, and you can clearly see that the cells which are reactivating virus, for example, 3 cells over here, and the cells which are not reactivating the virus has a complete different morphology of the mitochondria. This is very strong phenotypic effect what we saw. This is in bone osteosarcoma cells. Then we looked into, so we developed mathematical algorithms to count the mitochondria, to measure the size of the mitochondria. So here you can see that after the drug treatment, the mitochondrial fragments, the number of the mitochondria increases because the mitochondria changes from longer mitochondria to smaller mitochondria. At the same time, the mitochondrial fragment size decreases because the mitochondria are smaller. Yeah? So this is a quantitative measure for us to know that the mitochondria is changing its structure. This is astrocyte cell line U251, and you can see that in these cells also, so here the red doesn't mean that it's a virus reactivation, rather the red is a GFAP staining to tell that these are the astroglial cells, and you can see that the mitochondria shows a similar type of phenotype. Now, you must be wondering that why mitochondria fragments? So it's already known that there are many different mechanisms by which mitochondria fragments. One of the very interesting mechanisms is by a protein called DRP1. And we call it as the Lord of the Fission rings because this protein, which is in the cytoplasm, can move to the mitochondria and wraps the mitochondria and forms a ring around the mitochondria. By doing this, it squeezes the mitochondria and separates into smaller fragments, right? So we developed this super resolution microscopy-based approach to measure each and individual rings inside the cell. We can tell that whether it's a dilated ring, whether it's a constricted ring, and we can count these rings in a non-reactivated cell versus a reactivated cell. So here, what we see is that if you look into a solvent-controlled cells, there is DRP1, which is stained by red here, but they are in the cytoplasm, not on mitochondria. But if you look into the cell which is inducing or reactivating the virus, you will see that the DRP1 rings are increased and they are forming these rings around the mitochondria. And if you do a quantitative analysis, we can also see that the Pearson's coefficient is very strong, showing us that, yes, the DRP1 is on the mitochondria here. Now, what does it mean? So we know from the literature that there is a human microRNA which is called as microRNA 30, and this is responsible for DRP1 expression. When there is a more amount of microRNA 30, DRP1 goes down, and we have a longer mitochondria. When there is a high amount of microRNA 30, DRP1 goes up, and we have a smaller fragmented mitochondria. So what we showed here is that, yes, of course, in these cells after the viral reactivation, there is a defect in microRNA 30 processing. So you can see over here that microRNA 30, the processed microRNA 30 goes down. But at the same time, we found a very interesting observation that these cells with reactivating virus are producing small non-coding RNAs from the viral genome. Okay? And we found that these small non-coding RNAs can actually fragment the mitochondria by themselves. I'm not going to the details of this molecular mechanism, but here to show you an example that if we take HeLa cells and produce this small RNA, snRNA U14 without any other viral component, we create the same situation where the microRNA 30 is processing defect. You see the pre-microRNA is accumulating in the cells, and you have a DRP1 upregulation, P53 upregulation, and things like that. That means that we don't need the whole viral component, all the proteins to have the effect. This one small RNA, which is basically a 23 nucleotide long RNA, can cause the effect. Okay. Yeah? Now, what about the mitochondrial health? We take a different approach to understand this. So here, this is a control cell. What we do is that we put a protein, which is a photoswitchable protein called MEOS2, into this mitochondria. So when we throw a laser light, the protein becomes red. Yeah? As I said, the mitochondria fuse and separate. So if the mitochondria is fusing with other mitochondria, you will see that their color is changing, yeah? From red to yellow, and they're ultimately becoming green. If we do the same thing in a HHV6A reactivated cells, even after 300 minutes or so, you see that these mitochondria are normal, able to fuse with each other. Yeah? That means that there is a defect in mitochondrial health over here. We also looked into many different other aspects, which I'm not going to say today, but just to tell you that this process also leads to decreased ATP production inside these cells. And we can also show by using galactose in the culture media that not only the mitochondrial ATP, both cytoplasmic as well as mitochondrial ATP is decreased in these cells after the viral deactivation. So in summary, from our experiments or from our experiences with HHV6 reactivation, we see that HHV6, particularly A reactivation, induces alterations in mitochondrial architecture. And the cumulative effect of this is on ATP content, calcium signaling, mitochondrial proteomics, many different things. Now, this is all good. And with this idea, we came to Solve ME/CFS initiative, and we wanted to check if this is the case in CFS patients, ME/CFS patients. So before that, I told you that I don't believe that HHV6 is the only virus which is causing this. So this is just a simple idea here. I show you that the small RNA, what I'm talking about, 23 nucleotide, has a region of 7 nucleotide, which is doing the job. Yeah? And you will see that these regions are almost highly conserved in different herpes viruses. And I'm sure if people will look into different other pathogens, probably they will also find similar type of strategy. So this might be a universal approach by many different pathogens to alter the mitochondria. Now, when we started to look into ME/CFS patients, we are not clinicians. I'm not a clinician. I do not have the facility to recruit many CFS patients. I'm really thankful to CFS patients from different parts of the Europe, Germany, Poland, Austria, UK, who came forward to provide different type of samples to us to analyze. So I started looking into presence of HHV6. I was really daydreaming that I will find HHV6 everywhere, and then I will say, oh, HHV6 is causing the disease. And this was not the case. As you see here, we looked into many different type of samples. We looked into hair follicle because you know that HHV6 is chromosomally integrated and inherited. We thought that we will find them, but as you see, so this is a representative picture to give you a clear idea. We looked into 23 CFS patients and 12 controls so far. And so you look here that if we look into HHV6, we find that there is only one case out of this 10 which is having HHV6 DNA in the whole blood. In the serum, there is no HHV6 DNA or even HHV7 DNA. This is telling that there is no active infection. The true definition of active infection is not there. There is no viral particle formation. But if you look into the PBMCs, we find that there are 2 cases which is HHV6 positive, and there are here 5 cases which is HHV7 positive, which is also the data from many labs. They have shown that you can detect. But this is telling us that probably there are very specific cells in the PBMCs or in the blood which are carrying the virus. And if we take the total blood, we might be diluting this. So, and here is also another interesting case. For example, I have a ICI-HHV6. This person has inherited the virus. So you can detect the virus in hair, whole blood, serum, PBMCs. So this is an ideal control for me. Yeah. So the most interesting part, we found that the average copy number of viral DNA is only 1,000 copies in million cells. And it is very hard for me to understand how a very few infected cell can create a situation where almost every cell represents the disease conditions. That's what we look for in CFS patients, right? In bloods, we expect that there is a morphological change, phenotypic change in many cells. Now, as I said, we found that this small non-coding RNA from the virus is an ideal biomarker because this is not expressed in latent virus conditions. And we can only find it when the virus is active. I'm not telling that the viral infection is there. Yeah? And we took a different approach. What we did is that we took blood clot sections from these patients, and we did developed a new in situ hybridization to look for this. And we found that 40% of ME/CFS patients have small number of infected HHV6A infected blood cells in the clot. We tested this assay using many different type of probes. For example, if you use a human U6 probe, you can find it in both type of HHV6 minus and positive cells. You take a scrambled probe, you don't detect it. And if you take a positively infected probe, you'll find in the positive infected cells. So this means that our assay is working, and we can detect more number of infected cells. Now, this again doesn't tell me how the virus is influencing all the other cells which is not carrying the viral infection. Yeah? So during this time, we came across a very nice paper from Fluge et al. From I think it's from Denmark or so. And it is also the idea of Professor Ron Davis also that the serum of ME/CFS patients have something which basically can carry the phenotype of the CFS infection to a healthy cell. So we give it a try. What we did is that we took the serum from the ME/CFS patients and the controls and put them into healthy cells. These cells are labeled with green mitochondria, so we don't need to stain the mitochondria. We don't want to do this. And when we do this, you can see these are super resolution microscopy images, and you can see the effect on mitochondria. So here is the control that I told a ICI-HHV6 person, the person having HHV6 but not reactive. And you see there is basically no difference. But if you look into the ME/CFS patients, the mitochondrial morphology is changed. Here I find the typical bin-like structure to mitochondria. Yeah? We quantified this, and here to represent a data, you see that the first is the 3 controls. Here you have the average mitochondrial surface area. And if you look into the 5 cases over here, the mitochondrial surface area is going down. That tells us the mitochondria is fragmented. in presence of the serum of ME/CFS patients. Now we went back to our cell culture system. We took the culture supernatant from the HHV6 reactivated cells, and we did the same experiment. And what we find is that the culture supernatant from HHV6 reactivated cells caused the exactly same morphological difference with fragmented mitochondria. Yeah? That means there is something similar between a ME/CFS condition and something similar between a viral reactivation in vitro. Now, if you are jumping into the conclusion that HHV6 reactivated cells are producing the small RNAs and the small RNA is going out and affecting the other cells, this is not the case. If you look into the parameters that we studied in reactivated cells, yes, there is a little bit of DRP1 overexpression. There is no change in P53, at least not detectable, and there is no correlation between the DRP1 and the mitochondria. The DRP1 still in the cytoplasm, not on mitochondria. This tells us that probably there is infection going on in some of the cells, and the infected cells are somehow signaling the cells in the nearby area that something wrong going on. And they also shut down the process, and the mitochondria is fragmented. And the fragmented mitochondria induces senescence. Okay? This changes the metabolic profile of the cell. Now, this is one slide with which I would like to probably conclude my presentation. If we think that the ME/CFS patient PBMCs, if we take out from the blood and try to do some experiments, do they replicate what is inside the body? Now, this is a trivial question because a couple of years back, there was a paper showing that ME/CFS PBMCs produce high amount of ATP. Yeah? And there are papers from other established labs beforehand that there is low amount of ATP in ME/CFS patients. So I was wondering what is there. So what we did here is that we took out the serum from ME/CFS patients. We put this serum on healthy cells for 3 days. Each day point, we tried to look into the mitochondrial fragmentation, 1 day, 2 days, and 3 days. And then we removed the serum from the media, washed the cells, and then wait for another 24 hours and then tried to look into the mitochondria. And we were shocked to see that the moment you remove the serum from the culture media, the mitochondria comes back to the normal condition. So here you can see that, I hope you can see here, the cells with 1, 2, and 3 days treatment, their mitochondria lies in this part with bigger mitochondria, less number. On the 4th day, the mitochondria starts to fragment drastically, so you see all the cells with the smaller mitochondria on this panel. And the moment we remove the media or serum, we have the mitochondria coming back to this part again. So here is the precautionary note from my side is that don't try to come to the conclusion from cells or PBMCs from ME/CFS patients which is grown in artificial media. Yeah? This is something, at least from my experience. I am not sure whether this is true for everything. Yeah? So what we are trying to do is that we are trying at this moment to apply a system biology approach to look into many different possibilities. We have a hypothesis that probably the fragmented mitochondria, you know that the extracellular vesicles, small exosomal vesicles, they are produced from the outer surface of the mitochondria, and when the mitochondria are fragmented, the number of these vesicles changes, and this is well established in Parkinson's and many other type of diseases. So we're trying to see if something is induced by this mitochondrial change which is transferring the phenotype to the other cells. But we may be wrong here. It might be simply ROS, the high amount of ROS produced from the fragmented mitochondria. We know that it does. It might be small RNAs or anything. We heard about talk from circulating microRNAs, and we have already published the data. The microRNA profile from HHV6 reactivated cells changes. It might be some cytokines, some proteins, so we still do not know. So what we do is that we try to look into single cell approach. We try to fuse metabolic labeling into single cells and try to see what amount of new RNA are produced in these cells. We want to take it to CFS PBMCs. So we want to do this in PBMCs and see what type of RNA are synthesized from these cells. But yeah, of course, funding is always a problem for this type of system biology work. This is a small lab of mine with 4 to 5 people, but very talented PhD scholars and master students and bachelor students. And we also get collaborations from many different people, including Markus Sauer, who is the pioneer in super-resolution microscopy. We are supported by many other people, collaborations, and also grants from unusual sources like Volkswagen Stiftung, HSV6 Foundation, Solve MECFS Initiative, and we have a very, very renowned center in our place called Helmholtz Institute for RNA-based Infection Research, and we are also funded by that. So with this, I would like to end my talk. I would be happy to ask a couple of questions if I have. Yeah.
Yeah, I think you can probably do a couple.
Yeah.
Thank you, Bhupesh. That was great. I hope you all enjoyed that presentation. We can probably do about 2 questions in the room, and then if anyone has any follow-up questions, feel free to find Bhupesh afterwards. So let's start here.
That was great presentation, Bhupesh. Great work. In the 6 nucleotide sequence that you presented, the GAG-CUC, the common, the cytosine uracil cytosine sequence is the one that is common to all the herpes viruses. Do you think the primary effect is coming from those 3 nucleotides?
Yes. So I did not present the data over here. So what we can show is that these 6 nucleotides are the reason which goes and binds to the stem loop of pre-microRNA. And thereby it prevents the DROSA-diacer complex to cut the pre-microRNAs and produce the processing microRNAs. This is a very typical example of RNA-RNA interactions and how pathogens can modulate the host cell just producing small RNAs. Yeah.
Okay, please go ahead.
Yes. As you're aware, when CFS cells are stressed with saline in solution, their impedance changes.
Yeah.
Yes? Do you think that the mitochondrial model might explain some of what's going on there?
So as I said, we have some idea that what exactly causes the mitochondrial changes. But as I said, that we clearly saw that there is something in the serum, some signaling molecule or something, which is signaling the healthy cells to shut down their mitochondria, right? And if we take out those cells and grow them in a different conditions with a different type of stress, probably the physiology will change. So yeah, I agree that one has to be very careful when coming to any conclusion what these cells are doing in a completely different atmosphere.
Thank you.
Yeah.
Thank you. Joe's going to come back onto the stage now to introduce our next session.
Thanks, Bhupesh, and thanks, Sadie, for organizing a really great microbiome and virome session. Our next speaker really doesn't need an introduction, but I'm going to give him a short one. This session is called New Technology for MECFS Research, and Dr. Ron Davis is the director of the Stanford Genome Center and has been involved in MECFS research and been a leader in that, and actually a leader in many areas of technology. He doesn't know it, I've never told him, but actually some of the early work with Peter Uffner and others actually impacted my career 20-some years ago. So I feel a debt actually to some of the work that you've done there from the past. So it really is a great pleasure to introduce you today and to hear about the molecular basis of MECFS. advance and back. If you hold this down, it'll be pointing.
Oh, okay. Oh, fantastic. Okay, perfect. Well, thank you for that introduction. Title of my talk is a little optimistic, but that's what we need to always do, try to keep pushing forward. The first thing that we decided to do, this was several years ago, was to collect a very large amount of data, just from the patients. And the other thing to consider at that time was that we should probably do this with the very severe patients. Now, I've heard a lot of discussion here about severe patients, and some of these severe patients come to the clinic to give samples. That's not what I'm talking about. I'm talking about severe patients that are bedbound. They cannot even get out of the bed, let alone go to a clinic. And you have to go to them. So this was a collaboration with Andy Koklenek. We picked his patients. He had a number of very severe patients. And we set up sort of a mobile phlebotomy situation where we went to their house and collected all the samples. This consisted of urine and blood and saliva and so forth. And then we have been processing and analyzing that data ever since. And we've also now started to do families as well, and collecting family members. And I'm not going to talk about that today. But the idea was to really collect a very large amount of information, and we're continuing to do that. The other idea was the fact that once we have the data and we're pretty sure that it's correct, to post that data on a website, which we're doing, and that's in charge of that is Wenzong Zhao, who's been putting that data up. It was complicated to do that because we wanted it to be put up at Stanford, but we had to poke a hole in their firewall. And so it took a long time to figure out how to do that without endangering Stanford. But these are just some examples of all the different things. Most of the immunology was going to be a collaboration with Mark Davis, and you've heard him talk yesterday. And then we've also used a lot of our own technologies. We're also developing new technologies all the time, and we're applying that to this disease. Just to show you the severe patients, this is just an SF-36 score with a number of different diseases, and I just wanted to show that, in fact, this is the patients here, and they're much worse off than a lot of other diseases, including congestive heart failure. So these are very severe patients. And we call that the severely ill patient study. This is an example of the severe patient. This particular severe patient, which happens to be my son, is very fortunate. As you can see from this picture, he's really not that light sensitive, even though he's covering up his eyes so he doesn't see me. Looking at me causes him great pain, and so he has to cover up his eyes, but he is not light sensitive, so we could go into his room after he covers his eyes to work with him. But it always annoys me when people say, well, it's not such a bad disease. It's a very, very, very bad disease. And it scores very highly when you look at the difficulty. I'm just going to show you a few things about this for the properties. This is cytokines because they're often discussed. And I think Jose Montoya talked about this as well. And the severe patients, and I think I should call these very severe patients. Because they're not really the same as a lot of other people's severe patients. And they have a high level of cytokines, and we just put this on it. This is a 63-plex. and virtually all the patients have a very high level of cytokines. We've done a search for infectious agents by massive DNA sequencing. The first one was really looking at particles from the blood and then sequencing any particle, and that will give you viruses, bacteria, funguses, parasites. We did find a few bacteria, but those appear to be coming from the gut. We also undertook to do a big DNA sequencing project from the cell-free DNA. Ian Lipkin does this kind of stuff, and we were just doing this on the severe patients, the very severe patients. And basically, we didn't find anything that was not found at the same frequency in healthy controls. We do find the SS viruses, but that's not consequential. We have done a big effort to look for parasites because they're generally not looked for, and we don't find parasites either. We have in development of fungus and RNA virus technology to look for those as well. Also doing genomics, we carried out a complete genome sequence. This was done by Illumina for free to give us support for our project. They went to 120 to 130-fold coverage of the genome, which gives us a very, very high quality sequence, plus it's an experienced facility. One of the things we discovered, and we're still going through all that data, it's an awful lot of data, we discovered that all 20 of the patients had a damaging mutation in a gene called IDO2. I'm going to cover that a little bit. But it wasn't really considered very significant. And that's because mutations in IDO2 are common. And so, in fact, if you do an automated search, it doesn't even come up. It's excluded because it has lots of mutations and therefore cannot possibly be important for any disease. And however, it bothered us that every patient had that. The average frequency of mutations was 1.7. In other words, there's an awful lot of patients that were homozygous for mutations in this gene. So we undertook to do a targeted sequencing. This was Bidong Shen who developed this as a technology. It's a multiplex PCR. A number of people have developed similar things to this. Our effort here was to develop one that was very inexpensive and would work on a very small amount of DNA. So this was designed to do newborn screening, where you have blood spots, and you can do a punch out of the blood spot, gives you about a nanogram of DNA, and we could amplify up any region or regions from that to do analysis, genetic analysis from the blood spot. We have gotten up to 1,000 different amplicons in a single reaction. We've also done that on the cystic fibrosis locus to do the entire gene. That's currently used in testing for CF at Stanford. So this is just to give you an idea of how this works. And the idea is to, the problem with most of the PCR when you try to multiplex is you get an awful lot of homodimers. So you've got to do something to decrease that. And what is done is to use targeted sequences. And as I said, we can go up to 1,000 different targets in a single reaction. But then you put on a primer. And this is what's called a homotail, which means the sequence here is the same as the sequence over here. It's not a homopolymer. And because of that being the same, when you amplify something, there's homology between the two ends, and they will anneal to one another. But you do this fast enough that they don't have a chance to anneal unless they're very close. So this takes out the homodimers that are created in a solution and allows you to do a better reaction. And then you would do a second reaction and so forth to put it in order to put it into the sequencer. And this has actually worked out quite well. And we've done this on a number of situations. So we've gone back and looked at the IDO2. As I said before, the severe patients have 1.7 non-functional mutations in IDO2. We've done another 59 additional ME/CFS patients. All have a non-functional mutation in IDO2. Now, our definition for the patients is a little more rigorous, I think, than most, but we're very lucky that we're in the Bay Area because there's a number of specialists for this disease in the Bay Area. And so they have to meet all the definitions of chronic fatigue syndrome, or ME/CFS, but they also have had to been seen by a specialist that's extremely familiar with the disease. And we're very lucky that Jose Montoya is there. Some of them are his patients. Dan Peterson, and several other doctors that see a lot of patients. And those doctors have to agree that they have the disease. Now, one of the problems with the IDO2 is 75% of the population has a mutation in IDO2. That's caused geneticists to say IDO2 is a very ancient gene, and it's on its way out. And it's absolutely irrelevant because there's another gene called IDO1, and that does the same thing. And here's the IDO1 pathway. It's also called the kynurenine pathway. It's where you make tryptophan into kynurenine in one direction, and tryptophan can go by hydroxylating tryptophan to make serotonin. Reason we targeted this region is that we know that there's an immune effect on the patients, and there's also neurological effects. This is one pathway that, in fact, would account for some of that because it makes serotonin, and kynurenine is a regulator of the immune system. So we call this a model, a metabolic trap, and I'll show you the details of that in a moment. This was originated by Robert Fair. Robert Fair is an undergraduate in electrical engineering at MIT and then got trained in human physiology. He was a professor at Johns Hopkins and resigned because what he wanted to do was doing systems approaches. He found it difficult to get that funded. And so he started a little company called Integrated Bioinformatics, and the pharmaceutical industry definitely needs this kind of technology. And so he's been totally busy working in that. His neighbor has chronic fatigue syndrome, ME/CFS, and that's what caused him to come to us to donate 1 day a week for free. And so we set him up with a team. Julie Wellman is the best technician I have ever seen. And if you ever watch her work in the lab, you understand why. And so we assigned her to work with Robert Fair. So this basically is a system fusion of a nonlinear systems theory, which Robert Fair is good at, with genomics and biochemistry, which I'm good at. And here's what you see with these enzymes. Now, this is going back to 1967. And I must admit that most medical students and graduate students never read the literature from 1967. And that's one reason why this is a great, I think, a great theory, because it relies on some really old-fashioned great biochemistry. And so what you can see from this is what happens as this is a standard plot of tryptophan versus the flux through the pathway, is that the activity of IDO1 increases like it should for standard enzymes, but then instead of plateauing, it drops. And that means it's substrate inhibited. Very unusual. And so this unusual property creates a real serious problem, potentially, and that is that if your tryptophan were to get too high, then in fact you would inhibit the enzyme to the point where in fact you would not get any flux through the pathway. Now, biologically, there's a backup, and that backup is IDO2. So if this were to ever really happen, what you could do, what would happen is that IDO2 would now be active. IDO2 does not bind tryptophan very effectively, but it is not substrate inhibited. And so at the point where you get inhibition of IDO1, IDO2 kicks in, that would convert the tryptophan to kynurenine, and that we drop the tryptophan concentration and you go back over the curve. So a person with totally functional IDO2 and IDO1 would not have a problem. The problem is that if you have a mutation, even a single mutation in IDO2, so you're heterozygous, if you model that with a systems biology approach, you realize there's not sufficient inactivity that you would actually still be trapped. So this model does not require a homozygous mutation. It only requires a heterozygous mutation, and that's unusual to have a phenotype generated by heterozygous mutation. And this other second slide over here is what happens when you have IDO2 defective. You come down, and in fact, you are now trapped. So this is certainly a possibility of happening. Is it what's causing chronic fatigue? ME/CFS is the next question, and that's something that we're trying to figure out. So the key points really here is that in the severe CFS patients, it's very common to have the mutation, and the IDO2 is the backup in other people, and this generates something which we call a bistability. Now that is actually one of the hallmarks of this disease. Once you get it, the chances of you getting over it are very slim. And so a bistability could explain that. In fact, what's interesting is that that's basically true for all chronic diseases. Once you get it, you don't get well. So these kinds of models, in fact, might explain a number of chronic diseases, and therefore it's really important to begin to study them. Now there is a second trap that we find in the patients, and that's the tyrosine trap. And that has the exact same properties in the severe patients. So it's possible that the patients are in both the tryptophan or the tyrosine trap, and we have to figure that out. So it makes a number of predictions. It predicts that the cellular tryptophan will be increased compared to a healthy individual, that the kynurenine or the kynurenine tryptophan ratio will be decreased, and that we can measure the catalytic rate of the IDO2, and that should be decreased. Now, the way you measure that is mass spectrometry to measure tryptophan and kynurenine. We have a mass labeled tryptophan that we can put in. We did the very first experiments. All 6 patients that we looked at first agreed with the prediction. Now, fortunately, we didn't run off and publish, which a lot of people might have done. We did an error analysis. What is the accuracy of those measurements? And we also took the samples and repeated it over and over again. We could not get consistent measurements, and error analysis suggested we are really on the borderline of sensitivity of the mass spectrometer. We cannot trust that result. So we have to increase the signal. So we began to looking at why the signal was so low. We found several problems. In order to do the labeling, we have to put them into Eagles media, developed in 1950. And Eagles media has 25 milligrams per ml of tryptophan. They probably did not know the level in the plasma, which is 5 milligrams per ml. So that really dilutes the label. The other problem was really the sensitivity of the mass spectrometer. We have a $600,000 mass spectrometer. It wasn't sensitive enough, really. You can do better. And Mike Snyder loaned our use of his mass spectrometer, which is in excess of $1 million, which is much more sensitive, and that will help a lot in the sensitivity of the assay. And then as we make those alterations in our sampling, we still don't get reproducible results. And I thought I would be able to come here today because the first patient we put through confirmed the idea, but the second one did not. And so we still have some variability, and we have to figure out the variability. One of the variability is that it's probably only present in the dendritic cells according to the literature. Dendritic cells are only about 1% of the population, of the white cell population. So we've tried to enrich by getting rid of T cells and B cells. That helps the signal, but we still get lack of reproducibility. I suspect one of the problems is that dendritic cells are quite variable in number. And then we yet have another problem, that this trap is not a trap for the entire body, it's a trap for a cell. And therefore it's probably cell autonomous. And so when a person were to get trapped, they don't necessarily trap all of their dendritic cells, they may only trap a certain fraction. And that fraction may vary with time, depending on the proliferation of those cells. So we're going to have to isolate dendritic cells, and we're going to have to look at them very carefully. Now, the other thing about this pathway, which is encouraging, is the fact that this pathway is also on in the brainstem. And it's also active in the gut. So if this trap is true, you would expect to have effects on the immune system, the brain, and the gut, which you do. So it could explain a lot of things. What would happen in the brain is that the tryptophan would be high, and it would make a great deal of serotonin. That should cause a number of brain problems. It could also cause the lowering of the kynurenine will in fact not cause lack of suppression of inflammation, which you also see. And in the gut, it turns out that the enzyme that makes serotonin in the gut is also substrate inhibited. And therefore, what would happen in that situation, as you make a lot of serotonin, you would then shut down that pathway and make virtually no serotonin. So it fits the observations, but we have to be, is it correct? And that's what we're working the hardest to try to figure out. The next experiments will be using isolated dendritic cells. We've done one patient, and that one patient shows consistent results with the metabolic trap from a purified dendritic cell population. Now we have to do many more. So, and I think even if we get confirmation that dendritic cells consistently show this, I think we have to do more to validate this. And so I think that means we've got to try to set this up into culture and see if we can mimic and trap cells and see if we can get them out. And that's the next thing to be done. I wanted to show you just a few other things in addition to that, and one of these is Mark Davis talked about his T-cell activation. This is an experiment that Mike Sikora has done, showing CFS patients with healthy controls, and they don't look very different. The one patient that we have that showed a lot of activation turns out to be, later found out she was not diagnosed with cancer, and that's probably explaining that. And that's a general problem with this method, that the patients may have something in addition. But also, you can see that here's one patient that has almost no detectable activation. So there's not a significant difference. Now, as Mark says, well, that all in good, except that we don't know what the patients are reacting to. And they may be reacting to something different than the healthy controls, and he's right. And so that's why he's looking at what they are recognizing. And this is a collaboration together. And I don't know how many more cells we'll do for this, but I think it's important to look at what the activated cells are recognizing. The other thing we have to do is, in these patients that we're now looking at, we have to sequence HLA. We've been involved in that for a long time. We developed the method for high-throughput HLA sequencing. And so while we're at that, we will also do the Kerr locus, which is involved in virus susceptibility. And that's also a very complex locus. The other thing I just want to show you is a diagnostic test that we've been working on called the nanoneedle. This is an old slide, but it just illustrates this a little bit. This is the device which has nanofabricated electrodes, uses a drop of blood, it measures electrical impedance. And it's a very sensitive instrument. We have 2,500 electrodes per centimeter, and we sample each electrode 200 times a second. So it gives you a massive amount of data. And what you see when you do this, you put blood minus the red cells, you then add salt right here, and when the salt is added, you get a perturbation in the electrical impedance, and then healthy patients basically are fairly flat. There's one patient here that goes up a little, but it doesn't really penetrate this area, and all of the ME/CFS patients show a strong signal. And this is kind of unusual for a diagnostic test to have it to be 100%. We've now done 10 more patients and controls. They also show the same thing. So even with this sample, the probability that you would find this randomly is 1 in a billion. So this work has been submitted to PNAS, and yesterday they called me and it's been accepted for publication. And so it should be out in a very short time. The other thing that we've done with this is to look to where the signal might be coming from. And we've done what's called a plasma swap experiment. And what it appears is that there is information in the plasma that you can take plasma from the patients and mix it with healthy cells, and you will recreate the signal. But if you do the reverse with healthy plasma into ME/CFS cells, we don't see a signal. You can then try to figure out what it is. We've done filtrations. It's easily filtered out. That means it's not a metabolite. The filtrations are such that it's not a cytokine. We made a stab and said, oh, maybe it's an exosome. We've purified exosomes from patients and added to healthy cells, and it recreates the signal. Now, that doesn't prove it's an exosome because it could be a contaminant of the exosome prep, but it very strongly suggests an exosome. And that's kind of consistent with the microRNAs that have been looked at as well. So there's further work that could be done there. The other thing that we can do is to use this as a test for drugs. You can put a drug in and see if it abolishes the signal. We do not know where the signal is coming from. My guess is it's coming from the damaged mitochondria, but that's only a guess. We have found 2 compounds that obliterate the signal. Copaxone is one of them, and that is a collaboration with Bob Navio, who's the first person to suggest that to us, and also in talking with him, we both concluded that the SS peptides should be tried. We have tried them, and they do that too. And that's a mitochondrial repair drug. Last thing I wanted to show you is an observation by Laurel Crosby, who's here at the meeting, that in doing hair analysis, and we're doing that because it's actually very easy to do, because you can have someone send you a gram of hair from anywhere in the world, and then you can analyze it by mass spectrometry. And the interesting thing is the fact that patients have elevated, about a third to a quarter of the patients have elevated mercury. And also, a little surprising is that we see elevated uranium, and especially in this one patient from Finland. I think most of these other patients are coming from California. So we don't know exactly the consequence of the uranium. But one thing is that it's not necessarily just the mercury that's the problem, because it's also, if you look at selenium, there's a correlation of high mercury, low selenium. And so the problem here may be more the selenium than it is the mercury. And so, in fact, it can be the selenium can be quite low. But also it's possible that even the high levels of uranium can cause selenium to get low. So maybe any of the heavy metals can reduce selenium. Selenium is used for T4, T3 conversion, and T3 is often low in the patients. I've talked to a few patients like that. I've asked did they check their selenium levels, and they said the doctor never even considered that. And so it's a possibility that there are some of these metals are a serious problem. And that, thank you.
Thank you very much.
Thank you.
Unfortunately, I think you have to take questions at the break.
That's fine.
There's a 3 o'clock break. Find Dr. Davis.
Yeah, thank you.
Our next session is imaging of the CNS and ME/CFS, and will be moderated by Dr. Fred Friedberg. Fred?
Okay. I'd like to introduce Dr. Jared Younger, who obtained his PhD in experimental psychopathology at University of Tennessee in 2003. He then completed postdoctoral fellowships in pain medicine and neuroimaging at Arizona State University and Stanford University, before joining the faculty at Stanford in 2009. In 2014, he transferred to University of Alabama at Birmingham, where he currently directs the Neuroinflammation, Pain, and Fatigue Laboratory. His laboratory uses neuroimaging, immune monitoring, and clinical trial techniques to develop new diagnostic tests and treatments for pain and fatigue disorders. And today he'll be talking about neuroinflammation in ME/CFS. Jared?
Thanks. All right. What I want to do is present the data that suggests that ME/CFS involves brain inflammation or neuroinflammation, inflammation in the brain. I'm going to focus only on human neuroimaging. I'm going to talk about magnetic resonance spectroscopy, or MRS, and positron emission tomography, or PET, because those are the two modalities I think are best currently able to show us neuroinflammation in the living human brain. What I want to do is take you right up to where we're at today with those technologies in ME/CFS, and then I want to outline a few immediate next steps that we need to take. First thing I have to do is give a very, very condensed explanation of what I mean when I say neuroinflammation. I use that term pretty crudely just to refer to any time the microglia cells, which are the immune cells of the body or of the brain, move from that resting state, which you see in the top left, into this activated pro-inflammatory state, which you see on the bottom right. So obviously there's a structural change, but more importantly, there's a functional change. When they move into this state, they start to produce pro-inflammatory agents, like pro-inflammatory cytokines, IL-6 and TNF-alpha and interleukin-1 beta, many other things. Those cytokines, when they're secreted in the brain, change neuronal functioning in specific affective regions that cause what we call the cytokine-induced sickness response. That's heavy fatigue, kind of brain fog, confusion, low motivation, just general malaise. So if you get sick and you feel horrible, that's the product of these released pro-inflammatory agents in the brain. Now, these agents are supposed to be transient. So once that virus or bacteria is taken care of, the cell should pop back up into its resting state on the top left. What I believe is happening in an ME/CFS is the cells are stuck in that activated position, or they're flipping back and forth very rapidly. If that's true, we really need to know that, because if that's the case, there are strategies for targeting these cells that may be of benefit to ME/CFS. So we really got to see if that's the case. It's just a hypothesis right now. The problem is, how do we show that in a living human? That is very difficult. We don't have access to these cells. There's no ethical, practical way to access them in humans. So we have to come up with indirect ways to do this. And I'm going to show you the best attempts to do that. So one method that researchers are using is magnetic resonance spectroscopy. And this is a very cool extension of MRI. So you see MRI scanners all over the world. Most of them can do MRS as well. This gives you quantification of different metabolites, and many of them are related to neuroinflammation. So some of them are myoinositol. You see that more in glial cells than in neurons. So if you see a lot of myoinositol in a region, it suggests that there's glial proliferation or aggregation in that region. Choline should be, there's a certain level where it should be at. There's always cell turnover. This is kind of a marker of cell turnover. If that choline peak gets too high, it suggests that there's abnormally high cell turnover. That's typically a marker of neuroinflammation. And if it shoots up higher than that, it suggests there's a tumor, which is even faster. N-acetyl aspartate is a marker of neuronal health. And so if you're in a gray matter region of the brain and that's going down, it suggests there's a neurodegenerative process. You're losing neurons. And then lactate should be very, very low in the brain at all times, because that really, you only see lactate if you run out of glucose. And so it's used as an alternative or backup energy source. So astrocytes and other cells only produce that when the metabolic demand exceeds the glucose supply. And really, there's only a few reasons why that would occur in the brain. So there's been several studies, actually, to look at these chemicals in the brain and ME/CFS. The most recent one outside of our group, Nadelson and his group did this one, where they looked at lactate in the cerebral ventricles. And these are kind of the cavities of the brain where the cerebral spinal fluid circulates. So they reported that there was higher lactate in the ventricles in chronic fatigue syndrome and in fibromyalgia and in people with both. And it's about 3 times higher than in healthy controls. That's pretty significant. I can only think of about 4 reasons why you would see that. One would be if you're hypoglycemic, and that's easy to test. We can rule that out. The other one would be if you have a vascular problem, and so you're not getting enough blood supply to the brain, and we can rule that out too with a cerebral perfusion scan. The other one would be if you have a tumor, but then we can see that with structural scans. And so once you rule those things out, what's left is neuroinflammation. So I think this is really strong evidence of that. That's not the first time it's been reported, and I don't know if Michael Van Elzacker is going to dislike me for this, but I'm taking a table from his recent paper that he's probably going to refer to. So there's one table I just had to take. It just came out the last 2 months, a very nice review. And what I really like for my talk is the fact that it identifies that lactate is probably the most commonly found disrupted metabolite in ME/CFS. And I think that's the strongest evidence to date that there is something wrong in the brain of ME/CFS, and it involves neuroinflammation. You can see this has been found in addition to the ventricles. Groups have found it in the occipital cortex. They found it in the anterior cingulate cortex, which is really important for sickness response. And they found it in the corpus callosum. So this has been found by many groups. What we wanted to do is take that study, and instead of looking at discrete regions of the brain, which is the classic way of doing MRS, we wanted to look at the entire brain. And so there are some MRS techniques that allow us to look at the whole brain in 3D with about 3 to 4 millimeter voxels. And so now we can get these maps. Instead of looking at just the cerebellum, let's see where the elevations are. So we're doing this with an echoplanar spin imaging technique. This was developed by Andrew Maudsley at the University of Miami, and it's a very cool technique. Uses a lot of kind of acceleration factors and shortcuts to get you a lot of data in a short period of time. So very nice MRS technique. We have a paper based on this. I hope some of you got to see Christina Mueller's talk, who's our senior grad student who ran the study. She did a presentation. There was also a poster. If you missed those and you want more details, the paper is out and you can look at that. Let me show you just a little bit, because I do want to talk about PET stuff. So I'm going to give you a very condensed overview of what we found. The very short story is we found lactate all throughout the brain in ME/CFS. What you're looking at here is the average of the ME/CFS patients, 15 of them on the right, and then 15 healthy controls, age match, gender match. These are all women on the left. And on the far left, you see the regions where there was a statistically significant increase of lactate. lactate was elevated throughout the brain. These are the regions where it was statistically significant, but it was pretty much throughout the whole brain. Many areas, I don't have time to go into the importance of these regions, but things like the anterior cingulate cortex, you see the thalamus, you see the hippocampus. These are very key regions involved in the sickness response. And so it's very exciting to see those. I will note that on the healthy group, you see that little ring of red on the outside. We're still working out some problems when you get close to the skull. Those are erroneous high values, and we have ways to throw those out. But there's still a few things to handle kind of when you're close to the skull. I do not think that's legitimate lactate, but all the stuff internal in the ME/CFS looks legitimate. And those lactate values are about 4 times higher in ME/CFS than controls, which is what the previous groups have found. Very, very consistent. The next thing that comes out in the review is choline, and that's been reported by 3 other groups. So we looked at choline, and we also found it was elevated in several brain regions. Anterior cingulate cortex, middle cingulate, again, key sickness response regions. Looking at ME/CFS on the right and healthy controls on the left, and those red areas are where the choline peak gets as high as the creatine peak, and that tells you something abnormal is happening. It really should be more like 0.5. It should be about half. So this is suggesting in these regions, for some reason, there's very high cell turnover, and that suggests a neuroinflammatory process. The focus of this was the anterior cingulate cortex, and in particular, the very bottom part of that kind of white region of interest is the subgenual ACC. And this is a very important sickness response region. That's where kind of depressed mood and malaise is centered. And so if this comes up in a lot of different regions, but a lot of the affective experience of the sickness response will involve that region. And you can kind of see what a healthy control looks like. You can see that choline peak is about halfway up the creatine peak CR, whereas with the CFS patient, they're kind of matching. Doesn't have a laser pointer, so just follow my finger. And then on the right, you can see the distribution of control in ME/CFS in that one region. They are not separating completely in any particular region. So we don't have 100% separation, but there is quite a bit of separation. So just wanted to show you what the distribution looks like. We also get temperature. And the reason we wanted to look at temperature, it's never been looked before, is because we believe if there's this excessive metabolic demand, that may exceed the cooling blood's ability to reduce that heat. We didn't know if that would turn out to be the case, but we're able to get whole brain temperature with the same scan, and we found that the brain of ME/CFS is running hotter by about 1 degree Fahrenheit. There's many areas where that increase is significant from healthy controls. You can kind of see this in ME/CFS on the right. The higher temperatures are in red. In particular, the insula and the putamen and the thalamus, those are the same regions that had increased lactate. And so we're getting convergence where there's one side of neuroinflammation, there's this other one as well. So what needs to be done next? There's 4 things we need to do with these scans. We need to do it in a larger sample size. 15 versus 15 does not tell us what's happening in the population. An important part of that is we need to look at subgroups. Clearly, not everybody with ME/CFS is going to have this increased lactate or increased temperature. We need to know the importance of that. Does that mean some people with ME/CFS have neuroinflammation and others don't? Are there different types? We have to figure that out. We also need to test it longitudinally. We do other tests where we look in the blood and we test people over many months, and we look at their good days versus bad days to see what tracks with those good and bad days. I believe this brain scan will show us what we should see on a bad fatigue day. We should see elevations of these metabolites, these neuroinflammatory markers, and they should be suppressed on a good day. If we see that, that's pretty powerful evidence that what we're seeing in the brain is strongly related to the symptoms. Last thing is we need to validate the scan with a PET gold standard, and that takes me over to the PET stuff. So positron emission tomography, if you're not familiar with it, very cool technique using radioisotopes that you can link to different ligands to go to different receptors. And there's many other things you can do with that, but that's one of the ways that we're using it. So the really nice thing about PET is, remember I said we can't look at the cells directly as they change shape, but fortunately when those microglia move into that activated position, they overexpress a receptor called the translocator protein receptor, TSPO. We think those are to provide breaks so other cells can push that microglia cell back to the resting state or to an anti-inflammatory state. But regardless of the function, when the microglia are activated, there's more of these TSPO receptors. So if we use a radioisotope connected to a TSPO ligand, we can inject that, and if we see a lot of uptake of that ligand in the brain, that suggests more microglia are in the activated position. So this gives us a marker of activated microglia. This has been used in a lot of different groups. This is what happens to National Football League players when they've had their head banged around for many years. When they're scanned 3 decades later using this technique, there's evidence. You see the NFL players on the right. This is an average of, I think it's 30 versus 30 healthy controls. I could be mistaken, but a pretty good sample size. You see increased uptake of this marker, which suggests activated microglia, as opposed to the healthy controls. That suggests that brain damage gave persistent neuroinflammation through the rest of their life. It may explain why they have increased incidence of mood disorders and cognitive disorders. This has also been done in ME/CFS. Most of you have probably seen this study. This was a 2014 study by Nakatomi and colleagues, and it's the only PET study to look at neuroinflammation in ME/CFS. They found several regions, midbrain, pons, thalamus, cingulate. The amygdala is in there, but to my eye, it doesn't meet statistical significance at P05 if you care about that. And then the hippocampus. So at least 5 regions where the ME/CFS patients had an uptake of this microglia marker. What's really nice about it is it overlaps almost perfectly with what we found with lactates. Thalamus, cingulate, hippocampus, same places we found upcrease of lactate. Now the midbrain and pons we have not looked at specifically, and so we need to do that. We may find lactate in those regions as well, but there's some special techniques we need to do to look in those regions. And on the right you can just see that thalamus in yellow, and you can see that they had perfect separation between groups. Now of course, as you know, if you run a test and you get 100%, as you just heard, separation between groups, you've got something really, really important. So this study has to be replicated. And the reason it needs to be replicated is because they used a very old marker for TSPOs called PK11195. And while it was great at the time, it's non-specific. It doesn't give us a high degree of confidence that what we're seeing is activated microglia. It just docks on too many things. So now there's second generation TSPO markers that we have access to that are much more specific. So we need to replicate that study and see if it holds up. If it does, we'll have some very strong evidence that ME/CFS involves neuroinflammation. Now, we received some pretty good news on RO1 score, which involves this PET imaging. So I hope soon we'll be able to replicate this and hopefully show pretty definitively if these individuals have neuroinflammation by activated microglia. And we plan on doing these scans on the same people who are getting the MRS scans. And so we can see, are these different modalities providing complementary information? It's going to be really, really interesting to see. I also, as you heard, I think yesterday, Jose Montoya is using a similar radioligand, whereas we're going to look at moderately severe and severe patients, so people who can get to the lab by some means. Jose's group is going to look at homebound and bedbound. And so since we're using pretty similar techniques, that's going to provide some really interesting information about, are the very, very severely ill suffering from the same thing as the people who can make it to the lab? Is it just a matter of severity of the illness, or are they different things? And I think converging this evidence or this information is going to tell us that. A couple more things about the PET. We know that these TSPO ligands are showing us when microglia activate. And this group, this is San Diego and colleagues in 2015. I really love these kind of studies. They injected people with lipopolysaccharide or endotoxin. And if you don't know, that's kind of the part of bacteria that our immune cells use to recognize when we have an infection. So if you inject people with lipopolysaccharide, you get a very robust immune response peripherally, and you also get the microglia response. So they showed that when you inject people with lipopolysaccharide and you do one of these TSPO scans, you see very rapid increase in the microglia activity. So they seem to be very quickly moving into the activated position. which is exactly what you would expect because people report feeling really, really sick, as they should. So the microglia are activating, that's that bottom row right there, producing those inflammatory signals, and then the people are feeling really bad. What's missing here is no one has ever done this in fibromyalgia, and they've never done it in chronic fatigue syndrome. And what I think would happen is if we did this in healthy controls versus ME/CFS, I think what would happen is the ME/CFS group would show an even exaggerated microglia response to that LPS injection. That would be really cool to do, and I think it would distinguish the groups, and that would suggest the microglia are primed or hypersensitized, which is one of our hypotheses about what's going on. They react to little triggers in an overly robust way, probably daily triggers that normally would not trigger an immune response in us, so the person constantly feels sick when they don't actually have a pathogen. That's one model. Just something I want to note really quick before I do a few wrap-up slides. We do inject people with lipopolysaccharide. We have not combined it with imaging. I've just finished a couple of weeks ago this in fibromyalgia, and I just want to throw this out here because it is relevant. When we inject people with fibromyalgia with about 0.04 nanograms per kilogram of lipopolysaccharide, we see that they have a suppressed kind of typical immune response. So there's less TNF alpha, there's less IFN gamma, there's less interleukin 1 beta. All those typical inflammatory things are actually suppressed in the fibromyalgia group. But they have a huge, weird alternative inflammatory reaction that is mostly marked by a massive increase of leptin. And you've heard leptin before, and it's because everywhere we look in ME/CFS and fibromyalgia, we are finding leptin. If I track people over time, the best predictor of their day-to-day severity of fatigue is leptin. You've heard Jose find leptin cross-sectionally. Now we're finding, by the way, what you're looking at, this is baseline centered leptin. The green line is fibromyalgia. The blue is healthy controls. It's at baseline, and then we injected them with LPS between time point 1 or 2, and these are hours. And so you see this immediate increase of leptin, and then you see the second kind of increase that comes later. Now we know this isn't circadian rhythm, and we know this isn't because we gave them a little meal at time point 5, because we also injected them with really, really low endotoxin, and this response does not occur. The groups are the same. So this is due to that kind of low-medium level of LPS. The reason I mention this is because I think this ties in really well with the central imaging that we're doing. Again, if we can combine these kind of immune perturbation studies with the imaging, I think we can look at the abnormal microglia response. So one model from this is that the peripheral immune response is muted, but a microglia-mediated response is exaggerated. So they would look less sick peripherally, but they would feel really, really sick because of that microglia response. So that's what we're working on. Now this was FM, not ME/CFS, but we need to do it in ME/CFS. Some of these people meet the case criteria, but most of them didn't, so it needs to be replicated. I don't want to assume they're the same disease. I think they have a lot of overlap. But last PET study, and then I will do the wrap-up stuff. We just got funding from ME Research UK to do a different PET study that's really cool. What we're going to do is draw blood, isolate the leukocytes, T cells, B cells, things like that. We're going to incubate them with ZR89 oxine, which is a very long-lasting PET tracer. So that goes inside the cells, then we re-inject those cells in the patients, and we wait about 5 days and then scan the brain. What we're looking to see if any of those peripheral T cells and B cells breach the blood-brain barrier and pop up in the brain. If we see that, that's going to be really compelling evidence that there is a pathological, serious pathological immune-related process occurring in these individuals. What I think we'll see is the healthy controls will show absolutely no signal because those cells are not infiltrating. And in ME/CFS, we will see some sort of signal. I don't know if it'll be small, medium, large, no idea. We'll find out. We will probably start this in 4 months, just working out a few more things, and then we'll get this going and see what we find. Here's my model to bring this all together, what I think is happening. I believe, just based on the symptomatology, I believe that neuroinflammation is the most proximal cause of the symptoms of ME/CFS. The fatigue and the cognitive issues, everything that most of the patients report, I think neuroinflammation is one step from that, and the cytokines that are released. However, I think there's multiple reasons why someone would have neuroinflammation, because these microglia are supposed to be responsive to a huge range. In fact, they're supposed to be responsive to everything that could damage your brain. And so it makes sense that there's many reasons why they might be sensitized or activated. So just as an example, here's 3 potential pathways leading to neuroinflammation, which would lead to symptoms. And so what I think is happening is there's a core set of symptoms that all ME/CFS patients have that are driven by the neuroinflammation. And then there's these kind of different symptoms that some people have and some don't. And I think those are driven by whatever is pushing the neuroinflammation. So just a few examples. That could be a pathogen, viral, bacterial. If you have a recalcitrant resident pathogen, that will easily lead to this microglia activation. It could be an autoimmune disorder like we'd see in rheumatoid arthritis or multiple sclerosis. It could be autoinflammatory and involve abnormalities in mast cells and complement proteins. It could be something, an inflammatory gut problem or some other peripheral inflammatory thing that's causing the central nervous system to release cytokines as well through the vagus nerve or through some other pathways we know of. It could be these dysregulated fundamental systems we keep talking about, mitochondrial problems, energy transfer problems that would cause the immune system to behave abnormally. It could be a problem with the vasculature, with the blood-brain barrier, or something like that. There's probably, I could fill up slide after slide of possible causes. I think what I want to say with this is, I believe if we find this, if we can treat the neuroinflammation, I think we will alleviate a lot of the symptoms in the ME/CFS patients. In some people, that will probably be sufficient to cause a remission of the disease. In other people, there will still be a fundamental issue that needs to be fixed, even if we alleviate some of the symptoms. So we don't want to have a condition where, if you've got your smoke alarm going off at 3 o'clock in the morning, and because your kitchen's on fire, you don't solve it by taking the batteries out of your fire alarm. You still have a problem you have to fix, right? And so if there's this fundamental problem, it has to be addressed as well. But I think in any case, calming down that neuroinflammation is going to help people feel better. So I think it's something we need to tackle. Last slide, we're going to be hitting these studies really hard over the next few years. My goal, I like to set public goals because it keeps me anxious about meeting them, is in 3 years, I want to know definitively if ME/CFS as a group involves neuroinflammation on the whole. And then in 5 years, I want to have a definitive, reliable, valid neuroinflammation scan that can work on the individual level. So we can take as many people as you want, put them in the scanner and say, this person definitely has high, medium, or low neuroinflammation or not. That's the goal in 5 years. And now I think we have the resources to do that. We just got to really put in the time every day to do that. We will move as fast as we can because, again, there are treatments, both existing and things that can be developed, that we can use to target this if we're sure that's the thing that we need to target. So if anyone has expertise in advanced neuroimaging or in helping us interpret some of this inflammatory stuff we're trying to work out, feel free to contact me. I would love to collaborate with people that can help me think through and get to these advances even faster. So that is what we're working on.
All right, I'm sorry, we don't have time for questions for Dr. Younger. I'd like to introduce Dr. Michael Van Elzeker. He is a postdoctoral research fellow at Mass General Hospital, Harvard Medical School, and he's in the Neurotherapeutics Division. He's also an adjunct instructor at Tufts University. He does his research at the Martino's Center for Biomedical Imaging, where he started an ME/CFS research program from scratch. Pretty good for a postdoc. Welcome, Dr. Van Elzeker.
No. A little higher. Yeah. Hi, everybody. Oh, I see. Thanks very much for introducing me and for inviting me here. I'm really glad to be able to talk about this. There'll be some overlap with Jared's stuff, which I think is good news, actually. We're sort of surrounding some important targets, I think. And luckily for him, I'm not going to talk about spectroscopy, although we are doing spectroscopy in both of the studies that we are currently doing. So we're going to replicate that as well, which other groups are replicating. So I'm going to focus a little bit on methods, and hopefully in a way that's not too wonky and will actually elucidate some mechanisms that I think are important, some of which Jared talked about and some of which I'll just add some cartoons to the things that he said, I hope. So I'm at the Martino Center for Biomedical Imaging. I don't have any conflicts. So we just put this paper out. Jared was nice enough to cite one of our papers, one of our tables that went through the spectroscopy data. And I just wanted to say that Sydney, my RA, is about to apply for MD PhD programs, and Paulita is going to apply for MD PhD programs in a year. So keep your eye out if your institution is looking. They're really great. So we have two ongoing neuroimaging studies. One is a PET study of resting state microglia, which is similar to what Jared talked about. That's that Nakatomi 2014 paper, which I think is the right way to go. And we're also going to be doing some sort of improved methods that I'll talk in a moment about. And then we're also doing an fMRI study separately, but hopefully with overlapping patient populations, of post-exertion symptom provocation, where we scan at baseline symptoms, and then they undergo David Systrom's invasive exercise test that he talked about yesterday, and we know that that's going to make them feel sick for a little while, and so we bring them back the next day, take advantage of that, so that we can actually get a good collection of what their brain is doing during that state. So let me talk a little bit about this. So this is, in 1956, myalgic encephalomyelitis, the term was first printed in The Lancet, and it was an article called A New Clinical Entity, and it was sort of a question, and the question of it was, all these previous outbreaks through the 40s and 50s, the idea that maybe they were related, maybe they had some sort of similar underlying problem, or maybe it was actually the exact same condition. And the term benign myalgic encephalomyelitis was coined. I actually wrote about this slightly inaccurately in our review. I said that this was an Icelandic doctor. The Icelandic doctor responded to this in a letter. And so that I had that a little bit wrong in the paper, but then there was this sort of outbreak in Nevada in the mid-'80s, and I also had this a little bit wrong in the paper where I said that perhaps a connection wasn't made. My understanding is that there was a Freedom of Information Act request that showed that the term myalgic encephalomyelitis was discussed, but then it was decided to call it chronic fatigue syndrome, which I didn't actually know. And so I think that history is really interesting because I'd sort of like to know what happened here, and there's a lot of different theories. People have ideas. So I think it could actually help us if we sort of got to the bottom of this a little bit. So the term myalgic encephalomyelitis, of course, means muscle pain related to central nervous system inflammation. And that term came from those outbreaks back in the 40s and 50s where they found what they described as sort of damage in the spinal cord, and they described excess proteins in the cerebral spinal fluid. But the fact is that we need to get sort of modern techniques that look for that. And so that's what we're going to do. Neuroinflammation is a little bit of an imprecise term. Jared sort of alluded to this. Inflammation classically is sort of the invasion of immune cells into tissue. And that's a cool study that he's planning to sort of see if that's happening. And microglia activation really is the proxy that we use generally in brain imaging as something that sort of, you would expect it to happen if there were neuroinflammation, if there were actual cell penetration, although it's not really a tautology. And this is the Nakatomi 2014 paper. And again, to point out this figure is really important, I think. The brainstem is where, when you overlap this relatively small number of patients, the brainstem is what looked active in all patients. So remember, when you see these splotches in brain imaging, it's not biology, it's statistics. And so what you're seeing is signal here that lined up across all subjects. And I'm going to talk a little bit about why we may be missing signal even here. And I agree with what Jared said about the idea of the split between patients here being really important. And that's something that I think a critical reader of this paper could make counter arguments. I don't necessarily buy them. So we're going to do some methods to try to undermine those counter arguments and see if we can really demonstrate that this is a real thing. So just a little bit of information about the brainstem, why I think it's important, why I think it's something that we should be focused on, and why it's a little bit annoying to try and study. The brainstem is really central to a lot of things that we see problematic in this condition. So it's central to pain processing, periaqueductal gray. Up here is sort of a key center for pain processing. It's key for neuroinflammation. It's really where a lot of the communication between those two sort of artificially separated body systems happens via the brainstem. And it's also key for autonomic processing, which of course that's POTS. We see that over and over again where these are sort of some really central problems perhaps. And to my mind, some of this is really important. This is the nucleus of the solitary tract where the afferent vagus, the one coming from body to brain, enters the brainstem, and then you've got dorsal motor vagus, which is really important for autonomic and parasympathetic control. That also seems to have problems in this condition. So the fact that they're all kind of lined up right here, these structures, says to me that that may be sort of an important general area. Area postrema down here is a little hole in the blood-brain barrier where things can sort of pass through relatively easily. They call it a fenestration, like a window. It's not like the blood-brain barrier is this really tight seal, but the fact is this is sort of an open area it's sort of, part of its job is to sample the periphery a little bit. It's the reason, for example, that you feel nauseous during food poisoning or when you've drank too much. This is part of what triggers the nausea. And if you take a look at Barnden's paper from 2018, it really lines up really well. Of course, this is zoomed in, so it's really pixelated, but it lines up really well with those autonomic centers and neuroinflammatory centers in brainstem. And this is actually, again, it's statistics, not necessarily biology. It's a proxy for biology. This is T1 signal, where they interpreted it as a myelination story, which is plausible. That's a reasonable interpretation. My interpretation would be that it's maybe macromolecules, maybe it's penetration of some of the bigger molecules through that area postrema from the periphery that maybe normally wouldn't make it in there. We don't know, but it's worth thinking about. So there again is those centers. So just a little bit of review. This is the hypothesis paper that I wrote in 2013. I never argued that this was like it, that this is the answer, we found it. I think it's an important mechanism that we ought to think about, and I think it ties in a lot of proposed mechanisms, so it may be sort of a hub that we can think about. And essentially the afferent vagus nerve, the one going body to brain, it has a lot of sort of different jobs. It detects peripheral catecholamines, so like just as an example of how central this is, when you have an adrenaline response right on top of your kidneys, that doesn't actually easily make it across the blood-brain barrier. A lot of what happens is your vagus detects it and then causes an epinephrine response on the brain side of the blood-brain barrier, right? So just give an idea of how central it is. It detects local immune signaling molecules, which I think is really important. So again, that sickness response that happens when you're sick with everything, whether it's strep or the flu, despite one's a bacteria, one's a virus, you still kind of feel the same sickness, which overlaps with this condition. Again, I'm not so sure that it is this condition, but it certainly is important, and it's important to why people feel so bad. The vagus nerve, it's got the same root as the word vagabond, right? It wanders all over the torso. It's very highly branched and very sensitive, so it's got chemoreceptors that can pick up these little immune responses that can happen in very local. So that's, to my mind, that's part of the reason that you don't necessarily need to see circulating peripheral cytokines in order to have a sickness response. So we have to be careful of type 2 error in that realm of study, and we talked a little bit about that in the review. Another thing that vagus does on an ongoing basis, it surveys the gut microbiome, which we've heard a lot about microbiome. This is an area that's sort of like really, it's pretty clear that it's becoming more and more important. So for one thing, I think it's important to note that there's bacteria and viruses in the biome, some of which we don't even know what they are yet. Those potentially pathogenic microorganisms interact with one another through phages sometimes. They actually can produce metabolites, so a large chunk of the metabolites that people are measuring might not be from human sources. They like to take advantage in different ways of the body's existing system, so they like to, for example, hijack mitochondrial DNA. So that's a potential source of some of these sort of systemic problems is microbiome disruption. And also it should be clear at this point that the gut, of course, is not made of Tupperware. It's not sealing all these things in, and it's becoming more and more clear that there are microbiomes in other forms of tissue, including brain, which is pretty interesting, that, at least sort of later in life. So, for example, Alzheimer's is associated with a dysbiosis of the otherwise not harmful biome. At least we don't think it's harmful. So it's something to think about. And of course, it initiates the central illness response by sending a signal up to the brain from the periphery. And we can measure that with a couple of imaging techniques that I'll talk about. Okay, so here's the brain, and just for like a little bit of kind of review, but I hope it drives home some of the points. So there's circulating immune cells, and these are sort of like kind of the dumb innate immune cells. They're not targeted specifically like an antibody. They kind of respond to anything abnormal. To my mind, importantly, not just pathogens, but also sort of evidence of damage. So they respond to things called pathogen-associated molecular patterns, so patterns that are on different forms of pathogens, virus, bacteria, whatever, but also potential damage. So like broken up pieces of neurons and things like that, and also possibly sort of pressure, which I'll talk about in a moment. There is this blood-brain barrier, which of course is not perfect. So when any sort of pathogen connects with the pathogen-associated molecular patterns of these innate immune cells, they activate, and then they release pro-inflammatory cytokines. Now, not all cytokines are going to just passively diffuse due to this blood-brain barrier. Cytokines are pretty big. They're lipophobic polypeptide molecules, so they don't just easily diffuse across a lipid bilayer in the blood-brain barrier, right? So, in other words, there has to be other ways that they can get through. Now, just to be clear, the blood-brain barrier can be disrupted in aging. It can be disrupted in neurological conditions. It's probably disrupted in this condition. So this is one area where we might get sort of stuck in circuits a little bit. But another way that these communicate is through that area postrema, through circumventricular organ. There's 7 of these. This isn't the only one, but I'm talking about this because I think brainstem's important. And what happens is they actually go right through. And interestingly, cells can actually be actively transported across these circumventricular organs as well. So there's actually chemoattractants at those sort of fenestrations that bring the cells in. And then the cells on the other side of the blood-brain barrier will de novo release pro-inflammatory cytokines. So a third way is through the vagus nerve. Again, this is all over the trunk. So it can happen in a very localized area, some particular area of your trunk. So again, pathogens or some damage-associated pattern will activate these cells. They'll release pro-inflammatory cytokines, and because they have sensors all over the place, the vagus can pick up a very small amount and then sends an afferent signal up the vagus nerve that de novo creates new microglia activation on the other side of the blood-brain barrier. That includes cytokines. The triangles are supposed to represent cytokines. So in other words, it's not like cytokines get sucked up like a hose. It actually is nerve signaling that triggers it on the other side. And I think that's sort of interesting because if there's some sensitized thing happening in the periphery, you could have an ongoing activation being sent to the brain, sort of on an ongoing basis. So just for like a quick review there, the highly branched structure allows detection of local immune signaling. Local signaling does not have to be infectious, so it can be microbiome, which sort of may or may not be infectious, I guess, depending on how you define that term. But it can pick up the sort of inflammatory milieu of the microbiomes. and it can also be damage. And it triggers a mirror response of central glial activation. So that's really close to what we see here, right? The activation is here on the brain side of the blood-brain barrier. And what I wanted to talk about is microglia. So what I showed you before included macrophages, just means big eater. It's those cells that sort of like to engulf foreign stuff. And microglia have different functions depending on where they are. So there are things called what's called a tissue-resident macrophage. In other words, there are different types of macrophages that go in different tissues, and they sort of end up there during development. The microglia are the brain's tissue-resident macrophages. Interestingly, to my mind, some of the conditions that seem to be slightly comorbid, like so endometriosis, for example, there's a lot of strong arguments that that is a disorder of the resident macrophages of the endometrium. So it's something to think about, that this may partially explain some of the comorbidities that we see maybe at a higher rate than normal. So anyways, these are the resident macrophages. And again, when a pathogen, or crucially, cytokines, perhaps through diffusion, perhaps through a circumventricular organ, connect with the macrophage, they change shape. Jared showed some real, this is a cartoon, Jared showed some real pictures. They change shape, though, so they withdraw in their little arms. They actually change shape, and they become active, and they have sort of a different morphology, right? And then they dump out. So the triangles are supposed to represent cytokines. We know about that, pro-inflammatory cytokines. There's a bunch of different kinds. They interact. But also they release neuroexcitatory modulators. So glutamate, the classic excitatory amino acid, ATP, prostaglandins, a bunch of stuff, reactive oxygen species actually, a bunch of stuff that sort of activates neurons. Evolutionarily, it may be because it's trying to keep nearby damaged neurons alive by making them fire, making them form more connections. Who knows, but that's sort of important, I think, for perhaps if this is really a condition marked by microglia activation, that may be part of what hurts sort of signal to noise in normal cognition, especially depending on which brain regions it's happening in. This is the neuroexcitation, by the way, is why, you know, within 5 years of a bad TBI, about half of TBI patients end up with seizures. So it's something to think about. And also, another thing that it produces during this process is that translocator protein, which is the target that those PET scans pick up on. And so this is the thing we're actually measuring. The fact is that the function of the translocator protein is not super well understood. There's ideas. It's bound to the mitochondrial membrane. This is one of those examples, by the way, where if NIH wanted to help the field, this is one thing that they could do with basic research. This is a thing where a scientist who's not really necessarily thinking, oh, I'm doing ME research right now, they could be tracking down what exactly does the translocator protein do? And we could sort of figure out what is our PET signal telling us. So I just think that's something that maybe we could think about. And that this causes immune signaling, neuroexcitation in the translocator protein. So I've sort of made this cartoon to symbolize that idea of microglial priming. The fact is, it's not a morphological state that we understand. We can't look at, and at this point, we can't even measure a microglia and say, oh, it's primed. It's a functional state. So what it means is subsequent provocations produce a bigger response, easier. And that's another area where perhaps NIH could fund some basic research that would really help us. What is microglia priming? Tell us more about that. What can we identify in a rodent model? What exactly is it? That's something that the microglia world is really interested in, I think. And all that means is when it's primed and some other challenge of the exact same size, again, hits the microglia, it's going to give you, whatever, twice as big of a response. And this, I think Jared sort of alluded to this, I think this is part of what might be leading to increased sensitization. So that seems to be a really common theme in this condition, like sensitivity to stuff that might not normally cause such sensitivity. So if you've got, for example, primed microglia dumping out excitation through the thalamus, which is what Nakatomi showed. It's what a bunch of different groups showed with spectroscopy. Thalamus is where senses go. It's like one of those old school operators, right? It's like a relay station. And this may be where there's a lack of inhibition and you're getting sort of excess painful sensory stimuli that can be really bothersome. So this is thalamus kind of right in the middle. So just to revisit Nakatomi really quick, they used, as Jared said, they used this PK11195, a first generation radioligand for this translocated protein. And really great, really important study. Super glad they did it. I think it's a really important study. And also at the same time, I'm not sure that it quite means what a lot of patients think it means, because the fact is that microglia are activated in a lot of stuff. And that's part of why we have to really have good methods to see, is it different than in all these other conditions? So here it is. This is the exact same radioligand that Nakatomi used. After traumatic brain injury, here it is after stroke. Here it is in complex regional pain syndrome. Here it is in Huntington's disease. Now it's Alzheimer's, Parkinson's, autism, depression associated with age, depression associated with suicidality. Here's bipolar, and here's recent onset schizophrenia, right? So when you see a study that shows you've got PK11195 binding or microglia activation, and we go, ah, yes, neuroinflammation, that this is a myalgic encephalomyelitis, we have neuroinflammation. Yeah, that's true, and so does like almost everything else, neurological or even psychiatric. So I think it's super important that we get really detailed methods to tell us how this is different, if it is, than all these other conditions. Is it different qualitatively, quantitatively, location, what? So I'll talk a little bit about that. So essentially these studies, you inject this radioligand, and all that means is you've got something that binds to this protein and you make it a little bit radioactive with sort of slow decay. And the signal is normalized to arterial blood or to a reference brain region, which is the reference brain region is what Nakatomi did, and I'll talk about that in a moment. Patients are compared to controls. So here's an example where in an fMRI here on the left, and this is sort of raw PET data, well not raw, it's transformed, but it's the transformed PET data here that's showing uptake. In this case, this is just an FDG study that we did as sort of a pilot. We had some access to free scan time at our center. And what you normally do is sort of register, and then for everybody, you compare either the whole brain or specific regions of interest to a control region, and it's usually cerebellum. That's a perfectly legitimate and normal thing for research groups to do. It's what Nakatomi did. But I would argue that it maybe not be such a good idea in a condition that we're still trying to kind of characterize. The cerebellum is filled with really large blood vessels. So it could be the case, for example, that there's immune cells circulating through those big blood vessels. It could be the case when you're comparing, we know that at least a recent study showed that HHV6 in the cerebellum is more active than in controls. So there, I don't know if that's a specific cerebellum story, but it could be. And also, there's a couple other reasons that perhaps doing this sort of comparison may not work so well. And so here's some confounds and alternate interpretations. So control groups, obviously, when you're just comparing to healthy controls, and I hope everybody in this field is always thinking about just sedentary. That matters, of course, right? There is some evidence that fitness is inversely associated with these microglia activation states. So that's just an important thing. We make sure we're not just looking at people that are housebound or have to exercise less. The use of second-generation radioligands, one of the things I really appreciated is that Jared, me, and the Montoya group are all going to use different ones, and normally I understand that might sound like it's bad news, but I think it's good news with these different radioligands, because one of the things that's cool about neuroimaging is you can really compare across groups and see if we're seeing the same pattern. So I look forward to doing that. if this really is a condition marked by problems with blood-brain barrier permeability, which there's some evidence for, the fact that Nakatomi saw more signal could just mean more is making it across the blood-brain barrier. So that's why we think it's important to do an arterial line where you sample artery blood so you really know how much is actually making it into the brain on an ongoing basis. And what's cool about it is if we do this arterial line, we'll be able to take the data from the other groups and sort of verify that their modeling is valid, which I suspect it will be, but we have to sort of preemptively prepare for critics and sort of undermine their arguments, I think, ahead of time. So general metabolism, we've heard over and over again. Maybe it's the case that patients aren't breaking down the radioligand and therefore more is making it into the brain. So you need to sort of think about that, and that's part of why an arterial line would really be a good idea. And I talked about reference regions. Using an arterial line really is the gold standard. It's going to be really difficult and expensive, but I think we hope it's going to be worth it. Okay. So I'll talk just for a quick moment about efferent vagus nerve function. So that's the sort of motor vagus. Part of what happens is that there's an anti-inflammatory reflex that ought to turn on when you get an inflammatory signal heading towards the brain. The efferent vagus ought to be making a synapse here at spleen, which is a beta-adrenergic synapse, by the way. So I guess I'd be curious what people think about how propranolol might affect that. But synapse is in the spleen, and that produces IL-10, anti-inflammatory. And the fact that people are having all these autonomic problems, to my mind, is evidence that this system is really not working very well. There's parasympathetic autonomic control. We know that patients don't do well on the tilt table test. They often have POTS, this sort of autonomic incompetence that we can measure with ICPET and just normal exercise tests. And we think that brainstem is really important. And I want to talk a little bit about, I'm trying to make a pitch for why this method is important. So normally when you're doing registration in a brain study, you take a bunch of your patients and you kind of have to combine them to be able to compare across brains. So what you do is you literally spatially register all of them, and then you compare across, brains. So the problem is not all brains are the same, of course. So you may end up in a situation in which you've got a brain that you have to sort of register, change shape, and this is actually the way that these imaging techniques work. But the problem is, do I have to stop?
Yes.
Okay, I'm sorry, I'm going over. Okay.
Okay. Thank you.
You?
Well.
Yeah. I'm sorry I'm going over. I free associate a little too much.
Well, by popular demand.
Okay. Yeah. I'm sorry, everybody. Okay. Thanks. Thanks. I appreciate the applause. That undermines my anxiety. Thank you. So essentially, you normally sort of spatially register, but the problem is it's done with neocortex. This is the standard technique. It's what almost every brain imaging study you've ever read does. And you have to, if you're interested in brainstem, you have to do it specifically. So let's just make an example where, let's just say in some theoretical condition, the entire brainstem is active. So that's the actual answer. Brainstem is entirely active, right? So when you do spatial registration, it lines up with neocortex, and what happens is your program will say where is all the activation happening, and it'll see where they overlap, all of them together, and it'll tell you there's the answer, right? The fact is that we know that it was the whole brainstem. I'm not saying that's what's happening in ME/CFS. I'm just giving an example, right? So this may be part of why the Nakatomi paper sort of missed that dorsal area that the Barnston paper did. And literally, Vitaly Napido did this and demonstrated over here. We published this figure in our paper. Demonstrated that literally with normal registration, this is 10 brains. Each of these is 10 brains. You can see the neocortex looks fine, but the brainstem does not. And I wanted to show this slide just to demonstrate that this is what's happening with heartbeats in your brain. This is an NIH-funded study. It was on the director's blog. And literally, it moves all the time with heartbeats. And this is part of what circulates cerebral spinal fluid. This is really important for actual blood perfusion of the brain. The actual physical pumping is important. Interestingly, this is different in Chiari malformation. which I think is one of those conditions that sort of, overlap with this one. Let me just blow through this a little bit. So, we're doing this exercise study test with Systrom. We're scanning before and after. I'm going to show some super preliminary data. This is Phoebe Chan. She's measuring with an ultrasound the middle cerebral artery, what is actually happening in the brain, so we can directly measure. And then we're looking at correlates so we can take into account the movement of the brainstem. So as just some preliminary data, we found these perivascular spaces in our subjects. I have to dig into this a little bit more. I'd love to find the old scans this has been reported for a while. These like hyperintensities, I don't know if this is the same thing, but this is sort of a proxy for inflammation. So I'd love to see those old scans. We got a bunch. This is like a 30-year-old woman, and it shouldn't look like this. We've got a couple of them. And then I guess my favorite is this here, before the exercise test, baseline symptoms versus after. So this is PEM, and we're showing a pretty strong reduction in the correlation between peripheral physiology and perfusion. So we think of this as a measure of cerebral vascular reactivity. So it seems like blood is literally not flowing as well. During a symptomatic state, they're doing the exact same thing in both of those scans, and it's literally just their symptomatic state. And I'll just stop there. Thank you.
Our last session is on orthostatic and autonomic disorders. And I'm very pleased to introduce Dr. Peter Rowe of Hopkins, who will be the first of our two speakers in the session. Dr. Rowe is well known to many of you. He basically put on the map the link between or among POTS and ME/CFS and orthostatic intolerance and ME/CFS. I've learned today that he's Canadian. He got his undergraduate degree at the University of Toronto and his MD at McMaster U. And then in part because the Leafs have not won a Stanley Cup since 1967, he moved south where he's of the border and has remained here since. He did his pediatrics residency at Johns Hopkins and a fellowship at Robert Wood Johnson, and went back to Hopkins where he's remained since. He's a professor of pediatrics and directs the ME/CFS Center there. Dr. Peter Rowe, thank you.
Thank you, David. And as some of you saw from Dr. Systrom's talk the other day, he had an iconic figure in the beginning, this guy who's the quarterback for the New England Patriots, Tom Brady. And I was concerned as a Baltimorean now about Tom's health because he was standing still and upright. And, in Baltimore, we wouldn't want that to continue because he could get lightheaded and tired. We got a clicker. So this is what we try to do when Tom comes to Baltimore is we try to get him to a safer position, very gently. Okay. So I'm going to talk a little bit about orthostatic intolerance. We've heard a number of speakers mention that throughout the couple of days. We'll talk a little bit about the symptoms that we see, why we associate it with ME/CFS, and along the way I'll talk about some gaps in the way we define orthostatic intolerance symptoms, how we characterize the signs of orthostatic intolerance, and then some new findings that I hope will be relevant, especially given the talks that Mike and Jared just gave. So the general definition of orthostatic intolerance is that it refers to a group of clinical conditions. And often we hear that POTS is the only form of chronic orthostatic intolerance. That's simply not the case. It gets repeated a lot. But this is a group of conditions in which symptoms worsen with quiet upright posture and are ameliorated but not abolished by recumbency. And the problem that we have is that the persistence of symptoms after a single period upright can be quite prolonged. After a faint, we've known since the 1920s, you can get 3 days of exhaustion and tremulousness. So often the symptoms of orthostatic intolerance seem unrelated to the specific orthostatic stress. The big physiologic challenge we face in standing up as humans is that there's a shift of blood volume of about 500 to 750 mils into the lower half of the body when we stand. This cartoon from Philip Lowe's book on autonomic dysfunction shows the distension of the veins in the right-hand figure in the areas below the heart. What it doesn't show well is the fact that there can be a lot of splanchnic pooling, so the abdominal circulation ought to be much more expanded than it appears in this cartoon. The normal response to that shift of blood into the lower half of the body is a drop in arterial pressure. That leads to less stretch of the arterial baroreceptors in the thorax and the neck. The neural message to the cardiovascular nuclei leads to a slight reduction in vagal tone and a big increase in sympathetic nerve outflow from the CNS. That leads to about a 10 or 20 beat increase in heart rate, a little bit of improvement in stroke volume, and the major influence on our ability to remain standing is that there's an increase in sympathetic nerve activity that improves vasoconstriction. That shifts blood back up to the heart and the brain, and then the brain calms down that sympathetic outflow. When this process does not function efficiently, how do I go back? When that doesn't function efficiently, you get these symptoms of orthostatic intolerance, which, as anyone can see, overlap tremendously with what we see in ME/CFS. The ones on the left are thought to represent symptoms due to inadequate cerebral blood flow, so lightheadedness, fainting, poor concentration, headaches, blurred vision. Every form of orthostatic intolerance has an increased prevalence of fatigue and exercise intolerance. The ones on the right partially are related to the high catecholamine levels that are in response to the reduction in cerebral blood flow. So we can see an orthostatic dyspnea or shortness of breath, chest pain, palpitations, shakiness, anxiety, and so on. One of the signs that we'll see, and I'm not sure how well this projects, is acrocyanosis. So patients will get this purple discoloration of the dependent limbs. On the left is a young college student who had to stop college because of her level of lightheadedness and fatigue. And this is her hand after about 4 minutes of standing, with my hand behind it as a color contrast. On the right, I went over and did a capillary refill test, so you can see the imprint of my fingers. I stepped back, found the cell phone, fiddled with it, tried to find the photography part. It took me about 8 seconds, and I took this picture, and you can see no capillary refill, which is really profound. And if this patient had been an ICU patient, we would have had her on a dopamine drip. So it's really quite an astonishing, dramatic clinical finding in many of these patients. We started looking at the overlap of orthostatic intolerance and CFS back in 1995, and we were looking at a group of patients who were recruited from a patient support group, one in Hagerstown and one in Richmond, because the Baltimore groups wouldn't come to anyone at Hopkins because previously they'd been sent immediately to the psychiatry department. In any event, we saw lightheadedness by history in almost everybody. Many of them had sweating, blurred vision, and 43% had at least one prior episode of syncope. The conditions that exacerbated their fatigue, in addition to physical exertion, which is part of the definition, were things that involved quiet, upright stress, especially in hot environments. So a hot shower was particularly troublesome for them. Prolonged standing, like waiting in line at the store. A hot day, and after a lightheaded episode. We had 23 CFS patients in this study, and one of the striking factors that has persisted till this day is that when we tilt them upright to 70 degrees, they develop an increased level of fatigue, a bad day for their ME/CFS. 20 of the 23 were lightheaded, 20 had a sense of warmth or a hot flash, 16 were nauseated, and 4 had excessive sweating, whereas the controls, exposed to 45 minutes of upright tilt, were simply bored. Others have extended these findings over time. Julia Newton's group in England has shown much more sophisticated methods. They used the COMPASS Autonomic Symptom Questionnaire, showing that CFS patients were much more likely to have high scores on autonomic dysfunction compared to controls, and the COMPASS scores correlated with their fatigue levels. Others, like Julian Stewart on the right and Marvin Meadow, his colleague on the left, have shown that orthostatic stress is capable of causing the brain fog that we typically see. So as the level of tilt goes up, patients make more and more errors or have more delayed responses. All of this data led us, when we were summarizing the literature in the Institute of Medicine Committee, to conclude that sufficient evidence indicates a high prevalence of orthostatic intolerance in ME/CFS as measured by objective heart rate and blood pressure abnormalities during standing or head-up tilt, or by patient-reported exacerbation of orthostatic symptoms with standing in day-to-day life. These findings indicate that OI is a common and clinically important finding in ME/CFS. There are some gaps in how we elicit and classify orthostatic symptoms. So in the autonomic literature, if you list symptoms like difficulty thinking or fatigue, the autonomic experts directly attribute that to the circulatory problems and lack of blood flow to the brain. In our field, fatigue and cognitive difficulties are often assessed independent of the person's position and posture, of the degree of orthostatic stress, and they are often attributed to some aspect of the illness itself rather than connected to the upright posture. And that's a bit of a problem in the way we elicit the symptom. We need to do a much better job sorting out when it occurs. There are also gaps in how the hemodynamic abnormalities are elicited. So the group in England wondered, could you do a shorter, abbreviated standing test or tilt test to diagnose how the prevalence of POTS? And so this is a paper looking at our own data where we had patients with confirmed POTS during 10 minutes. POTS is defined as a 30-beat increase in heart rate for adults, 40 for adolescents, over 10 minutes of standing with reproduction of their symptoms. And if you look at this life table analysis, if you stopped at 2 minutes, you'd miss 53% of those who truly have POTS and would potentially be denied therapy because they were said to be normal. Similarly, others have said 5 minutes should be sufficient, but with a 5-minute test, you're going to miss 27% of those who truly have POTS. We also found that you needed to check the heart rate after the end of the test because some, at least adolescents, before the test had a higher than normal baseline heart rate, so it didn't give you an accurate reflection of their usual resting supine heart rate. We found that the similar life table analysis is present in adults who are tested with tilt table testing, not just the adolescents with a standing test. The Institute of Medicine criteria suggested we needed to look at orthostatic intolerance and count as a core feature of the illness, but we didn't in that document provide much on operationalizing how you measure orthostatic intolerance. So an example of the problems from a cohort study we did in adolescents and young adults, we said orthostatic intolerance ought to be defined by questionnaire if you have lightheadedness at least several times per week. And we had 42 out of 55 who endorsed that. We also had 5 who had a pre-study diagnosis and were on treatment for their orthostatic intolerance, so they didn't endorse the questionnaire response. They had less frequent lightheadedness. That brought the cumulative prevalence up to 84%. In the remaining patients, we did either a standing test in the clinic we did a passive standing test in the clinic, and 6 more had POTS or neurally mediated hypotension, and the 2 others had worsening of their symptoms on the passive standing test, keeping in mind that a passive standing test only goes for 10 minutes. So in our experience, orthostatic intolerance is present in about 100% of these patients if you look properly. If we summarize the physiologic literature on orthostatic intolerance, there are 2 main things that seem to contribute to the problem. One is an increased amount of pooling of blood in the peripheral, in the limbs and the dependent circulation, and a defect in vasoconstriction. The other thing that's been documented by a number of groups, and I think most elegantly by Nancy Klimas's colleagues, is that there's about a 10% reduction in circulating blood volume in these patients for reasons that we don't understand. Those two factors combined mean that when you undergo orthostatic stress, either with standing or tilt, there is ultimately a reduction in cerebral blood flow. That elicits a big sympathoadrenal response, and then the phenotype of the circulatory response that you might see is at the bottom. So you could see orthostatic hypotension in the first 3 minutes. You could see delayed orthostatic hypotension after 3 minutes. You could see the vasovagal or neurally mediated hypotension response. You could see POTS. And then a large proportion, especially of the adults, have what seems to be a normal heart rate and blood pressure response. When we looked at the literature, and this is meant to be unreadable, so don't try and get at each individual study. When we looked at the data for the Institute of Medicine report of the 14 studies where prolonged tilt testing had been undertaken, we saw the summary was 42% of ME/CFS patients had orthostatic intolerance in the first 45 minutes, and that compared to 15% in the healthy controls. But the variability in studies was tremendous. Some reported no patients with CFS having orthostatic intolerance. I find that hard to imagine. I'm not sure that those were patients that were anything like what we see. And this was up to 79%. But it may be that when we're looking at the phenotypes for hypotension and POTS and so on, we're looking in the wrong place. If the symptoms are due to decreased cerebral blood flow, maybe that's where we ought to focus. And the next few slides are with permission of Frans Visser and Linda van Kampen from the Netherlands, two cardiologists who have developed a new method of measuring cerebral blood flow. Our earlier methods used to involve transcranial Doppler to look at cerebral blood flow velocity, but not total flow, or scans that were done with the patient supine, which obviously wouldn't pick up what we're looking for. They came up with a technique for looking for cerebral blood flow changes during tilt using Doppler imaging for a few seconds each on each carotid and each vertebral. So you're getting all of the inflow to the brain. And what they showed was that by the end of tilt, there was a 6% reduction in cerebral blood flow for healthy volunteers. When they looked at the patients with ME/CFS who had normal heart rate and blood pressure responses during tilt and would otherwise have been said to have had a negative study, what they found was quite profound. And that was about a 20% reduction at the end of tilt, which was a 20-minute tilt, in cerebral blood flow. In those with POTS and hypotension, it was closer to 28% reduction, so really quite a profound change. Almost all of their adult patients had this kind of reduction. So I think that needs to be part of the discussion about the neuroinflammatory causes. Could they be related to cerebral underperfusion? I'm not sure we've ruled that out just by doing scans with patients supine. They also looked at the question that is raised often by the cognitive behavioral theologians, as I call them, because they don't take into account the autonomic data. They assume that everybody who's dizzy and lightheaded simply is deconditioned. So Linda took a look at those who'd had a cardiopulmonary exercise test, ranked them whether they had greater than 85% of their VO2 max or less, and they didn't differ from one another. So whether you were deconditioned or not, you still had a reduction in cerebral blood flow. And if they matched people on the number of steps, which you see on the left side of this slide, smaller numbers, you could still see that even though the steps were the same, those with ME/CFS had close to a 25 to 30% reduction in brain blood flow. Orthostatic intolerance, as you've heard from Cindy Bateman, is one of the most treatable problems that I've encountered, that many of us have encountered in this illness, and this was from one of our early studies in 1995 showing that with open treatment using a variety of medications directed at hypotension, the overall wellness score in the patients went from about 35 up to about 70 after 4 months of treatment. The responses weren't uniform, but most people can be helped by this. So in conclusion, the majority of the adult, and although I didn't present this data, all of the pediatric studies show that orthostatic intolerance is strongly associated with the illness. Upright posture, we know, consistently aggravates the symptoms, even in the absence of heart rate and blood pressure changes, and often for days. Again, consistent with orthostatic stress being a cause of PEM. The cerebral blood flow reductions measured by the Doppler technique are substantial and clinically significant. And then just to end with a couple of thoughts about research needs, I think we need to understand better, and perhaps Dr. Oaklander will be addressing this, the causes of orthostatic intolerance in ME/CFS. So is this due to some high prevalence of anti-adrenergic and cholinergic autoantibodies, as Scheibenbogen's group has suggested? Is there a high prevalence of mast cell activation syndrome as a precipitating or perpetuating factor? What's the influence of the increased vascular compliance in those who have hypermobility or Ehlers-Danlos syndrome? And one can ask reasonably the question, is mitochondrial dysfunction a cause or a consequence of the impaired circulatory control? One thing, though, that I want to come back to, and Betsy Keller made this point the other day, is that patients need treatment. The open treatment of orthostatic intolerance is associated with improvement in fatigue and other symptoms. And I think we need much more funding for clinical trials and practical studies to help provide an evidence base for practitioners who might otherwise not be inclined to try to manage orthostatic intolerance as a way to improve function. Lastly, orthostatic intolerance syndromes are heterogeneous, and we teach our trainees that we need to continually ask, orthostatic intolerance due to what? We published last year a series of 3 young women who had full-blown ME/CFS by anybody's criteria. All of them had orthostatic intolerance, and all of them eventually had abnormalities on their neurologic examination, either really brisk reflexes or a positive Hoffman sign or both. And the slide on the right shows the cervical spine MRI for one of these patients that I had followed for 6 years. She eventually got a positive Hoffman sign. We got the C-spine MRI, and she had cervical spinal stenosis on a congenital basis with a canal diameter of about 8 millimeters. Normal is more than 13. And at C5-6, she had a small disc bulge that might be inconsequential for most people, but it was enough to cause indentation on the cord. Her orthopedic spine surgeon said, I don't know about this fatigue and tachycardia stuff, but you need that disc replaced or else you're going to get into trouble in a car accident. With the disc replacement, she had a full recovery over the next 9 months and has done well for 5 years since, now rock climbing, fully active, working full-time, and not only did her POTS resolve, but so did her anxiety. And we had 2 other patients with very similar functions, one of whom recently sent me a picture of her being loaded into the ski patrol tray because she'd torn her ACL skiing. And as we say, we don't need no damn p-value for that one. So I'll end there. This is just a word of thanks for all those who have supported our work over the years.
Time for questions here.
Okay. Oh, okay.
Thank you very much, Dr. Rowe. We have time for a couple of questions.
Great.
Presentation. Can you just comment on the clinical observation that we see symptomatic improvement in women when they become pregnant in this group in patients with ME/CFS?
Yeah, it's not uniform, but we see it fairly often. And we think the reason is that if you're starting off with some degree of hypovolemia, part of the normal physiologic response in pregnancy is about a 2-liter expansion of blood volume that kicks in by the end of the first trimester. So some of our patients, we learned this from the mothers of the adolescents we were treating when we took their history, and they said, yeah, I had this lightheadedness stuff until I got pregnant, and that was the best I'd ever felt. And the young women often will say that. I don't think that's a really common report from women who are pregnant. They might be blissed out and happy that they're pregnant, but they don't feel physically better than they've ever felt before. But that's something we hear from our ME/CFS patients a lot. And in my clinic, what I do is I then say to the parents of the adolescent girls that they should get those girls pregnant often. And that's a test of whether they're going to tolerate my sense of humor from then on.
Can you tell us how you guide your patients about the role of exercise if they're trying to recover from
it's
this
a
condition?
big question. One of the problems with, I think, the way exercise has been forced on people with ME/CFS as if it's somehow curative is the sort of British pace type attitude that all you need to do is get off your lazy bums and get moving. And so there's been a reaction to that. There are some people who are harmed by excessive rigid advancement of exercise for sure. But in order to get where we want people to be to recover function, they've got to go from this point to this point, and the only way to do it is to increase their activity level at some point and with some level of support. I think the difference with how we approach it is that we want it to be flexible in patients who can tolerate it, and it's almost always the case that you've first got to support their circulation before they can advance to any kind of exercise. We find that the physical therapy stuff I was mentioning earlier today is another bridge to tolerating exercise. If they simply can't tolerate it, you have to find other ways to advance things slowly, gradually, and without provoking PEM. But I really think we are in trouble if we have such a strident opposition in this community to any form of activity, because when people are completely on bed rest, they lose about 18%, up to 18% of blood volume in 2 weeks. That's going to make their orthostatic intolerance worse. It will start a terrible downward spiral. So I think we have to have a much more nuanced understanding of the importance of activity for recovery, but also a recognition that our job as physicians is to support the patient in being able to tolerate that. Slow, gradual advancements.
Your last answer is very interesting to me. So my daughter, I live in Boston, she has chronic fatigue, and my niece who lives in Maryland, and I don't know if she was treated by you or not, she's 15 years old, and she just went on the Inca Trail. She just went to Machu Picchu. That's how much better she is. And I know that she did physical therapy and after being kicked out of, she couldn't go to school. That's how bad she was with POTS. That's what her diagnosis was. And now she went to Machu Picchu and to Peru and was dancing and everything. So my daughter, first of all, do you see patients that are adults or you only see adolescents?
I mainly see adolescents, and we're so jammed that it's very hard to get new patients in because there's no adult clinic to transition them to, and I've been following people for 25 years. There are a lot that we can't get better, and so I don't want to suggest that this approach works well for everybody. And those are the patients we struggle with the most. Some patients improve spontaneously as they get further and further away from their initiating infection. We don't understand that well enough, and why some people just don't seem to respond to much that we throw at them.
Okay, thank you so much.
Yeah, unfortunately, in deference to time, we'll have to take additional questions after the session. I'm sure Dr. Rowe will be around. Thanks. Our last speaker of the session and of the symposium is Ann-Louise Oaklander, a close collaborator and a friend from Mass General Hospital, where she directs the nerve unit. Ann-Louise received her MD and PhD from Einstein and then did her medical residency and neurology residency at the University of New Jersey. She then finally went on and did her fellowship at Hopkins, where she overlapped with Dr. Rowe, apparently. Dr. Oaklander spent her career studying a relatively unknown part of the human nervous system, which is the small fiber nervous system, and she has done a fabulous job of putting together some of her basic research with clinical findings, including fibromyalgia, and we'll see what she has to say about ME/CFS today. Ann-Louise.
Thank you very much for the introduction. I know I'm the last speaker, so as you'll see in a minute, I've actually put my conclusion slide as the second slide so that you can leave after that. But before I do that, I just want to acknowledge one additional part of my training, which isn't you wouldn't necessarily know about, but that's the many years that I spent learning from Walter Koroshetz and Ann Young at Mass General. And I think what you'll see is I'm going to echo some of the things that he opened the meeting with. So he and I are going to be bookends in a way. But then I realized that's not actually just by chance, because he helped to give me the approach that I have and that I'd like to share with you in just a few minutes. And my approach is that it's very helpful to patients if they end up with a diagnosis. And so I'm going to focus really on pathology. We heard about pathophysiology in the previous talk and also from Dr. Systrom. I agree completely with the things that are said. I'm going to talk now really about cell biology and a cell that I think contributes to the problems that some of these patients have. And again, that's because as a neurologist, I'm trained to localize what part of the nervous system is involved and then to look at the etiology. So Walter, I hope you'll stay to the end and maybe you could let me know. Okay, so to give you my conclusions in advance, I'm going to tell you that small fiber neuropathy or polyneuropathy is a cause in some patients, not all, of multi-symptom illnesses, that in the majority of patients, even in advanced countries and settings, it remains undiagnosed. Skin biopsy is the test that's endorsed by the American and European Academies of Neurology for objective confirmation. I'll show you some of our data in fibromyalgia. I'm then going to move on to etiology, the second part. If you have a cellular diagnosis, you need to think about what the underlying medical cause could be in that person. It's different in different people. And the reason to do that is because if you can come down to localization and etiology, then you have an actual diagnosis, not just a label or a syndrome. And that then puts you on the pathway towards more effective and potentially disease-modifying treatments. And then I'll end by telling you a little bit about our research. But before I do that, I'd like to mention the reason to do all this is because these small fibers, actually their biology is such that they continue to grow throughout life. We've heard a lot about chronic disease being chronic, but in fact here, if you can figure out what's going on and improve it, there are substantial chances for improvement. I'm talking again about nerves that connect the brain and the spinal cord to the outside world. Our peripheral nerves are mixed. They have different kinds of axons in them. And what I'll be speaking about are these small unmyelinated C fibers and the very thinly myelinated A delta fibers, and then the autonomic axons, the postganglionics, particularly the sympathetics, are mixed in. Polyneuropathy means that all or most of the nerves in the body are affected. We neurologists, and I'm sure Walter would agree, we just weren't taught a lot about these in our training. For number one, because they're hard to see, you need special techniques. But number two, because when the patients get sick with this, they just develop all sorts of different symptoms. They get sent to different specialists, each of whom make a different diagnosis. And a lot of times the underlying neuropathy doesn't get diagnosed. And by the way, POTS, more than 50% of POTS was shown to be this kind of neurogenic, small fiber mediated. So I'm going to give you a brief clinical overview and then move into the research. Chronic pain is one of the major symptoms of small fiber because, again, these are our pain neurons. They also mediate itch. That's been underappreciated, but it's a common symptom in many patients. In about 3/4 of patients, the symptoms will develop in the feet first. And this shows you what neurologists call erythromelalgia, but which we were just hearing about from Dr. Rowe, where you have microvascular changes and visible color changes in addition to the pain. The few patients at the bottom on the face may have attack directed at their cell ganglia, the cell bodies in the ganglia, rather than the axons. I don't want to belabor this point, which we've heard about wonderfully from our previous speakers, but I will just bring your attention to two slides that I think speak to the cellular mechanisms of some of what we've spoken about. I don't know if you can appreciate this immunohistochemistry from Alan Pestrong's lab, which actually looks at the innervation of the neurovascular bundles that go to the muscle cells. And what it shows you, the merged images here, show you that in the normal patient whose panels are at the top, there are lots of axons. When we look at the blood vessel in cross-section, the yellow squiggles are the innervation. When we looked at a patient with they look at a patient with small fiber polyneuropathy, you can see that the blood vessel has lost most of its innervation and it's gaping open, as we just heard. And again, we heard already about some of the consequences of this and the fact that in these type of patients that David Systrom is looking at, about 30% of them have skin biopsies diagnostic of small fiber neuropathy. I'd also like to mention the arteriovenous shunts, because that, I think, is a contributor as well. The AV shunts permit the blood to bypass the capillary beds and jump directly from the arterioles to the venules. They're normally closed for obvious reasons. But very nice work from the lab of Frank Rice in Albany, studying patients with fibromyalgia 18 and 14 controls, showed with immunohistochemistry that there's loss of innervation and consequently an gaping open of these arteriovenous shunts, so the blood may be circulating, but it may not be making it directly to the capillary beds. The gut is densely innervated by small fibers, as shown in the immunohistochemistry from my lab at the top. GI symptoms are also common, and worst case scenario, one of them is shown at the bottom. Some of these patients have such severe problems that they become cachectic and malnourished, and in the teenage girls, it's very often attributed to anorexia nervosa. I also won't belabor the point that this has consequences on the brain. So because the symptoms are multiple and kind of nonspecific, we really recommend objective confirmation. And again, it's these skin biopsies that are endorsed by neurologists. If you look on our website, neuropathycommons.org, there's information about how to get them shipped to our lab, how to do them if you're a provider. I'll make the point, though, that not all skin biopsy labs are created equal, and you need to look and see where the lab that's interpreting your biopsy actually is getting their normative data from. And so I'm showing you, and this is the work of largely of Max Klein and many others in our lab, this is more than 400 skin biopsies from normal individuals of all ages. And I show you this to show you that normal young people, here I think this is people under the age of 25 in red, normally have up to 4 times as many of these nerve endings as normal older people. So if you just apply a single diagnostic threshold, you're going to have false positives from the old people, and you're going to have a ton of false negatives from the young people. We get sent skin biopsies all the time interpreted as normal from other labs. And insofar as I know, please correct me if I'm wrong, NGH is the only lab in the world with actual normative data from children. So please think about the lab that's interpreting your biopsies. Beautiful immunohistochemistry can be done. These skin biopsies are very useful for research. I'd like to, and again, I'm not sure how well this comes out, but this shows you staining of different components, and I'd like to particularly draw your attention to the innervation, the dense green innervation of the arteriovenous in blue anastomosis. And again, this is from the lab of my co-author, Maria Nolano, who I consider to be an artist who paints with immunohistochemistry. Maria and I are just publishing a review paper together in JAMA Neurology, so that's something you might want to look for later this year. And again, you can see that these small fibers have many, many different roles in the skin. The panels on the edge are from a healthy 10-year-old boy. The other panels are from a similar age boy with Fabry as the cause of his neuropathy. We completely endorse the use of physiology tests. We do them as well in our lab. The conventional Mayo composite autonomic function testing. AFT has advantages. It's totally non-invasive. It can be repeated. It's used more often as an outcome measure for trials. But unlike the biopsies that can be taken anywhere in the world and mailed to a lab, the patient has to show up to the AFT lab, has to prepare in advance, hold medications, and sometimes the results, as we heard, are not specific. So I think they're complementary. I'm going to turn now to some of our research. Max and I, in 2013, published this paper in the journal Pediatrics, which I think is one of the early papers. It's certainly the first large case series looking at this problem in children's and teens. And this was a group of 41 patients with the onset of chronic widespread pain before age 21. We didn't rigorously screen them for such, but most of them were labeled as, would have been labeled as juvenile fibromyalgia. Many of them would fall into the category of patients we're talking about here. And although pain was the inclusion criteria for this study, almost all of them had other non-pain symptoms. In studying these young people, to look for cause, it was by studying young people that it really emerged to us that here the signal, there was less noise in kids, so the signal came out more clearly. And the signal that came out to us was inflammation and perhaps autoimmunity, both because of personal and family histories, but I think more directly because the vast majority of these patients had standard serologic blood tests that are considered soft signs of inflammation, systemic inflammation. We were able to find objective evidence of small fiber neuropathy in 59% among that young series. And combining this information that a lot of them had neuropathy and that in them perhaps the cause was autoimmune, we were able to show a 80% response rate to immunotherapies in the very small group. I should emphasize we did not give this treatment to everybody, nor would I encourage it to, and it would be a mistake to think that this is a universal treatment for small fiber neuropathy, because it is not. That was a retrospective look back for a more rigorous study. We next focused on fibromyalgia because of the ACR criteria permitted us to identify a homogeneous group for research. These are patients that had both the clinical diagnosis and they met the full rigorous ACR research diagnosis. We studied the 4 pillars of clinical medicine, which are symptoms, signs, pathology, and pathophysiology. All of these outcomes were consistent with small fiber neuropathy, and most notably, 41% among that group versus only 1 patient in the control group who later, actually 3 weeks later, was diagnosed to have MEN2, which is a cancer that's associated with small fiber neuropathy. So highly statistically significant overrepresentation of small fiber neuropathy. We're just getting ready to present at the American Academy of Neurology meetings a follow-up study in teenagers with juvenile fibromyalgia, and we're going to report essentially the same thing. Our paper was very difficult to get published because of the controversy surrounding fibromyalgia and previous studies that needed to be retracted from high-profile journals. But what ended up happening is that virtually every single study published since is all singing the same song, that about 40% of fibromyalgia patients have some type of objective evidence consistent with small fiber neuropathy, and I draw your attention to this review article in Scientific American Mind that discussed this. I have not studied CFS-ME, but I just want to briefly mention our work in Gulf War illness, which suggests evidence that small fiber neuropathy is quite significantly represented not only in fibromyalgia, but in other multi-symptom illnesses. This work, we're very grateful to our funding from the Department of Defense, and this is work we're doing in collaboration with the East Orange VA. I realize this is data from 42 Gulf War vets and 51 screened demographically matched controls, but in fact, this doesn't even include the data from the East Orange VA, so we're probably pushing towards 100. Time to move away from abstracts and publish in full, which we'll be doing later this year. But we're finding the same thing, that about 40% of the Gulf War symptomatic vets have objective evidence. Very interestingly, the results were identical in the non-symptomatic Gulf War vets. So this suggests that small fiber neuropathy is highly prevalent in this group, but that it doesn't go on to cause Gulf War symptoms in all of them. So I think it's part of the picture, but certainly not the whole picture. So moving on to part B is, if you make that diagnosis of small fiber, your immediate next step is to identify the medical cause. We published on this in 2016, evaluating the tests to do. We've created this form. The residents use it as a cheat sheet. It's available for your use on our website. Don't hesitate to use it. Again, diabetes is overall the most common cause of small fiber neuropathy. There are a number of other medical conditions. Most of these patients turn out to be what we call the initially idiopathic. But if you do all the blood tests, you do find a cause in about half of them. Again, these are the 3 tests, 2 that I published and 1 from a study in the Netherlands of 921 patients. And all these studies are highlighting the high prevalence of markers of disimmunity. The reason for this, I believe, is that the small fibers are intimate, to use a word that we know, with the immune system. And the reason is because that's part of their job. There are protective nerve fibers, and to do that, they migrate out of the CNS into the periphery. They have fenestrated capillaries, and they crosstalk with the immune system. That makes them vulnerable to threats, both infectious threats and autoimmune markers that we've heard about, cytokines, inflammatory mediators, paraneoplastic syndromes. So a trickle of cases of what seems to be small fiber restricted autoimmunity was published, some of which are ours. And then I believe that the largest is our 55-case series from 2018, among whom 3/4 did not have the systemic diagnoses. Sjogren's is, without question, the most common, and I'll refer you to our little New England Journal piece from 2018. This is another 2018 publication, retrospective, but first large study on the efficacy of pooled immunoglobulins. The fact that IVIG is helpful in some is additional indirect evidence of B-cell and autoantibody mediation. In this study, we use the results of autonomic function testing as the co-primary outcome to give an objective marker in addition to pain, very important to the patients, so that's why we had those 2 outcomes. Both of them improved statistically significantly. We need more direct evidence than retrospective studies, prospective studies, treatment studies, and that's beginning in our lab and elsewhere. The best study I know of is this passive transfer study from the lab of Yuki in Singapore, where they took serum from patients who had what we call apparently autoimmune small fiber neuropathy. We say apparently because, again, it's really not proven. This is an hypothesis that's being explored. They injected mice with sera from these 3 Chinese patients who they thought had this, from a ton, like 25 or 30 normal controls and patients, I believe, with CIDP. And they showed that the serum from the Chinese patients who they thought had the neuropathy produced behavioral changes in the mice, and then the expected pathology in the dorsal root ganglion and in the spinal cord. We're building metrics in my lab, both the SSS, the Small Fiber Symptom Survey, and we'll soon be publishing the MAGNET, the Mass General Neuropathy Exam Tool. We, like others, other labs, routinely collect serum, DNA, plasma, and these kind of standardized data that Dr. Koroshetz has encouraged. The goal, again, is to be able for people to collaborate around the world and to be able to pool our data in a way that's comparative. For the many excellent basic scientists in the audience, I would encourage you to think about phenotyping your patients with these standardized metrics, which I think will facilitate your basic studies. I'm going to end just by a hand-waving calculation, the best we can do for now, about what the prevalence of small fiber might be. I know of only one published epidemiologic study from the Netherlands that would predict that there may be 4 million cases. But as those relied on only diagnosed and confirmed cases, and it's estimated that 90% are in fact undiagnosed, perhaps 40 million worldwide might be a more accurate figure. But on the other hand, just feeding in the data from the fibromyalgia studies now moves us up towards more like 400 million cases. So we don't have an accurate estimate at this point. We do need a better case definition than the epidemiologic studies can be done. But certainly the data suggests that this is not a rare condition in either adults or children. So I'm going to go back to the stuff that I told you at the beginning. And what I've tried to demonstrate, I hope effectively, is that small fiber polyneuropathy has many symptoms, not just the painful feet that physicians learn about in their training, that precision diagnosis, both a anatomical, pathological, physiologic diagnosis, and then the etiology offers patients a path towards better treatment, and by the way, parenthetically, towards insurance reimbursement for that treatment, which is a very important consideration these days, that skin biopsy is right now the best accepted objective diagnostic tests. Again, please go right to the blood tests, figure out what the cause is in your patients, that this does affect children. We need more pediatricians to come into the dialogue and let their pediatric colleagues know about this, and that in the kids and the teens who don't have diabetes, most of them don't have HIV, don't have chemotherapy, in them, you really have to think very seriously about inflammatory causes. I've not had time to talk about genetic neuropathies, which is another major clinical and research interest. I lectured last year at Radcliffe in a longer format. If you're interested in hearing about the genetic cases, you can find that lecture on YouTube. Again, the data so far from our lab and elsewhere suggests that we're on track to discover the correlate of Guillain-Barré and CIDP, which are autoimmune neuropathies just directed at a different fiber type. The final data are not there, but that's certainly the way things are heading. And again, there's very early evidence. The reason why this discovery, I think, is important for patients is that it kind of gives a bit of a roadmap toward treatment. And again, the estimates from other studies are that about 40% of patients in these research cohorts do have evidence of small fiber neuropathy. So again, we're very grateful to our funders, to our internal collaborators in the lab, and to our external collaborators. I hope very much that this meeting will give me the opportunity to make new collaborations and give me the opportunity to help you advance your work as well. Thanks very much to everybody who stuck it out. Thank you so much.
For questions, Anne-Louise. So, Dr. Oaklander has left us some time for questions.
Yes, my question is, aside from patients with painful feet or widespread pain, I know we're here about CFS and talked about POTS. Are there criteria for which patients should undergo skin biopsy, or do you have some guidelines for other conditions when it's appropriate, what the indication is?
That's an excellent question. And as a clinician, if I know that 40% of a certain symptom is caused by a particular disease, golly, I'd really be thinking about that test when I see patients with that symptom. Now again, that's not to say that everybody with chronic fatigue or fibromyalgia, the data show clearly that they don't have it. But golly, yeah, Very good question. Wish I knew the answer, but very good question.
A very interesting presentation. Thank you. I didn't get to read the slide fast enough, but on the Gulf War slide where you had essentially the same level of positive biopsies in asymptomatic Gulf War vets, there also was a column for healthy volunteer, healthy controls, and it looked like the positive rate in that was around 15%. I couldn't tell exactly. And so is that true, and in which case, what's the prevailing background rate, and how much of what is observed in that particular study might be just a variant?
I don't want to actually get into a detailed discussion of our Gulf War data. I'd like to keep the focus on the topic here, but you're right, that's a high rate. And I think that the reason is because we used a demographically matched group. And when you look at that cohort, older middle-aged men, there's a not significant prevalence of conditions that can cause neuropathy. So yes, you're correct.
Okay.
So this is about a real patient who's too ill to be here today, who's been labeled by your institution as having a functional or somatic disorder when he's been previously diagnosed with autoimmunity and polyneuropathy. How can he get help and get into the correct neurological area in your institution, please? He's being treated like a psychiatric patient right now.
Yeah, I don't have a good answer for you, and I think because all of us in the audience know that this happens routinely. The skin biopsy, although not perfect, there are false positives, false negatives. I don't want to leave you with the mistaken impression that it's perfect, but it's very convincing because it's pathology. And so what I suggest to my own patients is that they really try to get that peripheral neuropathy diagnosis on their chart into their doctor's note and try to minimize some of the red flags. This is, you know, maybe the art of medicine, and maybe not everybody would agree, but you got to get medical care. And I think it's really important not to scare doctors away. And it's understandable that people develop depression, anxiety, deconditioning. I mean, I get it. But it doesn't always help patients to get the medical care they need. And part B, of course, is medical education. So there's something called the Valley of Death that this is in. It takes 17 years, they say, after you publish the papers, for the general physicians to become aware of it. It's really unfortunate. And then the insurance companies are even worse because, you know, they have their own policies about they will and will not pay for, and just because something's published in the literature, yeah, okay. Next question.
Thank you.
I think this will have to be the last question.
Okay, thanks, Olli Polo, Finland. Are you aware of any data how sensitive the peripheral nerve fibers are for hypoxia, for tissue hypoxia?
They're very sensitive because these are the longest cells in the body. The neuronal cell bodies are in the dorsal root ganglia next to your spinal cord. Those axons are going all the way down. They have the highest surface to volume of any cell that I know of in the body. I call them the canaries in the coal mine. And so that's why many neuropathies, including diabetes, and even they're finding, you know, in ALS that there's small fiber degeneration. So they are the most sensitive nerve cell to hypoxia. Thank you very much.
Thank you, Dr. O'Quinn.
So it's my pleasure to invite Tony Komaroff up to the podium to give us a summary of the conference. So it'll be very interesting to hear his input. And following that, we're going to have a panel discussion. So, Dr. Komaroff.
Well, Dr. Whittemore, fellow hangers-on, I'm glad, well, I'd like to first ask you to join me in thanking the organizers and the presenters for a remarkable 2 days. My task is to summarize roughly 30 different presentations and put them in the context of a literature of over 9,000 publications. So since I know you are all a kind and generous group of people, I hope you'll be tolerant of a few stumbles. In the mid-1970s, interest in this illness resurfaced, spurred by research done here at NIH and in Denver and in Atlanta. And at that time, we had an illness that was characterized by only symptoms, pardon me. Can someone help me get back into show mode? Thank you. They had an illness characterized only by symptoms, no consistent objective abnormalities that were noted then. No physical exam abnormalities, no diagnostic tests, no proven treatments, no information on prognosis, no evidence of underlying biological abnormalities, nothing. It was a suspect illness. But that was 30 years ago. Where are we today? I'd say we have come a very long way. Can you help again? We've come a very long way, and we still have a long way to go. What I think has become clear over the last 30 years, and you've heard a lot of it in the last 2 days, is that cases do differ from healthy controls, and in some cases from disease comparison group controls with regards to central and autonomic nervous system, metabolism, particularly energy metabolism, immune phenotype and function, the microbiome, gene structure, gene expression, and some epigenetic differences. The questions going forward are what caused the symptoms of the illness, what caused the abnormalities that I've just referred to in the various systems, what links together these abnormalities in these very different systems, what triggers them, and is there a hypothetical disease model that fits with the abnormalities that have been reported. So my agenda for this talk is to summarize the data presented at this conference, sometimes putting it in the context of the prior literature, regarding these various abnormalities that have been reported, and then to consider several theoretical alternative models that might explain much, if not all, of the data that we've seen. So let's start being as brain-centric as Dr. Koroshetz with the neurologic changes, which involve structural and functional brain imaging changes and autonomic abnormalities. The past literature has found hundreds of studies have demonstrated different kinds of neuroendocrine dysfunction. Many studies have demonstrated cognitive problems. Many autonomic dysfunction, you've heard a lot of that over the last 2 days. MR studies, both anatomic and functional MR, SPECT, PET, EEG, all demonstrating something is going on in the central nervous system. You've heard several people refer to this paper by Nakatomi from several years ago, the first serious evidence, in my view, of brain inflammation in patients with this disorder. Small study, hasn't yet been replicated, but the distinction between cases and controls was nearly perfect. As you can see, there were higher levels of a signal that measures an translocator protein that is a signal for activation of glial cells in the central nervous system. MR spectroscopy of the brain, very recently reported by Jared Younger, was a study of 15 women with ME/CFS and 15 matched healthy controls, and found, as Jared reported, abnormalities in multiple brain regions, particularly the left anterior cingulate, metabolite ratios in 7 regions that correlated with fatigue, and an increased ratio of choline to creatinine and increased lactate being particularly prominent findings. As Jared pointed out, those findings of increased lactate were just the latest. This is a highly replicated result. This is one paper from 5 years ago comparing patients with ME/CFS to patients who were healthy and to patients with generalized anxiety disorder. Very clear and dramatic differences in lactate levels. Peter Rowe, in talking about autonomic things going on in the brain, talked about CBF, cerebral blood flow reductions, being very substantial, and showed these data. And he just showed them again a few moments ago. Even in patients undergoing upright challenge, orthostatic challenge, who had a normal heart rate and blood pressure, there was a clear decrease in cerebral blood flow, both initially and then an increasing decrease towards the end of the tilt challenge. Metabolic changes. We've heard a group of different metabolic changes summarized at the conference. Impaired ATP production, a general hypometabolism, and I would argue, even though we didn't present at the conference, oxidative and nitrositive stress. At least my summary of the early papers on metabolomics in ME/CFS is as follows. Most of the studies have found that levels of most metabolites are lower, as Bob Navio was first to point out, is similar to what happens in the state called dower in the worm, C. elegans, or in hibernation in mammals and some birds. We'll come back to that in a little while. Abnormalities incriminate impairment of cellular energy and oxidative phosphorylation, indicate a possible defect in one particular enzyme, pyruvate dehydrogenase, that has not yet been replicated, to my knowledge, and defects in pathways converting sugars and lipids and amino acids into energy, into ATP. There is some evidence linking these metabolic changes to a state of chronic inflammation or activation of the innate immune system, triggered perhaps by NF-kappa B, which is measurably higher in the patients in studies that have looked at it, which upregulates COX-2 and INOS to generate both oxidative and nitrositive stress, the consequences of which is to damage nucleic acids and lipid membranes, which should be damaging to mitochondria, which should lead to an increase in anaerobic metabolism and increase in lactate. And I would say that the literature is generally consistent with this model. Maureen Hansen at the conference pointed out that we should be looking at the metabolomics not of populations of cells, but of individual cell types. and found quite different results when she looked at CD8 T cells as opposed to CD4 T cells, with different effects on mitochondrial respiration and glycolysis. Nancy Klimas argued that metabolomics data can be merged with drug-gene interaction data to identify potential therapeutic targets in this disease. So beyond simply looking for a metabolomic fingerprint that might be diagnostic of the illness, metabolomic data may also point the way to some successful therapies. I believe this is the data from Uppsala, spinal fluid protein metabolomics, finding clear differences between ME/CFS and matched controls with generally increased levels of markers for neuroinflammation, cell damage, and repair in the people with ME/CFS. Both significant similarities and differences were found when the ME/CFS people were compared to those with multiple sclerosis. There were some apparent similarities and some clear differences. Bhupesh Prusti talked about whether the energy generation mitochondrial abnormalities that data indirectly suggest are present might be caused by chronic viral infection, and mentioned experimental evidence that one particular virus, human herpes virus 6, in one cell line, active infection, not latent, fragments mitochondria and inhibits the ability of mitochondria to fuse and repair, and reduces ATP production, not surprisingly, and also reported that serum from ME/CFS patients fragments mitochondria, and removing that serum resolves the fragmentation. Mechanisms not yet pursued or uncovered, but a striking finding, particularly given Ron Davis and other people's findings, that there are some molecules in serum that cause various aberrant physiology, and we need to figure out what they are. Ron Davis presented this slide. I'm waiting for the paper, which will be published, as I understand it, in PNAS in the coming months, that found one abnormality that clearly distinguishes patients, in this case 20 patients and controls, perfectly distinguishes them from healthy controls. That also obviously is a clue as to some underlying biology that could be causative of the symptoms of the illness, and I'm sure that's going to be pursued. Immunologic changes. I've always been confused about immunology, but everything fell into place when Jose Montoya demonstrated this highly simplified overview of human immunology. Enough said. I'm still confused. But in the immunology of the 20th century, that a long time ago, it was already clearly established. I would argue by the turn of the 20th, 21st century, it was clear that in patients with ME/CFS, there were increased levels of circulating immune complexes, increased levels of immunoglobulin G, decreased levels of certain IgG subsets, increased numbers of CD8 cytotoxic T cells that bared various activation antigen markers, that NK cell function was impaired, and that there were increased blood levels and increased lymphocyte production of pro-inflammatory cytokines. Since that 20th century immunology, 21st century immunology has filled out the picture. Here was a study, the first study from Ian Lipkin's group, finding that blood levels of many cytokines are significantly higher in people with ME/CFS than in healthy controls, but only in the first years of illness, not thereafter. It is as if an initial immune system response to some perceived threat tries hard, several years, and ultimately becomes exhausted. And if anything, the Lipkin group finding was that after 3 years, the levels of many cytokines started to dip a little bit below those in healthy controls, as if the cells making those cytokines had been exhausted by the effort. Levels of many cytokines in spinal fluid also were found to distinguish patients from healthy controls in another study from the Lipkin group. And then finally, in the study that Jose Montoya presented at the conference, levels of many circulating cytokines were found to correlate positively with the severity of symptoms. Important because if you find a biomarker that appears to be abnormal in people, you would like to know whether that's an epiphenomenon or whether that biomarker actually contributes to the suffering, to the symptoms of the illness. And several of these cytokines seem to correlate with symptom severity. Oh, I see. Jose Montoya also pointed out that many of the cytokines that he found to be differentially upregulated in people with ME/CFS are made by mast cells. That's important because, particularly in the last 2 years, there's been a growing body of evidence from studies as well as clinical experience suggesting that some patients with this illness may have a mast cell activation syndrome. That we need to understand that better, but there are both diagnostic tests and treatment implications in establishing that connection. Jose also reported at this meeting some HLA associations. These is HLA genotyping, not the old-fashioned and less reliable and precise way of HLA typing, finding several markers that were associated with the illness itself, at both increased risk and decreased risk of the illness, but also markers that were associated with increased and decreased risk of severe illness. So separate markers correlated with the illness as well as with illness severity. That's new information that may be a clue that needs to be followed up. Durya Unamats pointed out that the CD4 and CD8 T cell subsets are different between patients with this illness and healthy controls, particularly in the older but not younger groups. That's curious, and the reason for it needs to be pursued, but certainly when this phenomenon is looked for, age needs to be controlled for, his data shows. This is Mark Davis's data showing that he finds an increased number of clonal CD8 cells responding in ME/CFS patients compared with controls. What is less clear at this point, and what he's obviously pursuing, is trying to identify the epitopes against which those clonal CD8 cells are targeting, because that could give a clue as to what trigger of the illness is, at least in those patients. Epigenetic studies. The past literature has found differences in people with ME/CFS compared with healthy controls with regards to the DNA methylome, with regards to the expression of microRNAs, and we'll come back to the data at this meeting on that subject. Differences in transcription factor levels, particularly NF-kappa B, and increased HDAC expression, all different kinds of epigenetic controls of gene expression. This is from Moreau's report at this meeting. He has been looking at various microRNAs in people with ME/CFS versus healthy controls, and has found a whole group of microRNAs that are differentially regulated in the illness compared with health. Some of them also correlate closely with the symptoms of the illness. This example, microRNA 155P, correlates with mental fatigue. Moreau also found that when you just let the microRNA data define subgroups independent of any clinical information about those patients, what you see is that the subgroups defined by the microRNA profiles also have characteristic and very different clinical profiles. The symptoms, for instance, in subgroup 1 are very different than the symptoms in subgroup 5. Provocation studies of several types. Why do provocation studies? The rationale is pretty clear. Biomarkers seen in resting people with ME/CFS may or may not have anything to do with causing their symptoms. So if there are challenges that make people's symptoms worse, it would be nice to know if they also make the biomarkers worse, because if they do, it would suggest a connection between the biomarker and the symptoms. And that's the rationale for doing it, as well as that the key symptom of post-exertional malaise has an underlying physiology that needs to be understood, and obviously cognitive and physical challenges are the way to elicit post-exertional malaise. Past studies of exercise testing in particular are numerous, and I would argue quite consistent and well replicated. There are abnormal responses in people with ME/CFS to anaerobic threshold, to heart rate, to VO2 peak, and to peak work. There is also an impact on pain. The pain threshold in people with ME/CFS is different at baseline before exercise, as you can see, the blue being ME/CFS and the orange being healthy. But notice what happens after exercise. The threshold goes up, that is, the pain goes up in the ME/CFS patients, but goes down in healthy. So that's the phenomenon of central sensitization, and it has been reported by many investigators in this illness. Upright challenge also affects cerebral blood flow, as showed a minute ago and as Peter Rowe demonstrated at this conference. This response to orthostatic challenge, as Peter pointed out, has certain pretty consistent findings and some quite inconsistent findings. There is venous pooling, particularly in the blood, in the legs. There is diminished vasoconstriction, which is normally the protection against venous pooling, diminished intravascular volume. But at the end of this process, this pathologic process, people respond quite differently. Some with orthostatic hypotension, others not, some with neurally mediated hypotension, some with POTS, and some without any significant heart rate or blood pressure drops. That variability needs to be pursued with physiologic studies. Betsy Keller described many studies demonstrating chronotropic intolerance, defined as on exertion, an unusually low heart rate, low ventilatory rate, so there's less carbon dioxide being blown off by the body, and a lower blood pressure. And she said that her 2-day studies, exercise challenge studies, found that this was a much more dramatic abnormality on the second day than on the first. Another reason why the 2-day study, in my view, has real value in both understanding the illness and unearthing the underlying abnormalities. This phenomenon is probably a manifestation of autonomic dysfunction. Hard to think what else it might be, but more formal study of that should be done. So putting it all together, the central and autonomic nervous system abnormalities, the metabolic abnormalities, immune system, epigenetic differences, microbiome differences, which we'll come to in a minute, and the provocable abnormalities, the various provocation studies. Are there any models that would explain it all or unite it all? And there may be, and I'm going to talk about several which other speakers at this conference have alluded to. I would say there's 5 models that seem to me most intriguing. One that we didn't talk about at this conference at all is really been raised by Ned Sharpless, who's the head of the NCI here, who in cancer patients has a lot of data suggesting that excessive cellular senescence leads to the generation of fatigue-inducing molecules. I had a conversation with Brian Wallet and Avi Nath that they will probably be looking for these molecules in the studies that are being done in the intramural program here. Sickness, behavior, inflammation is another model. Come back to that. The Dower hibernation torpor model is another model. The cell danger response incomplete healing model is another model. And then the microbiome as a driver of abnormalities that lead to the symptoms of this illness is yet another model. I would argue that at least the last 4 could well be linked with each other and may be different expressions of the same ancient physiological response in animals. And I'll come to why I say that. So the first model is the sickness behavior inflammation model. Jared Younger referred to that this morning. What's that mean? What is sickness behavior? Well, what do you feel like when you get sick, when you get the flu? Everyone has had the flu and everyone has felt sick. One phrase that's often used is, I feel like a sick puppy. We use that phrase because when our pets get sick, we see their behavior, we see the parallels between their behavior and ours, and we feel like a sick puppy. And that's what a sick puppy feels like. And that sick puppy is experiencing the same set of physiologic changes that we experience when we get sick. Sick acutely, the sickness behavior response is a evolutionarily preserved response in virtually all animals in which it's been studied, that when there is illness, it's been studied most in infectious illness, but not exclusively, there is a temporary response to that injury or infection in the animal, and there's a purpose to that response. The purpose is to focus the body's energy stores on fighting the infection or the injury, healing the injury, generating acute inflammation, fever, and the sickness response also has the brain discourage all sorts of behaviors that consume energy so that the energy can be saved. So people are lethargic. They don't move around a lot and spend energy that way. They're socially withdrawn. They're achy, and they don't want to move too much. They're sleepier, and they sleep more. Loss of libido, difficulty thinking, depression, anorexia. These are all manifestations of the acute sickness response. The question raised by many people is whether this acute sickness response, something we are all biologically wired for, is in some people somehow made chronic, unable to turn itself off, and whether that is what's happening in ME/CFS. Here is a model. It starts with the brain, and it postulates that in the brain there is a fatigue nucleus. There is some group of cells that perceive and monitor fatigue. There is evidence that those cells may be in the basal ganglia, illustrated here, or in the prefrontal cortex or in the anterior cingulate. It says that activation of the brain's innate immune system, the microglia, prominently, not exclusively, yields cytokines that trigger the fatigue nucleus to feel the experience of fatigue. And the question is, what activates the brain's innate immune system? Jared Younger listed a group of things earlier today: infection of the brain, directly of the brain, autoantibodies in the brain, toxins that reach the brain. He didn't mention it, but there's also data that the state of obesity, chronic stress, and elevated levels of leptin, whatever causes leptin to rise, all activate the innate immune system of the brain. Also, infection or inflammation elsewhere in the body outside of the brain can signal the innate immune system of the brain to turn on. It's essentially the periphery of the body fighting a battle, the immune system, and saying to the brain, hey, we've got a war on down here, get ready up there to do something. How are those signals from the periphery delivered to the brain? One way, known about for several centuries, is the humeral route of blood that flows through a porous blood-brain barrier and with molecules and cells that reach the brain that normally shouldn't be able to get there. This is not a new concept that the blood-brain barrier can be breached. Cajal first observed and drew it more than a century ago. This is his drawing of cells penetrating the blood-brain barrier. What's more interesting, and only in the last 20 years has become solid, and Jared Younger and Mike Van Elseker referred to it, is that peripheral inflammation also signals the brain, not by blood-borne signals, but by retrograde transmission of signals up the vagus nerve to the brain. So look at the bottom of the figure. My pointer isn't working, but look at the bottom. Infection outside the brain triggers the innate immune response. That generates neuroexcitatory molecules that are picked up by chemoreceptors on vagus nerve ends throughout the body and send signals up the vagus nerve. Glial cells that are enveloping the vagus nerve, as Michael Van Elseker postulated several years ago, themselves can become infected and send those same signals up the vagus nerve, where they arrive in the nucleus tractus solitarius and send signals to the rest of the brain that consummate in what we call sickness behavior, the changes in behavior that manifest as sickness. The potential sites of peripheral inflammation I've basically just summarized. One possibility suggested by Peter Rowe's talk today is that the phenomenon he described of neurodynamic strain might also be sending retrograde signals up the vagus and activating innate immunity in the central nervous system. The Dower hibernation torpor model. Dower in the worm C. elegans is a protective effect state that's temporary, and when the organism is challenged by harsh environmental conditions, that can be temperature, absence of food, whatever, crowding, but when the signal, the distress signal, is received by the worm, it goes into a state where it shuts down most of its energy-requiring reactions to preserve the energy it has to contend with the vital threat that it perceives. In other words, it makes physiologic changes that improve its odds of survival, but badly compromise its functionality. The same thing exists in hibernation in mammals. Food shortage, temperature change, trigger protective responses that help the animals preserve energy through the energy needed to survive through rough times. The thing that I hadn't realized until reading this literature is that the state of hibernation in mammals is not a semi-permanent one. The bears don't fall asleep in December, wake up in late March, and never awaken in between. In fact, those states are quite transient. They wax and wane, and they're signals that cause animals to enter into the states and exit from the states of hibernation. Torpor can even occur in warm temperatures, estivation, in some animals. I make that point because I'm arguing, obviously, that the cyclic depression of function in MECFS has some parallels with the cyclic process of Dower and hibernation and torpor. Both Dower and hibernation are regulated by the same transcription factors, and those same transcription factors also are heavily involved in the stress response, in detoxification of reactive oxygen species, and innate immunity. They both involved increased glycolysis and decreased aerobic respiration. You hear the parallels with MECFS. They may involve alterations in the microbiome. That's been better studied with hibernation than Dower. But there are parallels. Whether those parallels are decisive remains to be determined. The autonomic nervous system, which we've talked about as being a central part of the pathophysiology of MECFS, is also central in Dower and hibernation torpor. It controls entry into and exit from those states. The cell danger response, incomplete healing model that Bob Navio presented. As I understand it, since the earliest forms of life, cells and tissues have developed systems for identifying and then healing injury. And that includes injury signals. One prominent such signal is extracellular ATP. Initiation of the cell danger response is mediated by metabokines and cytokines. The progression of injured tissue through several stages, 3 stages that Navio outlined, CD1 through 3, is controlled by these chemical signals. And when the response gets stuck for reasons that remain obscure and is incomplete, chronic disease then can result. I find that an attractive hypothesis. I think a lot more work is needed in the major chronic diseases to demonstrate that that's the prodrome, but it's an attractive model. And the model can be very complex, but it has molecular components, but it's a simple concept that you go through what is intended to be a healthy cycle, get stuck midway and can't get out of it and are left in a compromised state. I didn't realize there were so many components to your slide, Bob. The microbiome. Just to summarize, why is everyone so excited about the microbiome? Why is the microbiome being linked with so many very different diseases? Is that at all plausible? I was very skeptical, but I think what has happened that has changed a lot of minds is that particularly the advent of rapid nucleic acid sequencing has revealed the microbiome, how diverse it is, how many species, what genes they have. And what it's uncovered is that, as I understand the current literature, that our collective microbiome has more than 100 times as many genes as we do. And it is essentially not just a second human genome, it is an additional endocrine organ, because those microbial genes make molecules that affect human physiology. They make hormones and neurotransmitters. They synthesize molecules of inflammation. They elicit the production of molecules of inflammation from our own cells. They affect the gut's barrier, like the blood-brain barrier. The gut has a barrier that is meant to keep noxious things from getting in from the gut into the bloodstream. But the microbiome of the gut can cause the gut to become leaky and can cause both bacteria and bacterial toxins to enter the bloodstream. This is a study done, I think, by Dane Cook that measured various bacteria in the blood before and after exercise in patients with ME/CFS and in healthy controls. And as you can see, in patients with ME/CFS, there was a spurt of bacteria into the blood with exercise, whereas that was not true in health, suggesting that the gut barrier is leaky. This is a paper from Maureen Hansen in which she measured at rest in patients with ME/CFS LPS, a bacterial toxin, the binding protein of LPS in the bottom right corner, and the soluble receptor for the combination of LPS and its binding protein. All three considerably and very significantly elevated in people with ME/CFS compared with healthy controls. The study from Ian Lipkin's lab, a metagenomic gut microbiome study, identified a relative abundance of several genera and deficiency of several genera, and went beyond that by studying various bacterial metabolic pathways and correlating those pathways to the symptoms in the patients, finding that several pathways positively correlated, just like Jose Montoya's cytokine data and Mark Davis's cytokine data correlated with symptoms. Both Julia O today and Ian Lipkin also pointed to the importance in their studies of the microbiome in ME/CFS of a deficiency in species of bacteria that produce butyrate. Butyrate production is protective against a variety of illnesses, diabetes, obesity being probably the most prominent. And so it raises the question of whether altering the gut microbiome to provide more butyrate-producing bacteria, or even taking butyrate itself as a supplement, might be beneficial in this illness. Can the various models be united? Well, it seems to me that all three models involve are obviously ancient biological mechanisms designed to preserve energy, to prevent or to heal an injury, and cause a necessary and hopefully temporary impairment in function in order to have the energy to heal. The fourth model, the microbiome, is certainly a plausible source of injury and inflammation that could be triggering the other three models into action in human subjects. Do the symptoms of this illness result from activation of these ancient mechanisms? And do they represent a pathological inability to turn them off? I think we just don't know yet, but I think those are questions that people will, I hope, pursue. So in summary, it seems to me that this conference and the scientific literature reveal robust and replicated evidence of underlying organic abnormalities in people with this illness. The abnormalities have considerable overlap with several well-documented models of disease that I've just mentioned, and more needs to be done to solidify and expand our understanding of these abnormalities, their relationship with each other, and what triggers them all, what sets them all in motion. Probably different in different people, but there's got to be a set of triggers that ultimately lead to a final common pathway that I would postulate reaches that fatigue nucleus in the brain that generates the symptom that patients with this illness experience. So in summary, as I look at what has happened in this field over the 35 years that I've been involved in it, and as I reflect on what was presented at this conference, seems to me that an awful lot has been learned about what's going wrong in the body in people with this illness. That hasn't, unfortunately, yet led to diagnostic tests that are accurate enough to use or to proven treatments. But I'm optimistic that with the continued NIH and CDC support and extended support, and with the support of private foundations like the SolveME initiative and the Open Medicine Foundation, that given that support, given the growing number of people who are interested in studying this illness, given the incredible tools that you've seen demonstrated in the last 2 days, virtually none of which were available back in the 1980s and 90s, I think we are going to lick this terrible illness. Thank you.
Okay. Thank you very much, Tony. Pretty amazing, actually, as usual. We're going to move directly to the panel discussion. If we can have the panelists come up to the front.
So what we're going to do is allow each of the folks up here to have just a couple of minutes to make some comments, and then we'll open it up for discussion with the larger group. So Sadie, are you going to start?
I volunteered to start. Hope everyone's doing okay and hanging in there. I know we're getting towards the end of the day. First, I just wanted to thank Joe and Vicky for all their work in putting this conference together. I think we've seen some great science over the past couple of days, and it's exciting to see everyone come together and discuss their work. I think we would all agree that a conference isn't enough, and how do we take all the drive and big thinking and hallway conversations and connections that we've made over the past couple of days and turn that into some progress on this disease. So some things that I've either heard in presentations or that I believe are fundamentally important. First, more open science. I think we heard a lot of presenters talk about that today and yesterday. Increased data sharing, and not just positive findings. Let's share methods. Let's share negative findings. I think those are equally important in advancing the field. Collaboration is key. We've had lots of people talk about working together and how that's really amplified the work that they've been able to do. So how do we do more of it, and are there ways that we can connect researchers and data in a way that makes collaboration easier? Big data. So I come from an oncology background, and I often talk about how breast cancer used to be a single disease, and now it's 50 or 60 or 70 different diseases, and that's really being able to be uncovered through big data and being able to look at subtypes of the disease and see which subtypes are going to respond to different therapies. I think that's critical here. We've seen a couple people talk about their databases, both at Cimarron and at Stanford. At Solve, we are getting ready to launch a global biobank and registry, and we're going to integrate a symptom tracking app that will enable ongoing data capture. So there's been other incredible efforts to increase available data and samples. Many of you know about the London School's repository. We're working with them to see how we can create a single data lake. I truly believe if we can take these disparate sources of information and put them together into a single database that researchers can access easily, it will really enable us to better understand what we're looking at, identify subtypes, and hopefully accelerate progress. And then the last thing I'll say, we had a young researchers conference here on Wednesday for the first time. It was great. I think bringing new researchers into the field is absolutely critical. It's exciting to see the number of new faces that are entering the field. Just speaking anecdotally, our Ramsey program last year, we have more applications than we've ever had previously, and we funded more than we've ever been able to do. And I think that really speaks to the interest that people have in this field, and that they want to come in and try and unpick this difficult problem. So let's encourage that, let's do more of it and keep it up. And one parting remark that I'm sure Joe may not want to hear, but more conferences like this. I think this is great, and it's really energizing and motivating when people come together.
Jose, you want to go next?
I want to also point to the participation of the young investigators on Wednesday. I think this is extremely important to attract young people to the conference. So that was a great idea, Vicky and Joe, to have a day for them to present their work. And I think that it's hard to follow Tony's act. I think no one could have done it better than him. So I was writing something like what could possibly be written in a textbook of medicine in few years, and I hope that it's only in few years. And I thought about this. Not that long ago, ME/CFS was in the dark and was mistakenly viewed as an illness that was not real. It is now established that ME/CFS is a real illness characterized by a chronic, relentless inflammatory process that primarily involves the brain, peripheral nerves, and in various combinations, other organs, resulting in a striking diversity of clinical phenotypes. ME/CFS inflammation may not be obvious clinically and by routine laboratory measures of inflammation. However, ME/CFS inflammation causes life-changing physiologic and metabolic abnormalities and can be worsened by cognitive, emotional, physical exertion, abnormalities in the microbiome, intercurrent illnesses, allergies, mast cell activation, reactivation of latent infections, allergies, toxins, stressors, and other stimuli. ME/CFS can be diagnosed by a device, nano-needle device, where blood cells behave differently entirely in patients, and it was invented at Stanford by Ron Davis. And the last paragraph on that would be, in randomized clinical trials, the following drugs have been found to be effective in ME/CFS. So I think that with conferences like this, paragraphs like this could be written not that long in the future. Thank you.
Are you going to go?
Yes, yes.
Okay. I'll give some impressions that I'd like to share of a couple things that I've thought about since the beginning of the conference. Of course, I'm not going to restate the summary because I think Tony does a masterful job, and it's really appreciated by everybody, and I'm sure by the community, because the summary is available, it will be available in about a week to 10 days, and everybody will be able to see that. And so I'm sure many of you would want those slides. So my thoughts are that, and actually, Ron Davis said it earlier, I think, especially from my position, I think we need to encourage continued sharing of data so that we can eventually do some cross-platform comparisons and cross cohort comparisons as we increase the number of cohorts and people working in this area. I think the systems analysis, we're just at the stage where we could actually do that and we've had some mention here of machine learning and artificial intelligence, but I think we need the data to do that. And it'll be imperfect, but I think we need to continue to work really hard to make that possible. And I think that links with another thing we heard and that rang true to me, and that we need to promote sort of unified concepts that people are seeing over and over, like TGF-beta and TNF-alpha, for example. We saw it several times today, and then some new things that we heard about at this meeting. And I think we need to continue to support, and I'm excited to hear about the new tools, and of course we just heard and saw some amazing imaging to better understand what really are mechanistic differences between people suffering with ME/CFS and controls, because I really think that it's the hints are there. I think we should be able to discriminate from biomarkers. We saw Dr. Davis's paper that we'll all get to read soon. It looks like it looks more and more likely that we're going to be able to do that. Whether we're going to be able to stratify patients appropriately, I think that's why we have to keep looking for biomarkers. And then that will help us understand mechanism, it'll help us understand pathways, and eventually, we certainly hope that we'll eventually be able to use interventions and to measure effective intervention as well as diagnosis, which is obviously needed. With regard to immunology, it's something that I hear at a lot of immunology meetings, and I think it's certainly true here. There's been a lot of studies on peripheral blood cells, PBMCs, and I think that's an obvious place to start, but I think we need to continue to work back to tissues, because I think that it's a different story, as we heard from, again, several talks about it's the highways versus the tissues and the capillaries, and I think many of the same mediators are probably there, but I don't think they're expressed the same, and I think we can be led astray if we're only looking at PBMCs. I know you have to start somewhere. I was struck by the AFM example that Dr. Lipkin showed earlier, because basically using some of the most sophisticated tools we have, he couldn't see evidence for a virus that there's a lot of evidence that that virus is involved based on epidemiology and many other clues. But really, it's probably the timing. It's not, because he'd found evidence for that virus using antibodies in a body fluid, which was fortuitous. But he only I think 2 out of 100 patients, he actually found the virus itself by PCR. So I think that's an important lesson, that it's probably a timing issue. So just because we can't find a virus, maybe we need to continue to think about ways to do that in real time, and maybe we'll have more success. Or maybe that's not the right approach, but I think based on that example, I think we still need to keep looking. And I also am encouraged by the mechanistic data that we saw here, and I saw a lot of it Wednesday. It was it was awe-inspiring, actually, to see the young investigators who are passionate about this field, a larger group than I expected, and I think that bodes well, and we need to continue to support that. And I actually want to commend Vicki, because that really came out that was your idea completely, based on where you saw this field going. I have to commend you for that, because I really didn't participate in that. I was busy with this conference, frankly, and it was super encouraging. So I'll stop there and let others talk.
So in all transparency, it was actually Richard Simpson's idea. He started the Young Investigator Workshop last year, and we just copied what he did here. But I also was so excited on Wednesday by the turnout of the young investigators, the more established, more senior investigators who came, which was really great as well. So like Dr. Koroshetz, I'm pretty brain, nervous system centric, and the immune system also confuses me, Tony. It's going to take me a while to wrap my head around all the data we heard. And the way I'm thinking about it, or the way I think I'm going to have to try to sort through it all, is to take it apart and think about what are the risk factors. So if I'm a person and I'm exposed to a particular trigger, why would I develop ME/CFS and Joe wouldn't? So what is that difference? So what are those underlying risk factors? And then from that, what are the acute responses and the acute things that are happening in the immune system, in the nervous system, autonomic nervous system, that then leads to more chronic phases of the disease? Because I think it's really difficult sitting in a lecture like this when people are presenting data. And so, for example, like the microbiome, I don't necessarily think that it's something the microbiome is exposed to that causes ME/CFS, but it may be a downstream impact on the microbiome that then creates longer-term chronic effects of the disease. I'm just throwing that. I don't know if that's true or not, but I'm throwing that out there. So I think we need to kind of pull things apart a little bit and say, what are the things that are put people at risk, are early reactions to an exposure or a trigger, and what are longer-term, more chronic effects. And that'll also help us, I think, to sort out the subtypes of people that, after an acute response, may have certain manifestations of the disease or not. And so I think that will really help us, and I think what I'm leading to is saying that I think what we really need are certainly better diagnosis, so people are diagnosed earlier and get in to see clinicians sooner, so that we can do really careful longitudinal studies. Because ideally what we would want to develop is something that intervenes and prevents at that earliest phase, so that we're preventing all of this additional downstream stuff. But I think it's been an amazing 3 days for me with the Young Investigator Workshop and all of you here. I hope that we can do this again soon, because I think it's what's really needed in this community, is to bring everybody together and hear what's going on and share ideas. So I'll just say thank you to all of you, and thanks to everyone who was here, and special thanks to Joe for all the work he put into organizing the conference. So I'll pass it on to Maureen.
Thanks. So I would like to echo my thanks to Vicki and Joe and Andrew. And many of you don't know how much time Joe spent on the phone with the organizing committee to try to figure out the program without enough slots for everyone we would have loved to have speak. And I know that Andrew, who's not up here, did an awful lot of logistical organizing for this meeting. So I really appreciate that. I outlined my remarks before Tony gave his talk, and he'll recognize some similarities. We had some similar things to say. So we're very lucky to have these three program officers. They advise the upper administration on research needs and opportunities, and I really believe that the funding for the MECFS research centers wouldn't have existed without their understanding of the importance of this neglected disease. And I suspect if it had been up to them, there would have been more than 3 research centers that could have been funded. This is not a syndrome. This is a disease. 35 years ago, the incidence of MECFS greatly increased. And although it wasn't investigated by the CDC, there are physicians here today that will definitely tell you that the upsurge in cases in the mid-'80s was very real. As Betsy Keller mentioned yesterday, it was already known 30 years ago that people with MECFS had abnormal exercise physiology, and reduced natural killer cell activity was already discovered at that time. So we knew the disease was biological, even though certain people, especially in the UK, did not know that. But other discoveries were not made because of lack of funding. As reported in Hillary Johnson's book, Osler's Web, only 2 proposals were funded during the first 4 years after NIH started accepting research proposals to study MECFS. Many potential researchers left the field for better funded areas. 30 years later, if we want to keep these young investigators that I'm very glad Vicki encouraged here to present their work, if we want to keep them in the field, we're going to have funds provided so that they can make research careers studying this disease. So what's different now, 35 years after the explosion of this disease? Well, for the first time, there are NIH program officers who understand how devastating MECFS is. There's a trans-NIH working group that's taking input from the community, and I encourage everyone to do that. Their deadline isn't now until May 1st. There are individuals and patient organizations making a substantial amount of funding available that has allowed a number of important pilot studies that we heard about at this meeting, and also 3 privately funded collaborative research centers. There are now 3 NIH-funded collaborative research centers as well, and the first data are beginning to emerge from them. There's a very expensive and labor-intensive intramural study at NIH that will be able to obtain a wealth of data never before available and that really couldn't be done anywhere else. At this meeting, we've seen analyses of the level of cytokines that were not even known to exist 30 years ago. It's now possible to sequence whole genomes, microbiomes, and transcriptomes. It's possible to examine immunological history, pathogen exposure with peptide chips. The functioning of the brain can be examined through sophisticated imaging. And we have computers and bioinformaticists to help with big data analysis. Now, these are just a few of the arsenal of techniques that weren't even imagined 30 years ago. And we also have the internet to allow rapid communication of new information and to allow patients to keep in communication with each other and with the world. But like 30 years ago, what we don't have is adequate funding. We still don't have adequate respect for the seriousness of this illness. We have repeatedly heard that there aren't enough researchers interested in this, interested in studying this illness. So we've heard that there aren't enough MECFS researchers, so that NIH can't fund more research. But the reason there aren't more researchers is the disease is extremely underfunded. This is a classic catch-22 that NIH can overcome only by investing more funds despite the false narrative that no one wants to work on this disease. At the time HIV was discovered, there was not a huge number of researchers working on human retroviruses. Then the floodgates of funds opened and people moved into the field. How many retroviral researchers are there now? Some who fled MECFS research were able to find a home in the abundant support of AIDS research. Dr. Peter Rowe suggested at this meeting that we need something analogous to the Ryan White Initiative. That's an initiative that resulted in not only survival, but a much better quality of life for people living with HIV. Maybe the MECFS initiative should be the Lyndonville Initiative. Many children who became ill there in an outbreak in 1985 are still ill today, suffering for 35 years, along with the many adults who became ill across the country and in the world at the same time. It needs to be recognized that people with MECFS lose their lives even though they don't die. Instead, to quote Mark Lovelace, the head of AIDS and MECFS clinic at Oregon Health Sciences University, people with CFS feel effectively the same as an AIDS patient feels 2 months before death. The only difference is that the symptoms can go on for never-ending decades. Dr. Collins suggested that we continue to hold him accountable. So I challenge him to give the MECFS community the hope he mentioned by funding research that will lead to the breakthrough in MECFS that occurred in AIDS when HIV was discovered. I would like Jose's medical textbook to become true as soon as possible. I believe this breakthrough is coming, but it will come sooner, fueled by additional NIH funds. MECFS patients deserve the same hope that patients with other diseases have been given through the resources that NIH can provide. I agree with the quote that Dr. Collins gave us: no action, no hope. I'd like to see that action. Thank you.
So we'll open it up now for any comments from the floor. Terry, go ahead, please.
Hi, I'm Terry Wilder. Just a couple of comments. I don't want us to hope that we're going to have another conference. We need to start planning it now. So, Joe, I would like to have a follow-up phone call with the planning committee in the next week to 10 days. We need to discuss what went well and what we can do better next time. I think we can start planning it now. We'll figure out the logistics as we plan. I mean, as you know, it took forever to plan this anyway, so it's not like it's going to happen tomorrow. It's what my team does when we put on a conference. We get together, talk about what went well and what we could do better, and start planning the next one. We deserve to have another one of these conferences. Francis Collins also talked about that we're a family. Well, families don't just hope for things. They start working on things to help the rest of the family members, and we certainly deserve this. The second thing that I would like to mention is that, yeah, we have to have researchers, and grateful for the young investigators, but the medical providers are the ones who push the patients into the research. And so ME Action, through a family foundation, sponsored 3 people to come. One was an MD PhD who's going to be a pediatrician. Another person is an MD in medical school, and then we have a practicing MD that came here. So the whole goal was to make sure that medical providers are going to be continually coming into this field, so that we have people to take care of us and that you guys have subjects to study. So I am grateful for this day. I am absolutely wiped out. So it was really tough for those of us who have ME to be here, but it's certainly important. At the center of everything is people with ME. I think the other thing that I've thought about a lot is that going forward, when we have conferences like this, for co-chairs, at least one person needs to be a person with ME.
Thank you, Terry. Yeah, please go ahead.
Thank you, Joe and Vicki, for a really wonderful conference. It's been very enlightening. And Dr. Komaroff, tremendous summary there, and actually helped synthesize some of the things that I've been thinking, and what I would like to, as I was not trained like Dr. Korshoff as a neurologist, I was trained as an integrative physiologist, an almost extinct type of physician these days. And the linkage that I see is we have inflammation in the brain. We know that the HPA axis is low. Blood volume is low because of that. As a result, as you've seen the data here, low cardiac filling pressures, making people susceptible to orthostatic intolerance, and that the brain stem is also affected, including the VLM and other areas of vascular control in the CNS, and autonomic nervous system. And the other key point that you brought out was, back when I was a beginning investigator, we studied exertional heat illness and the role of lipopolysaccharide in leaky gut as a precipitant of exertional heat illness. And so there is a link between poor perfusion of the gut and the causes of severe illness. And so there is a unifying integrative physiology hypothesis, because Dr. Systrom and Dr. Bateman and Dr. Rowe have all showed that when you improve circulatory control with better cardiac filling and better blood pressure response, most of this syndrome gets better. I don't think it all gets better, but I think it mostly gets better. And so the real question that I've said before, and I'm saying it again now, is we need a study that restores circulation back to normal. And then what is remaining? Because that really will tell you what's the epiphenomenon of the physiologic response, and what is really underlying pathophysiology that isn't explained. But there, again, I said it yesterday, this is circulatory control problem until proven otherwise, and that's where we need to be putting in our energies, in my opinion.
Thank you. Lily? Oh.
Did anyone want to answer that?
Anyone want to respond? Good comments. Yeah.
So I wanted to get back to Terry's point about recruiting younger, earlier stage physicians and clinicians to this. So I'm already involved in a number of medical education efforts. But when I think about how I got into my field pre-CFS, which was geriatric medicine, it was because I was introduced to it in medical school. It was mandated during my residency to have a rotation in it. And then I had a bunch of mentors who gradually led my way to fellowship and helped support me and told me where to apply and how to get to where I wanted to go. And I think about, well, how does that happen for a PhD student if they've never even heard of this, or they don't have anyone at their institution? And so I was thinking, when you have the trans NIH group and you have people from different institutes, would it be possible for them to talk about ME/CFS as they go about to their different universities or to the conferences, to just mention it even? Because I have a feeling that most of those PhD programs have never even heard of ME/CFS.
Yeah, thank you, Lily. That's a good suggestion. Thanks. Yes.
Hi, I've been sick for 29 years, and I run a support group on Facebook, and a lot of people know me. I'm the blue butterfly. And I've followed the science, of course, since 1989. And over the years, I've watched what we've learned, and I've looked at my symptoms to kind of connect, this thing is probably causing this, or this thing is probably causing this, looking for that downstream effect. When you guys are writing your research papers, I think we could speed up that 17 years thing if you would include what the downstream symptoms could be from this finding. So when we walk into our doctor's office and we say, I have all these symptoms, could you look for this, like the red blood cell deformation? Could you look for this because maybe that's explaining my symptoms? We need a better way for us to talk to our doctors, and we don't really have that document, official document, that gives us deep, in-depth, that we can speak with our doctors. We've got the ICC, we've got the CCC, we've got, the SEID, but we need something that shows them science. They don't want conjecture. So if we could just ask that when you're doing those research papers anytime, and I've seen that you've done it in some, if you'd just be a little bit more specific about the more odd symptoms we have, like paralysis and the can't regulate body temperature, those kind of really odd things that we get that, really? Look, that'd be great.
You want to respond, Jose? Sadie, go ahead, yeah.
So I think it's a really good point. I'm fairly new to this field, and when reading the literature, oftentimes the context for me was missing. So there was disparate elements of scientific findings which were very compelling, but what did it really mean for my symptoms? And so I think it's something definitely for me, we're consciously trying to do that when we summarize research findings. Yeah. We're summarizing it. What are the key points, but then what does it mean? So I think it's a great point and something that we could all learn from.
And I'm very sorry you have been sick for so long.
Thank you.
It's always hard to hear, that. And yes, so you are absolutely right. There was that paper with the correlation with symptoms and cytokines, so that is one example, but we need more. And one thing that Mary Dymock is doing is putting together those clinicians who have been in the field for decades, and so that the whole thing can be distilled into a document that, because that is considered evidence when you have what is called by consensus, the sort of like the highest level of evidence, that is like the holy grail of evidence, is when you have a randomized, double-blind, placebo-controlled trial with enough numbers of patients there, then that nobody argues with that. But consensus opinions also matter and weight. So I think that Mary's effort will result in publications that we hope that patients can take to their physicians and say yes. And the other piece that I will urge you to use is Tony Komarov's editorial in the Annals of Internal Medicine, where he titled ME/CFS is a real illness. I use it when other colleagues who I want to invite to collaborate with me ask me for, send me something introductory, and I know that they might be in the camp of skeptics of the disease. So I use his editorial to say it's a real disease in a journal that has lots of prestige. But yes, we need to do more, and sorry we haven't done more.
Yeah, just to clarify is that we're looking for, a lot of us have found a doctor that says, yeah, you're really sick. But they're trying to make that connection between, okay, which of these symptoms can I work on? We're trying to help the doctors help us. And so I'm looking for that, not just the overall, yes, you're sick, but, okay, now you're sick, now what do we do? It's the what do we do part I'm looking for in the research papers that, if they're finding, we've seen with the red blood cells that you can do some things to help those be better. So let's help the doctors understand that we're dealing with these symptoms because of this downstream of that. So thank you.
Hi, thanks for everybody who was involved in organizing this. It was a great conference. I have a scientific background and training, and so I really appreciate the value of the science that was coming out today. I'm also the mother of a son with ME, so what I really care about is getting diagnostics, treatment, and accessible quality clinical care as quickly as possible. So it's probably not a question, it's more of a plea to do two things, to ask you to do two things. The first is to come up with a concrete plan to do in parallel studies with understanding the basic disease pathology to find the first diagnostics and treatments as quickly as possible, because that will help patients improve their quality of life. Some of those are already being used effectively by clinicians, and they need to be researched. So can we do that in parallel with the work that's being done on the basic pathophysiology? The second request is, I know it is not your remit, but we are facing a crisis in clinical care with less than 20 doctors in the country and many of them nearing retirement. NIH is in a leadership position to be able to make an impact on that in collaboration with the other agencies at HHS. And I'd like to see a concrete plan and also sponsorship, funding support to help these clinicians pull together the information that they have, share it with other clinicians in the field, so we can start to address not only the clinical care crisis we face, but also have clinicians who can bring patients to research. Thank you.
Thank you, Mary. Do you want to comment?
Hi, I'm Hillary Johnson. I wanted to talk about money, following up on a few of the things Maureen Hansen said. I think people at NIH may not understand the depth of despair CFS patients have, ME patients have. It's a sense that the government has turned their back on them, that they might as well be dead. There have been a period of 10, 15 years when NIH was spending less than $5 million a year on this disease. It's a common statistic, but the point is it's almost no money. That's the price of a nice house in Los Angeles. This is patients feel this is an emergency, a public health emergency, a crisis. You now know how severe this disease is, how devastating it is, but it does not have anywhere remotely near parity with other diseases of severity, similar severity. In fact, this is the most severe disease, and it's probably transmissible as well. But just final statement is that AIDS, for instance, receives $28 billion a year in federal money. About 8 million of that goes to research, and the rest goes to social services. This is from CDC, NIH, and the Veterans Administration combined. Okay, 28 million in 1 year. That's domestic spending on AIDS. And I'm sorry, I haven't totaled up in my head what the centers are getting, but it's, a few million every year. You've got to do better. This is just, and lastly, I think I've mentioned this before to Vicki Whittemore. I really would like to impress on you how meaningful it might be if the NIH could issue an apology to patients who have been sick for decades, given the paucity of research, the paucity of money, et cetera. And that's it. That's what I was going to say. Thank you.
Thank you, Hillary. Carol?
Yeah, first I do want to thank Vicki and Joe and the NIH for putting on this conference. It truly has been so meaningful. I really sort of want to address my comments to the audience as well, though. If as best as I can, when I tally up the dollars that are available for expenditure on this disease, both in the research arena and in advocacy and changing the public narrative and understanding about this disease, I believe that the funding that handles all of that among the private organizations is still higher than the expenditures from the NIH on this disease. So when I look at the extraordinary work being done at the Open Medicine Foundation, the Bateman Horn Clinic, and our organization, the Solve ME/CFS Initiative, I know these people. I know that these are highly intelligent, highly committed, highly ethical individuals who do everything on a shoestring. So my plea here, and we're doing research, I think you saw the names of those organizations up there frequently today, and we do more. It's research plus in the case of Bateman Horn medical education, in our case, working toward a Ryan White Act for this disease with advocacy and more. So my plea is this. I do believe there will come a time when the NIH will step up. It is a large bureaucracy that has its own ways, and I think we've come to understand its ways, and eventually dollars will be there. But in the meantime, the gap is being filled on the backs of patients and their families. I believe all three of the organizations I've described I know we are completely funded by patients and their families. So I would invite all of you. I don't know whether you want to give to OMF or Bateman Horn or the Solve ME/CFS Initiative, but talk to your friends, talk to your neighbors, give to one of us, give to all three of us. But until the NIH gets to the point where they step up to the responsibilities of our federal government for patients and their loved ones, I think it's important to emphasize that burden is currently being carried by patients and their families. So everyone here has an interest, and I just urge you to give. Thank you.
Thank you, Carol. Yes.
So I really appreciate these big data approaches and also having this information being made available to scientists. One thing that I think might be valuable, and I'd be interested to hear what you think about this, is to have some drug treatments tried and also responses matched to things like DNA information, proteomics. So the big data approaches will tell you things that are correlative, but you don't know whether they're adaptive or potentially causative, whereas drug responses and things that make things worse, symptoms worse as well as better, might be informative in terms of, you know, some of the causative mechanisms.
Yeah, certainly. I hear what you're saying. I think that it's one of the things we're looking at to see how we could potentially implement some trials, clinical studies. So all of these ideas and suggestions will go back to the Trans NIH Working Group to see how we can really move some of these suggestions forward. So thank you.
And may I just ask, so I come from the mitochondrial field, and Steve Zullo at NIH kind of started a listserv that goes out to about 1,000 mitochondrial researchers worldwide, where people can write in questions, occasionally mitochondrial disease patients, but a lot of scientists discuss things. And I was wondering whether there's anything like that for ME/CFS that will help people learn more about it or exchange ideas.
We don't currently have anything like that, but it's something that we've talked about implementing through, we're funding the 3 collaborative research centers as well as a data coordinating center. It's something we've talked about implementing through the data coordinating center. So that's something I think would be a great idea, to provide that forum for ongoing scientific discussion. That's a great suggestion.
I think it's a great idea, and it's consistent with the sort of the open data model and taking input. There is a listserv, but it's more about
pushing
providing everybody with
information.
And you know, if you combine the number of people who attended this meeting and online, it's over 1,000 people who were interested in this today. So that's an example, and all those people were certainly on a listserv, or at least from one of the organizations that was already mentioned. And I guess since I'll have the mic, I'll just say that was it was a pleasure to work with the advocacy and patient organizations to help develop the program for this. I think it made things richer, and I've been involved in this field as a program official for 4+ years, and I think we'll do a better job moving forward as we cooperate with our private partners, and I'm really gratified that we had so much support for this meeting and what we're trying to do in a larger sense, sort of outlined by what Carol said earlier.
I'd like to make a comment about the combined issue of we're losing our physicians to retirement and the issue of clinical trials. Many of these very experienced physicians believe that it's time for clinical trials, and they have some ideas for them. And I certainly hope that that is something that can go forward. Even though we don't know the cause of the disease, there are some things that help the symptoms, and I think it is time to do clinical trials for those possibilities.
I think, as everybody knows, that all those types of studies have to be subject to peer review. But I think that as we increase the amount of mechanistic information that we know, that we have more of a rationale than ever. So we do accept ideas about clinical trials all the time. The hurdles are high because the costs are high. It's a high bar because it's a lot of resources. It's taxpayer resources. So, but I think I'm optimistic, as Tony mentioned earlier, that the more tools that we have, and we heard about a lot of them here today, to characterize and better understand what we're looking at and how to measure response, I think I see that. It's never going to be as fast as it should be and as we'd like it to be. But we do have mechanisms to accept clinical trials that don't require, a special RFA, for example. So I would encourage people to submit those ideas. Talk to your program officials about them.
Yeah, and I would add to that. I mean, yeah, we don't have the money right now for clinical trials, but let's sketch them out. What would a clinical trial look like? And develop a protocol. There's things that we can do, kind of optimistic that we'll get the funding for. I come from a pharmaceutical biotech clinical development background, and oftentimes, we'll design 4 or 5 different clinical trials, and only one of them will get funded. So we shouldn't let the lack of funding stop us from thinking about what trials might look like.
And I think it will be important to distinguish the things that appears to work and touch the periphery of the disease, which will be important to try because that would be could bring significant benefit to the patients. But I think that what goes into the clinical trials really needs to be fed by the advancing the science, because ultimately what one wants to do is to really go to the core of the disease. So we want that day that a drug treatment starts, and then the patient is clearly improved days later and weeks later and months later. And not sometimes like what we do that it takes a long time for a patient to improve or they don't improve. So we want, it has to be a parallel process, yes. But I think that we have enough now data to try in randomized settings compounds that could bring significant benefit to subsets of patients. But we cannot abandon that dream and pursue for what will go to the core, the central core of the illness.
Great. Thank you. Huge thanks to everyone involved. I'll keep it brief. The network analysis that was used for the 17 cytokines in Dr. Montoya's study, along with, I believe, also Mark Davis and Jared Younger on that paper, and I forgot the name of the computational biologist, but could that method be extended to shed light on data across multiple studies? So thinking slightly smaller scale, all the immunological studies, so interactions between the MAIT cells that Dr. Anutma has been studying and the NK cell findings, and there was some dendritic cell findings. So in short, can that network analysis be extended to incorporate multiple studies?
Yes, by the way, the name of the our statistical director, heavy computational guy, he's like a genius, is Tyson Holmes. So I have to publicly recognize his name. Without him, we would have not been able to do anything of what we have done. So it's him. Yes, and we have actually CyTOF that I think that some people are familiar with, where you look at the immune system as a whole. So you look at immune subset cells for like 36 subtypes of immune cells, and we plan to correlate that with others, but also to openly, with anyone who wants to do the cross-assay, the assay crosstalk, we are open to do that as well. So it's not just cytokines, but it's looking at many other aspects of the immune system and integrate them in one big analysis and one big thing that hopefully will see the whole picture. Thank you.
So one of the things we're also working with the Data Coordinating Center on is something we call MapME, so that would allow data sets to be put into the system such that they can be compared and looked across different studies from different cohorts. So more on that coming soon. Thanks, Matt. We have about 5 more minutes unless people are willing to stay longer, but please go ahead.
Okay, thank you. My name is Art Mirren. I'm an applied mathematician from California. I have a 30-year-old daughter who's been afflicted with this disease since she was 15 years old. A couple of years ago, I, along with Mary Dimmick and Lenny Jason, performed an analysis of the disease burden for ME/CFS measured in disability-adjusted life years as used by the WHO, and we published those results. Now, if one then performs a statistical analysis on the data, the burden and funding data provided by NIH, that analysis shows that the funding for ME/CFS should be at $203 million a year. And we all know it's down around 14 or 15, thereabouts. So there have been improvements, and it's really great to have seen those improvements. But using this norm, we're still way down there. In fact, the data shows that this disease is the most underfunded in NIH's portfolio relative the disease burden. And this is now 4 years after the National Academy of Medicine report. So really, a lot more needs to be done here. And thank you for listening to me.
Agreed. Thank you. Daria?
So I also like to thank Vicki and Joe for this really wonderful meeting. I personally learned a lot. So I just want to emphasize on the point of precision / personalized medicine, which I feel that is something that's like a holy grail of the whole of medicine. I mean, all diseases should be personalized eventually. And I feel that ME/CFS is very unique in the sense that it could be at the leading edge of development of precision medicine, because you can see that there's an incredible diverse group of scientists and physicians here. I've learned fields that I wasn't even aware of, from brain to immune system to metabolism. And this is exactly what we need, an integrative type of science medicine to develop the precision personalized medicine. And I think that what we'll learn from ME/CFS is going to help many other chronic conditions and really make them more personalized and precise. So this actually, again, emphasizes the importance of studying this disease. And the second unique thing that I have to say, in all the years that I've studied many human conditions as a human immunologist, this is the first time that I've learned so much from the patients. This is extraordinarily important, and we really appreciate all your feedback, all your personal symptoms. I get messages from Twitter, great ideas, by the way, I have to say, some of which we start to work on. So please continue that, and as scientists, I greatly appreciate that. Thank you.
Thank you, Daria.
Vic, if you don't mind, I want to echo Daria's comments on the patients. My journey in ME/CFS began with a patient because my basic training is in infectious diseases. And since then, it's listening to the patients that really a lot of the things that we have done have come to fruition. Cannot agree with you anymore.
Courtney?
Hi. So I'm Courtney Miller here with Cimarron Research. And on behalf of my husband, Robert, who's been ill for 30 years, and what I want to point to two things, actually. One is that the success of this last 3 days demonstrates, it's the evidence to me, I hope it's the evidence to NIH and everybody in the room and the scientific community, that there is, that this money that has been recently invested and increased is well spent, that there is serious science, it is in progress, and that we have a lot more to do. So there is a lot of data that's been generated. I know the data centers and the research centers are going to generate that much more, and the intramural study will add to what the CDC has already done, and we need to unlock all of this data. We need to make it relevant to treatments. And so my second comment is about clinical trials, treatment trials, and we do need them, and we need them now, and they ought to run concurrently with the rest of this research, because we have a lot to learn from people who've responded to certain treatments already and people who don't, and it is going to help generate those research paths that will ultimately tell us what the cause is, how to mitigate it, how to prevent it ultimately. But we're we're far away from that point. And from a practical standpoint, there are treatments that are being used, and they are providing some benefit, some relief, and some not. And it is all about the funding to study those in the most rigorous way. And so I'll add to the pleas that have been made. We've got to run these concurrently with the research centers and the research, the data centers. And I do want to thank Dr. Whittemore and Dr. Korschetz and everybody who put their time and effort into producing these last 3 days, which are really different than they have been in the past. And we need them annually. Thank you.
Thank you, Courtney. Yeah.
Yeah, hi, I'm Marga Jankalo. I'm a pediatrician from Chicago. I'm also the mother of a 26-year-old who has ME/CFS. And through my journey with my daughter, living in Chicago, which is a big city, should have lots of doctors, found it very difficult to find providers. And in talking to all of the, the centers out there, you call, you want to make an appointment, at least a year and a half to get in anywhere. And so I've decided myself that I would like to start seeing more patients, doing more, but still feel very uncertain because this is a complex community with complex needs. And I guess my question is for all the people that really do specialize at these centers, are they willing to work with physicians if we send questions, if we do things in order to try and have more physicians take on patients so that we can at least, give many of these patients some kind of care in the interim? I did actually spend a few days with Dr. Bateman, and that was great, and learned a lot from her. But, as you see more patients, nobody's the same, and these are complex patients. These are not simple, straightforward patients, many of them.
Someone want to comment, Jose?
Yes, I think that is there are few hours in the day.
Yeah, I understand that.
And then we need to sleep. But so one of the things that at least I decided was, should I go and try to convince colleagues that this is a real disease and trying to show them what we do, or should we try to help facilitate to advance the science? And it's always a difficult task. And I decided that if I was able to put together a team at Stanford that will help to provide a better understanding, deeper understanding of the illness, hopefully find ways to diagnostics and treatments, that would be more effective to convince others. Certainly at Stanford would have not worked. Just saying, take my word, I have seen patients, they have a real illness, that would have not worked. So you have to choose sometimes, do I talk by helping bring in the science, getting the science from other groups, and then that be the one that does the talk versus just word of mouth. So it's not an easy task, but it's something that needs to be addressed. And I think that organizations like Solve.me and other organizations and Mary Dymock's effort is trying to bring education also to our colleagues as we learn.
I just think a lot of physicians are just scared off by the complexity of it. It's just, they don't know where to start, and so they're just kind of frightened by the complexity of many of the patients. And so they just will go to a specialist, go to one, except that the waits are so long.
And you are absolutely correct, and that's part of the issue. For example, what the IOM did, that is now called the National Academy of Medicine, they really simplified the way to approach and arrive to the diagnosis with those 5 questions that they have, from the fatigue, the unrefreshing sleep, PEM, cognitive, and orthostatic intolerance. Really, I have personally tried that, and I arrived to the diagnosis within 20 minutes, when before it would have taken us hours. And then you go and flavor the case and color the case. But I think that a lot of things are needed. Maybe Vicky and Joe, if you could also touch the right agencies to bring significant resources to education, medical school level, residency, fellowship, and colleagues in practice.
We recognize that the whole clinician workforce issue and helping clinicians like yourself, is something that needs to happen. So I think right now, NIH has a working group of our council at NINDS that's going to be providing recommendations on workforce, and I think this will be one of the issues that we need to address.
I mean, just simple things like these are the basic guidelines about what are the labs that we would recommend for this population, these types of things. I mean, when I was doing for my daughter, I literally went to the literature and sort of searched everything.
To pull it out, right.
To pull it out, to figure it out.
Yeah.
And hopefully you've major way to Cindy Bateman at some point during this conference. I know Cindy and the Bateman Horn Center are doing a ton of efforts creating a hub and spoke model, right? So where you can take centralized areas of knowledge and push it out in that kind of a model from an educational diagnosis help. So hopefully your paths have crossed, and if not, I recommend you. Okay.
Okay, we need to wrap up, and so I'd like to thank everyone so much for being here at the conference for 3 days, sharing your stories, sharing your lives with us, and sharing your expertise, and I'll let Joe have the last word.
I just want to echo that and thank everyone for your input and your patience and your staying power, staying here late on multiple days, and for our support to make this happen from the audiovisual side. Thank you very much. And I'll adjourn the conference. Thank you.